give his welcome address and start the session.
Good morning, all. This is the day 2 of the conference, 45th Annual Vidarbha Ophthalmic Society Conference. So I welcome you all, and I thank you all the panelists and the scientific chairman, Dr. Viral Shah, for this session. And thank you all the participants. I wish them all the best. Go to Dr. Viral.
Thank you, sir. Thank you. Now I request our chairpersons to please take over the. Hello.
Hello.
Yeah.
Hello.
Yeah. Hello, sir. I request now the chairpersons, Dr. Karandikar sir, Dr. Bhave madam, to please start the session.
Good morning, everybody. All of you can hear me, I suppose.
Yes. Yes, sir.
No, yeah. Good morning, everybody. This is the second day, as Dr. Viral has said. Thank you, Viral, and thank you, President Upadhyay. To conduct this session, the illuminaries with me are Dr. Shubhangi Bhave as the chairperson. Moderator is Ashutosh Bhoyer. Convener is Abhijit Vaidya, but he is not present because he has got some family commitments. So his place will be taken by Rajesh Ugade, who is also coordinator of this program. The first speaker is Bhagyashree Deshmukh from Amravati. She will be talking to us on posterior corneal astigmatism hiding a plain sight. She is the opening batsman for today's session. Whenever we talk of cornea in Vidarbha, it is always Bhagyashree's name which come forward. I have attended her class in skill transfer program in one of the conferences. Excellent teacher, excellent messages she gave. I call upon with this Dr. Bhagyashree Deshmukh to talk on posterior corneal astigmatism. And after her talk, Dr. Shubhangi Bhave will pass the expert comments and the panelists will be free to ask any questions. With this, Bhagyashree Deshmukh, please take it.
Sir, the timing, I asked the admin to take a note of the timing. The technical person to note the timing.
Dr. Rajesh Ugle, I think Dr. Rajesh is there. He can help us with the timing. Dr.
Okay.
Rajesh?
So everyone sticks to the time of 8 minutes.
Yeah, we will have some, we have, madam, got a request from Dr. Jagdish Rana, sir. He will exceed it by a couple of minutes. So within 10 minutes, he will be brief.
No problem.
Thank you.
Bhagyashree, please.
Yeah, can I start? Thank you. A very good morning to everyone. First of all, I would really like to thank the office bearer and the organizing committee of Vidarbha Ophthalmic Society. Coming to my talk, posterior corneal astigmatism hiding in plain sight. I hope everybody can hear me.
Yes.
Have you noticed that often there is a significant difference in spectacle refraction and the keratometry of a patient, both in magnitude of astigmatism and its axis? Looking at this patient, for instance, the spectacle correction is -2 sphere and -1.5 cylinder. The corneal astigmatism is 2 diopters. So they are often different. Previously, this was attributed solely to the crystalline lens. But with furthering knowledge, we now place emphasis on posterior corneal astigmatism, or PCA as it's known. So why is PCA focused only in last decade or so? Firstly, a majority of refraction happens at the anterior corneal surface. There's a large difference in refractive index pair of air and anterior corneal surface. Hence, the anterior corneal surface has power of around 40 to 45 diopters. And there is a negligible difference between the refractive index of posterior corneal surface and aqueous. Hence, the posterior cornea has a mean dioptric power of -6.25. This led earlier models of eye and IOL power formulae totally neglect the PCA. Secondly, measuring the PCA was not possible. The easy commercial availability of machines like Pentacam and Cirrus has made this as easy as just pressing a button. And thirdly, prior to the advent of toric IOLs, there was no need for surgeons to be so precise in calculation of total corneal astigmatism. And now we are slowly realizing more and more that the posterior corneal surface also contributes to the corneal optics less significantly than the anterior surface, but not negligibly. For the past few years have increased our understanding by a great leap. The first researcher like Ho et al. Had first deduced that PCA had a negative effect on the total corneal power, and they quantified it. On an average, PCA reduced the total corneal astigmatism by 13%. Subsequent groups like Koch et al. Have done a lot of initial work on PCA. They provided us that the posterior cornea is steeper along the vertical meridian, creating an against the rule effect. The anatomic correlation, why this happened, was provided by Eno et al., the last group. This group said that the cornea is thicker along the vertical meridian, so the posterior surface also becomes steeper along the vertical meridian. And this is a very important concept to understand. The posterior cornea is steeper vertically. So you can see in first image that these dark colors indicate steeper axis, but because it is a concave surface, it is a minus lens. It deducts from the total corneal power. So its effect on the total power is that of against the rule. So it is actually with the rule, but it exerts its effect against the rule on the anterior cornea. So this principle has much importance, especially in the context of toric IOL calculation and post-refractive surgery IOL calculation. In the routine course of events, we measure only anterior corneal surface. Suppose there is a patient with anterior with rule astigmatism, and now we know that the posterior cornea has against the rule, so it reduces the anterior with rule. In other words, the total astigmatic power of this cornea will be less than what is indicated by your keratometry measurements of anterior corneal surface. We'll have to use a toric IOL of less toricity and with rule corneas. Conversely, if there is a patient with anterior surface has against the rule, and we know that the posterior surface also has against the rule, it adds to the anterior against the rule. In other words, total astigmatism power of this cornea will be more than what is indicated by keratometry. Whatever K value you get, the posterior corneal value will have to be added to it. Therefore, you will have to use a toric IOL of more toricity against the rule. The simple mnemonic, which we can remember by withdraw from with rule and add to the against the rule. Now, most of us were using regression formulae to predict the PCA in a toric IOL calculation. Most popular being Barrett toric calculator. But nowadays, we have so many machines made available by technology to actually measure the PCA. It gave birth to a new debate, which out of two would give better outcome, predicted PCA or measured PCA. The co-measurement group says measurement is always better than prediction. And the co-prediction group says that measurement is not consistent or fine-tuned yet. Yet slowly, we are moving towards measured PCA with machines like Pentacam XL and IOL Master 700K measuring total corneal power and giving IOL power in a single button press. If you have any of the other machines, you can measure the PCA and enter values in these calculators, and these calculators give you the IOL power, the total IOL power. Recently, even the Barrett toric calculator has added the option of measured PCA. Other very important calculation where PCA is necessary is post-refractive IOL calculation, which is a topic in itself. But I will just briefly summarize why we can't rely on anterior corneal surface alone in this group. Because standard keratometry measures only anterior corneal curvature. The posterior curvature is extrapolated based on the normal anterior to posterior curvature ratio. And this extrapolation is no longer valid after LASIK. LASIK procedure modifies only anterior curvature and leaves the posterior curvature unchanged. thereby altering the normal anterior-posterior curvature ratio. Hence, it becomes necessary to measure anterior and posterior corneal curvature separately and thereby calculate the net corneal power in this patient. Thank you very much for patient hearing.
Thanks, Bhagyashree, for a nice talk. We all now know that the contribution of posterior corneal astigmatism is significant in certain cases, like it underestimates with the rule astigmatism, overestimate the against the rule astigmatism, and can cause a problem where nowadays the cataract surgery is considered as a refractive surgery, especially when we are using toric IOLs, which are quite expensive, and we are promising the patients having a good distant vision. So very well, you very well brought out your points in the talk. I just ask you one thing, which is the instrument which you feel is a preferred one for measuring the posterior corneal astigmatism?
As I just mentioned in my talk, there are almost 5 to 6 machines which give you PCA value. I have Pentacam personally, and I have been using it since last 5 years. It gives very good results. But recently, when I talked to Zeiss people, the IOL Master 700, the advantage of this machine over other machines is that it measures PCA in every patient, and it gives the IOL power immediately with considering PCA. In other machines, we have to PCA and then enter those in online calculator, and then we get the IOL power.
Okay. I request one of the expert or anyone from the experts to make a comment on this particular talk. And also one more comment, do we need to do an topography in each and every case of toric IOL? So,
if you have the machine of topography, you might as well perform topography in all the patients. But particularly what I feel, if the readings are not consistent, your keratometry value in lens star and your on your autoref, if those are not consistent in magnitude or even in axis, I think we should think of 2 things to perform topography, or look for the anterior corneal surface if it has dryness or some other surface issues.
Okay.
In those patients, I think topography is necessary.
Okay. Experts, any comment from the experts who all have joined?
Should we go ahead?
Yeah, I think we should go ahead, sir.
Dr. Nangia sir has joined. Dr. Harsh Mamidwar is there. Dr. Sima Deshmukh madam.
Anyone wants to make a comment on this from the panelist?
Can I ask a question now?
Yeah, Manoj Jawhar sir.
Manoj, please.
Bhagyashree, can you tell me how much difference it makes for an anterior, means if we are not having a instrument to measure the PCA, how much difference it makes with without calculating PCA and calculation of the IOL power for anterior segments?
Yes, sir. Actually, that is the debate. Actually, you do not need to measure PCA in all the machines, and you do not have a fancy machine. The direct toric calculator uses the predicted PCA, and it takes into account for your calculation even if you don't have a machine which measures PCA. And of course, if you don't take into consideration the PCA at all, by prediction or by measurements, it gives you a lot of difference, as I just mentioned in my presentation, that in against the rule it undercorrects and in the rule it overcorrects. So yes, you have to take into consideration in these 2 fields at least, in toric IOLs and post LASIK.
In case of toric, it is okay, But if we are putting a simple spherical lens,
No,
and we have got a powers in 0.5 of difference of lenses.
no, sir. If you are not using toric or doing post-LASIK calculation, then I think without PCA you can
Yeah,
manage
we
well.
don't need, we need
Yes,
only
you can manage well without
yes,
PCA.
certain situations.
So lenses are available at a step of 0.5 diameters always.
Yeah, we'll have to stop the discussion, Manoj, here because we
can take up at the end, madam. We can take up at the end. When we
yeah, we can take up at the end if the time permits.
There
Yes.
is-
With this, thank you, Bhagyashri. We pass on to the next thing, that is IOL power calculation in various situations. Very nice to have this particular talk after the first talk of posterior corneal astigmatism, importance of posterior corneal astigmatism. See, life is not all that easy for us. There is no one formula which will suit all and in all the situations. And that's why Dr. Bevare, a versatile surgeon from Amravati, will deal with the intricacies of power calculation. It is a difficult topic indeed, but he will make it simple for us. With Dr. Bhuyar will be moderating this particular talk initially, and then the panelists, as we decided, will have their comments. With this, I call upon Praveen to deliver his talk. Praveen, please.
Thank
Dr.
you,
Karandikar,
sir.
sir. Yeah, Praveen sir.
Yeah,
before-
I'm in the
Yeah, Praveen sir.
all in Akola. Yeah.
Yes. Praveen sir, just a second. Before you start, sir, we have got our MMC observer, Dr. Sunil Mulchandani has joined us. So I welcome him also to this session. Welcome, Dr. Sunil Mulchandani, MMC observer. Sir, please go ahead. We have listening.
Yeah. Thank you, Dr. Karandikar, sir. And very good morning to everyone. Actually, we are at Akola and we are just waiting for a live to be started. There is some internet problem here, but I hope it will be solved soon. I'm going to share my screen. And before beginning my lecture, I would like to congratulate Dr. Nitin for giving me the Dr. Viral for giving me the opportunity, and Dr. Nitin for arranging it so beautifully. But unfortunately, because of the corona, there are not many delegates here. Can you see my slide?
Yes, sir, visible.
Is my slide
Yeah, yeah.
visible?
Yeah.
Okay. So today I'm going to speak on IOL power calculation in different situations. I don't have any financial disclosure to make. And I will be covering the 3 or 4 situations because of the lack of time. The first situation in high axial myope. So whenever you are using a 3rd generation formula, when you have an axial length more than 25 millimeter, you can get a hypermetropic surprise. So how you can deal with this? Either you can target some amount of myopia or adjust the lens constant as recommended by Dr. Hegis, or use a new generation formula like a Barrett 2 or Hill RBF. Or you can, if you still want to use a 3rd generation formula, then you need to adjust your axial length according to the formula which has been advised by the Wong and Koch. And you put this adjusted axial length in your 3rd generation formula, and then you calculate your IOL power. Or if at all you are using the new generation formula like a Barrett or the Olsen C or Hill RBF, you need not to do any adjustment. So remember, in high axial myope, you will get a hypermetropic surprise with your regular 3rd generation formulas. The second scenario is the eyes which has been underwent prior refractive surgery. Now here there are 2 situations, unique situation. You cannot calculate your IOL power properly, and second thing is your IOL calculation formula doesn't work in a good way, particularly a 3rd generation formula. So there are basically 3 types of error. One is keratometry index error, radius error, and formula error. So our keratometry measures the radius of curvature from the anterior surface of the cornea, and then it converts into the diopteric power with the help of index of refraction. So to calculate that, it needs to have a proper or a normal average relationship between the anterior and posterior curvature. Now, if the patient has underwent a prior refractive surgery, this relationship is disturbed. In LASIK and PRK, your anterior surface is flattened and posterior curvature is maintained. Previously, it is thought that in RK, the both curvature flattened equally. But later it is found that the posterior curvature flattens more than the anterior curvature. So the index error applies here too. Second is the radius error. Whenever you are using a routine machines like a manual keratometer or a autokeratometer, it measures the paracentral points. And with the help of these paracentral points, it extrapolates the data of the central cornea. And because after LASIK surgery or PRK or any refractive surgery, your cornea is flattened too much or steepened too much in the center, you have this radius error. And a formula error when you're using a formula like a SRKT, which consider a keratometry to predict the post ACD. And if your cornea is flat after surgery, the formula predicts that your ACD will be less, and it will give you the low IOL power and can cause a hypermetropic surprise. So here you need to use a formula like a myopic Higgs L or Holiday 2 in Holiday 2 consultant software. Now, if you go into the literature, there are more than 20 methods and formulas which are available to calculate the intraocular power after LASIK or PRK. And sheer number of availability of this formula suggests that the no formula is a perfect formula. So there are so many methods, but no clear answer. So the prudent way is to counsel your patients properly before going for the cataract surgery in these patients. My choice of method to calculate in these eyes is a ASCRS calculator, which is available online. And it is very easy way to calculate your IOL power in these eyes. Whatever available data you have with you, you put that data on the software and it will calculate all necessary formulas. So if you have a data before the surgery, it will take into consideration that formula, and it will give you the average IOL power, a minimum and maximum, and you can go accordingly. The prudent way is to have some amount of target myopia in this patient because you are expecting some amount of hypermetropic surprise. The third situation is a silicon filled eyes. Now, what happens in silicon filled eyes is your velocity of light or a sound is decreased in the silicon oil. Now, if the viscosity of silicon oil is more, then your velocity will reduce further. Now, if you're using ultrasound, then you need to use a conversion factor of 0.7 or adjust the ultrasonic speed. And if you're using an optical biometer like IOL Master, then you use a silicon filled mode to use a axial length. And another thing is it alters the optics of the eye because of the high viscosity. And if you're putting a biconvex lens, the anterior surface of the silicon oil will act as a minus lens and can cause a hypermetropic surprise up to high as a 6 diopter. Now, if you want to put a lens in these eyes and your posterior segment surgeon says that he's going to keep a silicon oil for a longer period of time, you have to consider that. And if you want to at all have a choice, then use a plano-convex lens where more power is incorporated anteriorly rather than the posteriorly. If your more power is incorporated posteriorly, you have a more hypermetropic surprise. So use a convexo plano lens to minimize the effect of silicon oil. And if you are at all using a biconvex lens, then add 6 diopter to calculated power if it has to work emetropic with silicon oil inside the eye. And when you use a silicon, you do a silicon oil removal, then expect a 2 to 5 diopter of induced myopia. And the another unique situation is a posterior staphyloma. It is very uncommon when you have axial length less than 26 millimeter. But 70% of eyes which have a 33 millimeter and more axial length can have a staphyloma. And the some amount of staphyloma will be always there if there is a pathological myopia. And in these particular patients, you have to be very careful while measuring the axial length, and you have to measure the refractive axial length and not anatomic axial length. So here the ultrasound may get a erroneous axial length and you can have a lot of surprise. So thank you much. And these are the 4 senior I can cover in the 8-minute talk. Thank you so very much.
Good.
Good, very good.
Yes, Dr. Bhuyar, please.
Yes, congratulations, Praveen. Very nicely covered most of the topic. But as far as the refractive error cataract surgery is concerned, there are various errors, as you mentioned. So there are various machines to calculate the corneal power as well as ACD and axial length, and with very meticulous planning of IOL power and very good surgery, most of the time you may land up in a residual refractive error. So you must warn your patient about the postoperative circumstances and the postoperative result and the treatment. In that case, the patient may be happy. In the second case of silicone oil also, you find the measurement in axial length very difficult. It may give a erroneous error of around 8 millimeter. So you have to change the IOL power accordingly and explain the patient in that way. And the third case is of staphyloma. In that case, you may combine your axial length measurement with A scan with B scan machine, where you can have a axial length from the posterior capsule to the posterior segment, and thereby calculating the axial length properly. And the most important is the choice of the IOL. Probably you should not use the multifocal diffractive and refractive lenses in these cases. You must go for a negative spherical lens so that patient's vision is proper. Thank you very much, Praveen.
Sir, Dr. Praveen sir is in hall, so I would request Dr. Hussain sir to give the memento to the Dr. Praveen Vevare sir.
Real, not virtual. No? Thank you. Thank you, Doctor. Now we pass on to the next topic, that is Capsulorhexis, tips and tricks by Dr. Nilesh Jain. He has been trained at Arvind and he has got now huge experience. He will be talking to us how to decide the precision in the size of the rhexis, as well as exact centering of it. When pupil is small, how to go ahead with it. Then how to make the rhexis bigger if it is initially becoming smaller. How to control it. How it is going out when it is going out of control. And in different situations like intumescent or hypermature cataract. Dr. Ugae will be passing on his suggestions after his particular talk. Nilesh Jain, please go ahead.
Thank you, sir. I'll share my
Screen. Yeah, now we can see.
1 minute, sir. Okay. Right. Now share screen. अभी इधर 3 मिनट कर लूँगा ना. So now you're seeing my screen.
Yeah, we can.
Okay. Good morning, everybody. I'm Dr. Nilesh Jain, and I would like to express my sincere gratitude to Chairman of Scientific Committee and Team VOS for giving me this opportunity. I would be talking about the CCC in the coming 8 minutes as it plays a vital role in the visual outcome of a cataract surgery. I would be giving out surgical tips, so let's begin. Let's recall the basic anatomy of the lens. Overall diameter of the lens is about 9 mm, and there are zonules attached to its surface up to 7 mm, or in some cases up to 6 to 6.5 mm also. Hence, we only get 5.5 to 6 mm of effective space for our axis. Now, this is an important thing to note. Considering the physics part of this topic, lens is a convex structure. Due to this convexity, the anterior portion experiences immense amount of pressure which is exerted by the vitreous elastic fibers of the zonules and the lens itself. We may encounter such condition in cases of intumescent cataract, small eyes, and pediatric cataracts. Now moving from the anterior to the equatorial part of the lens, Increasing convexity causes more outward pressure. Again, a tip to remember, because it is important to counteract this pressure by various means that I will be mentioning ahead to get a successful CCC. 5 to 5.5 millimeter is an ideal size of rhexis. As we know, the diameter of IOL is 6 mm. The remaining 0.5 to 1 mm of CCC margin will cover the optical edge, preventing decentration of IOL and giving a good vision, especially in cases of multifocal IOLs. These are the instruments used for CCC. Femtosecond laser patient interface is used for laser-assisted anterior capsulotomy. MICS or microforceps is used for CCC through side port incision. As it grabs the capsular flap, the movement becomes easy. Utrata forceps are bulkier, so they are used through main incision, resulting in continuous shallowing of anterior chamber, so frequent refilling is needed. Cystitome is the most cost-effective and is used routinely. Out of this, I would be explaining about the cystitome in detail. To start with the steps, make two self-sealing 0.8 mm side port for entry of instrument. Again here, important tip to remember is never allow your instrument to press the posterior lip so that the anterior chamber will never get shallow. Staining of anterior capsule by trypan blue improves contrast. It provides good visualization, reduces elasticity and increases the stiffness of the capsule. Other tip is that contact time should not exceed more than 30 seconds. Ideal choice of OVD is high specific gravity, high molecular weight molecule, for example, chondroitin sulfate and sodium hyaluronate. These OVDs balances the interlenticular and posterior vitreous pressure, mostly preferred in intumescent cataract, in extending rhexis tear and pediatric cataract. As shown in the above image, first put the dispersive OVD to coat the endothelium and then insert the cohesive OVD underneath to press the anterior capsule and the vitreous. This technique is known as soft cell technique. In routine practice, we use low molecular weight OVD, which is 2% HPMC, due to its cost effectiveness. But while performing the CCC, if we encounter more upthrust or extension of rhexis, then we tend to put excessive HPMC inside the anterior chamber, which stretches the globe and compresses the vitreous, which in turn behaves like a spring and puts rebound pressure, resulting in extension of the further tear. So the tip here is not to fill the anterior chamber excessively with HPMC. To ensure centration of CCC, pierce into the anterior capsule near the center of the limbus or near the Purkinje image. Cystitome can be used by 2-bend technique for side port introduction and 3-bend technique for main incision is advised to prevent leakage from the anterior chamber. Considering 2-bend technique, first bend near the tip and make the second bend near the hub. Important tip here is to bend the tip of cystitome exactly 45 degrees so that you have a constant observation of tip and flap, especially in subincisional area. After puncturing in the center, make a radial tear till 1/3 of a distance between the center and the limbus, which is approximated to 2 mm, and raise this flap. After raising the flap, forwarding will be done by shearing or tearing method. In shearing, pulling the flap tangentially exert less pressure over the zonules, which is useful in weak zonules and in redundant capsules. In tearing method, pulling the flap centripetally exerts more pressure over zonules. So please note that shearing method is better and tearing should be avoided in weak zonules. On the contrary, in pediatric cataract, where everything is elastic, we need a tearing force to forward the flap. While forwarding the flap, always hold on the peripheral part, considering the center point of rhexis as a pivot and the peripheral part as long of lever, which will ensure less force but more torque. During the advancement of flap, imagine an isosceles triangle to be made up of pivot, long arm and the peripheral edge of flap. Hold in center of this triangle, which keeps on changing with every movement of CCC, ensuring the smoothness in the procedure. Holding away from the tear edge leads to uncontrolled flap advancement that should be avoided. So I have explained all the fundamental steps of making an ideal CCC using a cystitome until now. Now I'll show you how to do CCC in white cataract. Here we are using a combination of cystitome with microforceps. Yeah. Now coming to intermittent cataract. As we all know, intermittent cataract is being a challenging case. Points to remember here is use a high molecular weight OVD, after which make a cruciate incision with the help of cystitome over the anterior lens capsule. Then use a 27 gauge hydrodissection cannula, aspirate the liquid cortex from both the sides, followed by peripheral tapping of the capsule to clear the pockets of liquid cortex, and then continue with the routine procedure of the CCC. In pediatric cataract, eyeball is small, sclera is elastic, lens is very much convex, and zonules are strong and elastic. So almost everything is unfavorable. So use 1.8% sodium hyaluronate and make chamber steady by counter pressure, and do puncture in the anterior capsule by cystitome and forward it by microforceps by tearing method, so that you achieve desired size of rhexis. Otherwise, by shearing, it will lead to unwanted bigger size of rhexis or may land up in extension up to the zonules. Now, I will show you the red flags and its rescue. Here, in this video, you will see there is a complication of rhexis like extension of tear up to zonules, and how surgeon faces difficulty in managing it.
I think you'll have to wind up, Nilesh.
Yes, ma'am. This is my last slide, ma'am.
Okay.
Here the mistake by surgeon is he has not used the high molecular weight OVD, and he has not used the microforceps initially. He has not decompressed the liquefied cortex from the pocket, and he attempted a large axis. And at the end, when he is in complication, he has not tried the quick pull maneuver. That is all from my side. Hope you find this presentation helpful. Thank you so much.
Thank you. Dr. Ugare. Dr. Ugare,
Sir,
would you like to say something?
yes, sir.
Please.
Nicely covered topic, sir. Just I want to ask Nilesh, sir, do you suggest any special precaution during topical anesthesia while doing CCC?
A bit loudly, Rajesh. Please speak a bit loudly.
Sir, in special situation like during topical anesthesia and in zonular weakness cases.
In topical anesthesia, when we are doing this CCC, first thing is important is to tell the patient to fix it properly. Because of the light also, patient is not able to follow it properly. So that's why tell the illumination should be less, and let the patient should be comfortable. And after that, you can do put the high viscosity OVD if patient is not cooperative. Otherwise, you can do the procedure in a routine way.
Or I will suggest one thing, even in the topical anesthesia, with the iris repositor, you can fix the eyeball and then go ahead with the rhexis, because in the intumescent cataract, it is little bit difficult to do when the patient is moving the eye, because sometimes there is rise of pressure, and because of that, there is extension of the capsule. So you have to fix the eye with the repositor, and with the high viscosity, you can go ahead with the rhexis.
Yeah.
Any other comments by the experts?
Hello, good morning, Nilesh.
Yeah.
Yeah, just a little bit comment or suggestion. In intumescent cataract or hypermature, would you like to enter the anterior capsule with bevel down 26 number needle and to aspirate a little bit?
Yes, that is
so
what.
that the rhexis,
See,
so that the rhexis is under control.
There is a special technique. We have to follow the 4 steps. We have to use the high molecular weight OVD, and after that, with the help of cystitome, you have to make a cruciate incision. The thing is that if you have a single tear, the vectoral force will act over it and resulting in the extension of the tear. So that's why you need a multiple tear. So that's why you do cruciate incision, and after that you have to put the cannula inside and to aspirate it. Instead of the same cystitome, you can go with the help of 27 gauge cannula and you aspirate.
Okay.
I think
Thank you.
we can go ahead with the next speaker. Okay. The next, can you hear me?
Yes, sir.
Next topic is innovative patented double tooth Phaco chopper. And to talk on this, Dr. Jagdish Rana is there. It gives me an immense pleasure to introduce to you all Dr. Jagdish Rana. He hails from Ahmedabad and he covers almost all areas of Ahmedabad like Isanpur, Maninagar, and also visits Raman Laser Center. He is director of Netralaya Super Speciality Eye Hospital, Ahmedabad, and also holds managerial post of Secretary of Ahmedabad Ophthalmic Society. He spreaded his wings beyond Ahmedabad to all over Gujarat, and he is now Vice President of Gujarat Ophthalmic Society. His lookout is different. He takes keen interest in socials also, birthday celebration of each member of the Ahmedabad Ophthalmic Society. He also organizes cricket for the members. In all this, he has never forgotten his interest for ophthalmology and his passion continues. He has come out with his innovation, which we will now witness in his lecture. We have heard of choppers from Akaoshi and also from Ajay Devgan. Now, Dr. Rana has spread his wings all over the world and he is coming out with his chopper with the help of Japanese ophthalmologist and he has now become international figure. With this brief, I request Dr. Jagdish Rana to take over and Dr. Ugade will be passing his comments after his particular lecture. Dr. Rana, please.
Yes, thank you very much, sir, for the kind words for introducing me, Dr. Sriram Karandika, sir. Thank you so much.
Thank you. Please go ahead.
So, very good morning, friends. I am thankful to Dr. Rajesh Joshi and Dr. Vail Shah and the committee members of VOS for inviting me and allowing me to present my topic on my patented double tooth Phaco chopper. It was patented in 2013 and there is a video-based presentation. Let me start with my topic. So this is a double tooth Phaco chopper beneficial in segmentation of all type of cataracts. So these are the salient features of my double tooth Phaco chopper. Two blunt tooth at the tip and the curve at the base of the tooth, which is mentioned or shown in a figure. It helps to state the pupil. It's a unique feature. So the curve where the handle starts helps to hold the eyeball in case of a nasty movement of the eyeball under topical anesthesia. And the gap between the two tooth is 1 millimeter. So it can be easily passed through a side port incision. So this is the mechanism of action of my double tooth Phaco chopper. So blunt two tooth at the tip and the wider surface area of contact with the cataract. And the cataract material gets trapped between the two tooth, so giving a controlled chopping. So the wider surface area and the brittle control helps in chopping hard-edged cataract, acts as a lens manipulator in soft cataract, and acts as a lens rotator to rotate the nucleus and nucleus species. So nature works on the same concepts. All hunting animals have two sharp teeth to get the hold of their prey. So this small funny video highlighting at the hotel what happens when it's a single tooth chopper or the fork is used, leading to a disaster. With the double tooth fork, we are able to cut and eat the pieces of food with a double tooth fork. So friend, it's not a chopper, it's a combo. So it's chopper in hard cataract, lens manipulator in soft cataract, it's a lens rotator to allow to rotate the nucleus and nucleus species. It also helps to set the pupil in case of a semi-dilated pupil and to see behind the iris when the pupil is not dilated or semi-dilated. And it's also to fixate the eyeball when there are nasty movement of the eyeball. So it's actually the eyeball fixator. So this is my little separation technique. So there is a no vertical chop like this or a no horizontal chop like this. First there is just a little separation. The other steps of little separation technique. We have to hold the nucleus with enough vacuum. No lifting on nucleus. We can say chopping in situ. You have to do the little separation near the probe, and it is done in a pupil area, so we can say it's a safe zone chopping. Mostly done within a CCC. There are a few videos of segmentation in different type of cataract. This is hypermature cataract. So I am doing holding the nucleus with a probe with enough vacuum and just doing a little separation, no vertical or horizontal chopping. So again in a brown cataract, again holding with enough vacuum and doing little separation near the probe. So it is very much effective when the little separation is done near the probe, or you can say when the two teeth are in a line with a Phaco tip. So this is the main trick how to use it. Two Phaco tooth should be in line with a Phaco probe. So again in a soft cataract, I am able to divide the nucleus and again able to rotate it also. So again in a soft cataract, there are no chances of cut through like in a single tooth Phaco chopper. Because of double tooth, cataract material gets trapped between the two teeth, and we are able to do the chopping very easily and very effectively. Again doing a multiple pieces and by this double tooth Phaco chopper, as well as easily rotating the nucleus. Again in a subluxated cataract, after fixating the capsular bag, I'm able to rotate the nucleus also, as well as I'm doing some amount of chopping also, though it's a soft cataract. Again in a semi-dilated cataract with a hard cataract, I'm able to rotate it, able to chop it by little separation technique. Again, it is done in a line of a Phaco probe. So holding it with enough vacuum and doing a little separation. Again, in a pseudo explosion where the jonular integrity is compromised, I am able to rotate it, separate it, doing a chopping also. So it's done so easily, so effectively, without any stress over the journals. Because of a double tooth, we are able to do a controlled chopping. Again in a cataract with a posterior synechiae after a posterior synechotomy and applying a pupillary expander. Again I am able to do the chopping of the nucleus, rotating it, doing multiple pieces. So friends, the new chopping technique have advantages. Main is the less stress over the nodules because the no extra force is required to break the nucleus. So it is useful especially in a subluxated cataract, pseudo-explosion cataract, and in a case of jonular weakness. And so in a horizontal and vertical job, axial, there is more axial stress over the journals in the axis of a chopping. Whereas in case of lateral separation, it is stress is widely spread and distributed over the many journals in the axis of a lateral separation. So this picture mimics the stress over the journals in horizontal as well as vertical chopping. And this is how the stress is distributed over the many journals. So chopping is done so easily as if the already separated pieces are lying side by side. So it's a safe, fast and easy surgery. And the most important, there is a no learning curve. So these are the pictures when I started using this Phaco chopper in 2012 and 13. Premium lenses are implanted after successful Phaco surgery. And now from 2012, 13 to 2019 and 20, now using in a all type of premium lenses, almost in all 100% cases I am using in all types of cataract, I am using this double tooth Phaco chopper. This is about what expert says is Dr. Ronaldo from Singapore. What he says is it's easy to use, easy to chop when the two chopping tips are in line with the primary groove or the Phaco tip. And again, our international faculty from India, Dr. Suhas Aldipukar, he is also using my double tooth Phaco chopper in all his OT tables. And this is my friend from Japan, Dr. Toshihiko Ota. So he is also using in all types of cataract, and he has slightly modified this Phaco chopper, and he has named this chopper as a Rana Ota chopper, and he has presented about this chopper in all international conferences, and he's also using this chopper in his all types of cataract surgeries. And so friends, so after experts says this is a book of publication, it's published in a ophthalmic surgical instrument by Dr. Rajesh Sinha and Dr. Jeevan Tityal. So friends, a successful Phaco surgery in all types of cataract leads to a smiling and a happy doctor, and a happy doctor gives a more successful result to the society. So friends, stay ahead. Thank you. Thank you.
Thank you so much. Yes, Dr. Ugare. Dr. Ugare. Dr. Ugare, please. Okay. Any of the yes.
Congratulations, sir. A very nice presentation, and it is very informative. But my question is, any difficulty you came across when you are performing the subluxated or especially brown type of cataract? Because in brown cataract, the fibers are leathery, and even you use this type of chopper, any difficulty while doing the case?
In a subluxated cataract, we have to fixate the capsular bag, and then it's a routine surgery. So it's no problem. As far as the brown leathery cataract is concerned, I have shown the two videos. Though it is difficult, but it is far easier than the single tooth chopper, because we have to hold the cataract pieces or the cataract by enough vacuum, and then we are doing the chopping. So this is your Phaco probe. You have to put the chopper like in a line with Phaco probe. This is the probe. So when they are in line, you can easily separate the pieces, because you are piercing the cataract in the direction of cortical fibers. So in between the cortical fibers, you are putting two tooth and holding with a probe. So you can far easily do the chopping in case of brown leathery cataract also.
Hello.
Okay. And
Sir,
any complication? Any complication, because it is size is little bit bigger than the routine chopper. So any complication you came across till this date?
No, I would not gone through any complication because of the chopper. It can be because of technique, but not because of chopper, because the chopper is rather decreasing our complication and making the surgery safe and easy, rather fast also.
Right.
Hello.
I
Sir.
want to ask one thing.
Sir, one thing.
Yes, please.
Jagdish sir,
Yes, sir.
it's a world-class, excellent innovation. Just, I have one question.
Yes, sir.
Since it is a two ends are there, if you have any, in any case, any nucleus piece tap in between these two forks, any type, you experience such incidents during surgery?
No, sir, it's a 1 millimeter gap only.
So
1 millimeter gap.
gets struck into that fork. So
No, so it's not possible. It's never happened because it's a 1 millimeter gap only. No, you can see how 1 millimeter you can pass it easily through the side port. So there is no question. And never have gone through like this complication.
So one more thing, I wanted to know whether it's a pointed tip or it's a blunt tip, because in the photo it appears little blunt.
It's a blunt, sir. It's a blunt.
It has to be.
Is it commercially available?
Yeah, it's a commercial available in India with Appasamy, and it's Epsilon in titanium material.
Okay.
And internationally, it's available with Ducote and Ken from London. Its name as a Toshi Rada Ota nucleus dividing hook or a chopper.
Okay. Thank you so much, sir.
Okay.
I would request, yeah, sir, I would request our national faculty has joined us. So I would request our chairpersons to virtually present a certificate and a memento to him. So I have shared the screen. It is for Dr. Jagdish Rana, sir. And I think we are running a little behind the schedule. So I will ask the chairpersons to please start with the next talk. Thank you. Thank you.
Thank you, sir.
Congratulations, Dr. Rana.
Yes, thank you, sir. Thank you.
After this particular talk of Rana Ota's chopper, we pass on to the next thing, that is small pupil cataract surgery by Dr. Shon Chinsole. He is a large volume surgeon coming from a small place like Buldana, and he will be talking to us on how what his technique is to manage the surgery with a small pupil. Dr. Shubhangi will hook him or fish him. Okay? Shon, please.
Thank you, sir. Thank you, Karadikar, sir. Thank you, Dr. Upadhyay, sir. And thanks, Dr. Viral Shah, for me as a faculty to present this topic. Small pupil is really a challenging case. Common causes of small pupil is the posterior uveitis surgery, pseudoophthalmic syndrome, diabetic patient, floppy iris syndrome, and high hypermetropia, prolonged myotic therapy, and neurological conditions. The problem really appears that Capsulorhexis, it's very difficult for visualization of the rhexis. It will definitely help in size, shape, and if any extension to the periphery. It will definitely causes so many problems in hydro procedures also, and that may lead to difficulty in rotation of the nucleus also. The Phaco emulsification also will be troublesome, as smaller the pupil, poor will be the red reflex, which can lead to difficulty in judging depth and strange. Risk of catching the pupillary margin with Phaco tip that leads to capsular catch, capsular trauma. Chopper can cause a posterior extension to tear, and that leads to PCR. Increase in risk of iris damage will be there. That iris bleeding, prolapse, smaller the rhexis, incomplete evacuation of cortical matter, and definitely it will cause so many problems in putting the lenses also. How to manage? The long term, stop using the small pupil that leads to pseudo-exclusion syndrome, neurological disorder, uveitis, angle closure glaucoma, trauma, and previous history of surgery. What is the critical diameter for the pupil? Which we should consider as a small? That depends on surgeon's skill and technique, intraoperative situation, and iris tissue properties. We can operate in 4 millimeter also. Even few surgeons who are more having good skill, they can operate in 3 millimeters also. How to manage? So it depends on surgical technique, pupil expansion techniques, depend on pupil size, biomechanical properties of iris. The pharmacological management is preoperative atropine eye drops from 3 days prior to surgeries, viscoelastic agent which can lead to iris stretch, deepening of the AC and pupil dilatation. in case of posterior synechia. In case stepwise approach is 1:1000 preservative-free epinephrine intracameral injection, viscometritis with cloazu, Helion, GV, like this. Posterior synochiasis, which leads to posterior synochiasis, stretch pupilloplasty technique, which I am going to show you with the video. Surgical technique is use of good OVDs, decrease fluidic parameters, utilize the vertical chop because that is more important, and manipulate it with manipulating the anterior chamber and use bimanual. If you use bimanual IR, there is less chances of iris catch also. So here is the stretch pupilloplasty. First I have put the good OVD which stresses the pupil, and now the pupillar margin I am giving small cuts with the Werner scissor. If you have the side port incision scissors, you can use that also. And that will definitely help to maintain the pupillary margin in good condition. In case of posterior synechia, that will also break. Stretch pupil, the iris repositor. It is very simple. Put good OVD and you can just stretch with two Y hooks. One is with the horizontal and one is with the vertical direction. And you can start your surgery with good OVD. You can stretch the pupil. These are the commercially available pupil expansion devices. I'm using iris hook. Need 4 to 5 incision port. Should be placed near to the limbus to maintain the depth. Only thing is that you can find shallow AC in this case. And fifth one, why I am asking where you are going to put the main port incision, like for the Phaco. So many times surgeon get chances that after putting the Phaco probe, you will get the chances of iris to be prolapsed. So it is again very difficult to go for the surgical cases. BHEX pupil expander, because I am using it routinely. This is a BHEX injector-free delivery, preloaded, simple and safe. Advantage is it is having the hexagonal shape and easy for insertion. You can use. I am using here with the CSCR hook, but you can use with the side port forceps also, and that is more important. And it is also easy to remove also. You just have to catch, push and pull technique, and you can just remove with side port incision also or with the main port incision also. It is less traumatic to the endothelial also. Here I am removing that. Gupta pupil expander. It is also one of the good expander. We use square shape, need injector and cartridge. That is more important. Give square shape pupil margin, easy to insert and remove. The same technique which we are using with the BHEX pupil expander. Nowadays, in case of preoperative meiosis, or now even you are in a hurry to operate and patient is not dilated, one commercial available pupil dilator injection is there, tropicamide, phenylephrine and lignocaine hydrochloride injection, which can give you a good dilatation more than 4 millimeter. The advantage of overhook over the pupil expander is technically much easier to insert and remove. Pupil expander is difficult to insert after capsulorhexis. Iris hooks much more reliable in such cases. This is more important. The advantage of pupil expander over iris hook is no need for extra paracentesis, easy fixation points, smooth edges, less trauma to iris tissues and flexibility. Thank you very much.
Thank you, Sean, for nicely elaborating various techniques, the pharmacological, the mechanical devices, and the newly launched Phenocaine in managing the small pupil cataract surgery. I just one sentence that one has to be perfect with each step when you are dealing with a small pupil. You can't go wrong in any step and then do the surgery well. With this, I request the experts if they have any comment, a quick comment on this topic, so that we can go ahead with the next topic. The expert.
Nicely explained by.
Anyone?
Yes, it is nicely explained. Covered all.
So we can go on, sir.
Next, yeah, we can go ahead, madam. Yeah.
Next topic is 7 pearls for hard cataract by Dr. Rajesh Joshi. Diamond is very hard to break, isn't it? But Rajesh Joshi has learned the important steps to check the hard nuts, to crack the hard nuts over his long-standing experience. Let us hear from the academician, Dr. Joshi, about the 7 pearls for hard cataract. Joshi, please. Rajesh.
Yeah, thank you, sir, for those kind words. At the outset, I thank VOS. Special thanks to Viral and Nitin for giving me this opportunity. Nothing to disclose. Now, when you call the cataract as hard, how hard is hard and what level of hardness makes the cataract removal challenging depends largely on the experience of the surgeon. The photograph which is shown here, someone may think that it is very hard, but someone may think that it is softer one. So no definition describing hardness of the nucleus is there. So the first thing is the preoperative consideration, whether the cornea is clear or not. Because with long surgery, your cornea is going to go hazy. So that you need to see whether the cornea at the outset is clear or hazy. Pseudo-exploration comes with a lot of surprises like small pupil subluxation and the difficulties in the capsulorhexis that you need to find out whether the pupil is dilated or not. Because if the pupil is not dilating properly with pre-op mydriatics, then you need to consider the iris retractors, whether there is subluxation or not. Because if there is a subluxation, you have to keep endocapsular ring ready. And whether the patient is taking some tamsulosin for the prostate problem or not, because hard cataract with floppy iris syndrome are the deadly combinations. Endothelial cell count, what is the endothelial cell count? Because with a lot of energy which is being used for breaking the nucleus can cause endothelial damage also. So that also you need to see. Now, what are the challenges with hard cataract? As the cataract is hard and there is no glow, so the CCC is difficult one. The margins are difficult to see during the chopping technique. So you should always use Trifam blue for the staining of the anterior capsule. Capsulolenticular block, because the cataract is harder one, and once you do the hydrodissection, some amount of fluid may accumulate between the nucleus and the posterior capsule. So the lens may get pushed up at the capsulorhexis margin and may cause capsulolenticular block. Incisional burn, if you are using too much of power, that can cause incisional burn, endothelial cell loss, and weakened zonules. These are the challenges which you may encounter during management of hard cataract. Second is the incision one. Hard cataract sometimes comes with shallow anterior chamber. So you have to take the side port and main incision very carefully. Sometimes to provide the iris prolapse, you may have to consider more taking these incisions clear corneal. To protect the endothelial cell, you may have to use soft shell technique, which has been described well by Nilesh. So I will not go into details of this, but how we do it? You have to place the dispersive viscoelastic first, followed by cohesive one, so that your dispersive viscoelastic goes near the endothelium and it coats the endothelium. Next is a capsular staining. With the availability of the Trifam blue dye, CCC has become very easier. So either you can stain under air bubble or under viscoelastic. This makes the surgery very easy. How do you, what techniques you can follow to prevent the extension of the CCC? Soft shell technique, initial 2 mm incision, clear corneal incision, then perform the CCC either with the help of microcapsulorhexis forceps or 26 or 23 gauge, 30 gauge bent needle. Small CCC initially. You can always enlarge the CCC later on once you have done with the Phaco procedure. But I have found some lenses are destined to have extended rhexis, whatever you do. Hydrodissection. Next thing is hydrodissection with shallow anterior chamber and hard cataract and small CCC. Debulk the bag and then go ahead with the hydrodissection. If nucleus rotates During debulking, no hydro procedure is required. Now here you can see I am removing the cortex with the help of Simcoe cannula. So the nucleus is rotating. So no need of hydro dissection in such type of lenses. No vigorous hydro dissection as it may cause capsulolenticular block. You may not need hydrodissection in such type of lenses because once you give nick to the entry capsule, most of the fluid comes out and you can perform the capsulorhexis. So no hydrodissection is required in such type of lenses. Now next thing is the nucleus management. As these lenses are hard, you may have to protect the endothelium with soft shell technique. Debulk the nucleus with just aspiration parameters on the Phaco panel. Then you can do either vertical or horizontal chop, make the multiple chops. As you can see here, it's like a flower petal thing, and the central hard core you can remove first, followed by the peripheral hard nuclear pieces. These are my parameters usually which I follow. All are in the linear one, power around 60 to 80%, vacuum 350 to 400, and the flow rate of 35 cc. So these petals you can emulsify later on. You don't have to put too much of strain while cracking the posterior nuclear plate in this technique. And you may have to refill the chamber with viscoelastic off and on. Now this is sometimes you need to protect the posterior capsule in such type of cataracts. These are very hard cataracts and the nucleus rotates while chopping. Once you have multiple chops like this, so you can place the nucleus on one side and place an IOL as a scaffold to protect the posterior capsule. Later on, as you have placed the IOL, then you can emulsify the nucleus fragments. So this protects the posterior capsule and you will not have posterior capsular rent. And even if the surge occurs, your posterior capsule will not come in contact with the Phaco probe. So you have to prepare for eventualities also. Such type of fibrotic capsule, entry capsule, while cutting the entry capsule, you may pull some amount of zonules and may cause zonular dehiscence. So in such type of cases, I prefer to put endocapsular ring for stabilization of the bag and then go ahead with the Phaco emulsification. Phaco emulsification becomes easy once you put the endocapsular ring. With such type of cataracts which are not dilating with anything, and if it is a harder one, I prefer to put iris hooks because the fragments may rub the pupil and may cause further constriction of the pupil. And later on you can go with routine Phaco emulsification. Now, if you have such type of extension of the capsulorhexis and you are not comfortable in performing Phaco emulsification, you can always convert to the technique of your choice. I usually convert to the small incision cataract surgery. If I have extension of the capsulorhexis, you can remove with small incision cataract surgery and then place intraocular lens. Always bail out if you find that you are not able to perform Phaco emulsification. Like in this case, the nucleus was very small and I thought I won't be able to perform Phaco emulsification. So I converted it to small incision cataract surgery. So these are my top 7 pearls for managing hard cataract. Thanks for your patience listening.
Thank you. Thank you, Rajesh. A very nice talk. You have given us nice pearls. Dr. Buyar,
Yes.
would you like to add any pearl? Dr. Buyar, please.
Am I not audible?
No,
Now
You are audible. You are audible.
I will like to congratulate first of all Dr. Rajesh Joshi. He has a very cool mind, good skills. Therefore, he can only perform cataract surgery on these hard cataracts. I would like to call him Dr. T.P. Lahane of Vidarbha Ophthalmic Society because I have seen only Tata Sahib Lahane doing such kind of cataract surgeries. Thank you very much.
Yes, Dr. Lahane calls it a Laturian cataract. This will be a Vidarbhite cataract. I think we should pass on, isn't it?
Yes.
Because of the time shortage. May I call upon Dr. Subodh Purohit?
Yes, sir. Before we proceed, we have been joined by our Dr. Kalpana Narendran Madam from Coimbatore. She is the speaker in the next session. She is the awardee, oration awardee, Dr. R.N. Gandevar. So we welcome you, madam.
Welcome, Kalpana.
Okay, I think now we can pass on to Dr. Subodh Purohit from Yavatmal. May I call upon Subodh to talk on achieving a precision in toric IOLs? Subodh, please.
Good morning, sir.
Good morning.
Am I audible?
And Dr. Ugai will be passing his, will analyze his particular talk. Okay?
Sir, am I audible?
Yeah, yeah.
Can you see my screens?
No, you share your screen.
Share
Yes.
the No. No. Share the screen. Any difficulty?
Yes, sir, just a minute.
Ah.
Can you see my screen, sir?
No, we can't. We can't. I think you'll have to stop and start again.
Yes,
Now,
yes, sir.
we can see now. We can see now. Start.
No, but
No,
this,
We can see your screen, Subodh.
No.
Start. Yeah.
Right.
Yes, sir.
Yeah. Start your screen show. Yeah. Please.
Yes.
Go ahead.
Good morning, everybody. At the outset, I would like to thank our Chairman Scientific Committee, Dr. Viral Shah, for giving me opportunity, and Team VOS and Dr. Upadhyay sir for allowing me to speak on precision and toric IOLs. Now, this is the importance of precision. Everybody must have witnessed the situation like Chandrayaan-2 missed history by just 0.006%. And this is the trajectory which missed just 200 meters before landing to its target. And the picture speaks louder than word. Modern cataract surgery is more of a refractive surgery, and because of that, there is increasing our responsibility to fulfill high expectations of our patients. As we all know that myopia and hypermetropia could be corrected by using appropriate spherical powers. However, there are plenty of patients and having more than 1.2 adapter of astigmatism. So that could be corrected with the help of a toric IOLs, which we are going to speak. LRI is the other option, but it is unreliable and unstable. Lasers post-operatively has got its own complication. Now, this is the effect of astigmatism on our image quality. Now, seeing this data, we can see that around more than 87% of cataract patients have got significant astigmatism, and at least 50% of them have that cataract patients have are the potential candidates for the toric IOLs. Now, spherical calculation, already Dr. Praveen Vivare has spoken about it. We know how to calculate the spherical calculation. Now, just we are looking for the toricity of that IOL. So what we are looking is, we are looking for the projected corneal cylinder after cataract surgery. For that, we need two inputs. That is pre-op corneal cylinder and surgically induced astigmatism. Now, current consideration is the toricity of the calculations. Now, old thinking was like the astigmatic analysis was based only on the anterior cornea alone, and any disparity, if there would have been occurred between pre-op and the post-op refraction, that was attributed to the lenticular or the retinal astigmatism. But the new thinking, like it is about posterior corneal astigmatism, which Dr. Shubhangi has already spoken about it. We have to be addressed for the proper precision for the toric IOLs. And PCA, if not considered, could lead to overcorrection or undercorrection of the toric IOLs. And also the new thinking is about the centroid SI, which I'm going to speak about the vector. Now, measurement of the pre-op corneal astigmatism. All the toric, we all know that all the toric IOLs, they come in plus cylinders. So what we have to measure is only we have to determine the steep meridian of a cornea. Now, steep meridian of a cornea could be measured with the help of a manual keratometer, automated keratometer, but the corneal topographer is best if you can afford it. But for I usually use Lenstar 900, which works very well. Dr. Deshmukh madam had already spoken about posterior corneal astigmatism, but I would like to just add few points. Like anterior corneal surface in the earlier in the life is with the rule astigmatism and shifts to against the rule astigmatism as the person grows up. While the posterior surface of the cornea remains until throughout the life. So it will induce around 0.7 diopter of cylinder at 180 at spectacle plane as a with the rule astigmatism, which will have a vertical meridian steep axis. That means if we are only considering the anterior corneal astigmatism, with the rule astigmatism, it can overcorrect by 0.5 diopter, and in against the rule astigmatism, it could give to 0.3 diopter. So this will give us refractive surprises. So we have to use the newer generation of online calculators like Barrett toric calculator, and the best way to use is by using the corneal topography. These are the newer machines, but I have never used all these machines. Now let's talk about a little bit about the SIA. It is the amount of astigmatic change that we are going to induce on a cataract patient after the surgery. So ideally, a surgeon should calculate his own SIA for his own cases. Initially, we used to consider mean and median way of a SIA calculation as the best, but now it is obsolete. Nowadays, a centroid SIA is considered to be the gold standard, and centroid SIA is a vector which has got magnitude and direction. That is, it has got it has got magnitude and a direction. That is a magnitude with axis. As we can see, as I said, that it has got a magnitude and direction. So we can say that if a person has got a SI of 0.5 diopter at 90 degree and 0.5 diopter at 180 degree, initially the mean SI would be 0.5 diopter. But nowadays with the centroid SI coming into picture, the 0.5 diopter at 180 and 190 will negate and will have SI as a 0 and not 0.5. And it could be, for us, it is good that SI is minimum with 2.2 millimeter of incision or 2.4 millimeter of incision. And if you're not comfortable with this, we can go with the online calculator and get your SI. Now we have got pre-op meridian and steep meridian and also the SI. Now the point is left is like reference marking. So we can mark the patient in upright position in undilated pupil. There are various markers like gravity, bubble marker, etc. But I prefer slit lamp AC, that is BCAQ marker, which is very handy and very easy to mark. And at least we should have two reference marking, or we can directly mark on the intended axis. As we can see here, with the slit lamp marking, we can directly mark at the 180 or 90 degree or directly on the intended axis. There are no need of any fancy markers. There are other higher end machines, but I have never used all these machines. Now, after doing a proper phaco surgery, which we all do, then comes about the toric IOL alignment. So first, what you have to do is we have to go for a gross alignment. Usually you can keep around 15 to 20 degrees short of the intended axis of the toric marker, and then you can rotate it after putting the lens and while doing the eye. And after OVD removal from the posterior segment of from the posterior part of the lens and also from the anterior chamber. As you can see here, I'm just showing here in short. Like first you're putting the lens, and here is the toric mark on the lens, and which is 15 to 20 degrees short. And while doing eye, I am again taking it to the intended or the perfect axis, and then again you can go to 12 o'clock position and just see for the parallax. So as you can see here, first you have to go for the gross alignment, then you can go for the OVD removal, and then you go for the fine alignment again. And if at all, if it overshoots, again you have to go to first position, that is gross alignment, and do it. Always rotate it in a clockwise manner, even if the axis is very near. By rotating anti-clockwise, do not try that. Now, what about the rotation? Rotation can have a significant impact on the astigmatism. Generally, if for every degree of IOL rotation, there is loss of a 3.3 degree of lens cylinder. A complete loss of cylinder could occur with a rotation of 30 degree, more than 30 degree. So these are the 10 pearls of, for the precision of IOL, I'll say. Ensure that patient is willing, promise less and deliver more, which applies for all the premium IOLs, LASIK, and even for the toric IOLs. Precise corneal steep axis marking should be done, and the incision location site of even the that is also equally important. CCC must be precise around 5 to 5.5 mm. Then meticulous cortical cleanup and capsular polishing is important. Then accurate axis marking in the OT and proper toric printout. Also, the orientation of the toric printout is very important. Many times we make mistake with the orientation of the printout, and we may land up in a problem. Proper toric placement, as I've said, like 15 to 20 degrees short of the axis before the OVD removal, and 2 compartment removal of viscoelastic, and then lens stabilization at that stage. Reconfirm proper alignment, and always go at a 12 o'clock position to avoid the parallax error for the proper alignment, and look for the Purkinje images if you're not sure. Seal the incision, do not allow the AC to be shallow, and don't overinflate also. And post-op, if you find any misalignment, do realignment within 2 weeks after visiting Bartlett Harden Astigmatism Fix Calculator.com. I had this experience, and I had to do this within 2 weeks, and the patient worked very well. Astounding difference between accuracy and precision is consistency. Thank you. Thank you very much for patient hearing.
Thank you. Thank you, Subodh. Dr. Ugade, would you like to analyze his talk? Ugade, please. We have to hurry up with the things.
Yes, sir. After first follow-up, if you find what are the factors which are very in these cases you think it will be there will be axis distortion.
So both, can you stop sharing?
Yes, yes.
Axis size is okay, but any other factor in which you think this might have this in this case there may be distortion of the axis?
No, after in a first follow-up, like on the first or second day, it is not important. After throughout 3 days, you can dilate the pupil and again see for the axis. Actually, you can know very well, like if the, for example, if it is 180 or 90, you can very easily pick up that whether your lens is corresponding to the axis what you have seen. And if it is within the 2 weeks, you can go, if it is misalignment, like gross misalignment, again you have to go to www.astigmatismfix.com, and you have to fill the how many days of surgery you have done, what is the refractive error, like auto refraction, and pre-op all the parameters, and you can get all the details that how much you have to rotate it, and you can do it very well. I had a very good experience of this. I had taken help of Dr. Vyavare sir for that. 4 diopter cylinder was there, and post-op it had come to 4.5 cylinder, and I had fixed it, and the patient worked very well after that.
Okay, thank you, Subodh. With this, we pass on to the next topic, that is decision making in refractive surgery by Dr. Shweta Mukadam. Shweta Mukadam was a gold medalist in ophthalmology in DNB, having studied at Shankar Netralaya, Chennai. She did her fellowship at LB Prasad Eye Institute, Hyderabad. May I call upon Dr. Shweta to deliver her talk on decision making in refractive surgery. Shweta, please.
Thank you, sir. A very good morning. And at the outset, I would like to thank the organizers and the host for giving me this opportunity. Respected senior members, dear colleagues and friends, it is very important to be able to choose the right surgical option in a patient coming to us for refractive surgery, because refractive surgery gives us an opportunity to favorably alter the functional vision and quality of life of a refractive surgery patient. However, However, it necessitates that the surgeon possess a level of technical expertise, and so that he's able to choose among the options available, and not only just one refractive surgical procedure that he needs to be familiar with. He needs to have a multitude of procedures as a backup. The second thing is having great communication skills so as to ensure realistic patient expectations and proper patient understanding. And the third is patience, so as to be able to guide the patient in order to help him arrive at a particular decision about the proper surgery which is best suited for his needs. Instead of just making it a very theoretical talk, I decided to go across a few common case scenarios that we encounter in our practice so that we can drive home the point of proper decision making in refractive surgery. The first case is of a 30-year-old female. She has high myopia, a normal corneal topography and fundus examination, and her pachymetry is also good, 554 and 556. Looking at this data, the first thing that comes to our mind is we can probably get away with LASIK and counsel her properly about a little bit of undercorrection and possibility of regression. But a better option for her would be a phakic IOL. However, in this patient, after dilatation, we noticed this. This was a small posterior subcapsular opacity in both the eyes. This caused us to alter our treatment and management thought process, and we ended up presenting her the options of either continuing or having a contact lens trial, or just doing a refractive lens exchange if she wished something to be of permanent nature. So this case was presented to bring about the importance of a proper and a very close proper clinical exam before we jump upon providing a surgical option to the patient. The next case was of a 26-year-old male. He had a high cylindrical power. His pachymetry was about 520 microns. His corneal topography was normal, and it showed the presence of a high cylinder. What are the possible options in this patient? We can offer him the option of PRK or LASIK or going ahead with a contact lens trial. However, it is wise and often more fruitful to remember that it is not always mandatory to provide a surgical option to the patient. It is often more rewarding to just follow up the patient 6 monthly with a refraction and topography in order to ensure that he is not progressing in the wrong direction. And this will make our surgical outcome more consistent and more predictable. The third case was of a 22-year-old male patient who wanted refractive correction for fitness for the purpose of medical exam for a job. His refractive error was very low, minus 0.5 and 0.75. He had a normal corneal topography and adequate pachymetry. LASIK would be the favored option for such patients, but it is important to have proper counseling and to ensure proper patient understanding and realistic expectations in such patients, because these are the kind of patients who will be extremely dissatisfied in case they have a residual error. My next case is of a 24-year-old male patient who had -7 and -5 amount of myopia with a normal topography and adequate pachymetry. His retina, however, revealed the presence of multiple lattices with holes. On further inquiry, we came to know that he had a history of RD surgery in his father, and this immediately raised a red flag. We could offer him LASIK after barrage, but it is important to explain to him the possibility of an RD, especially with such high myopia and a positive family history. It needs to be emphasized that he needs to have regular routine retina screening examinations even after he gets rid of his myopia. A better option for him would be contact lenses, though non-surgical, but it is important that we discuss these options with him before we embark upon a surgical procedure. This was a very interesting case. This was a patient referred to us. He had iris colobomas, and along with that, he had myopia. He was a 30-year-old male, and he complained of rainbow-like rings around light at night. These increased at night. He even had them in the daytime. He was fed up of wearing glasses and wanted a surgical option. His fundus examination revealed the presence of a coloboma not involving the disc and macula. His topography was normal, and his pachymetry was 560 microns. We were debating whether to have a phakic IOL for him, whether the lower edge of the IOL would come in the visual axis and enhance his optical aberrations, or whether it would be wise to not enter inside the eye and just get away with the LASIK, and explain to him about undercorrection and regression. But after a lot of intellectual gymnastics, we just thought that it would be wiser to ask him to continue the option of contact lenses. We showed him his clinical photograph of the anterior segment and showed him why he is having dispersion of light, especially at night. And we told him that this particular problem would not be solved even with a surgery. So it would be wise to just carry on with contact lenses. Another case of a 19-year-old female who had an error of -6 and -7 diopters with a small cylinder. She was using contact lenses but was interested in a surgical option. On examination, her topography showed the presence of a steep K reading of about 47.53 or 47.06 in the right eye, and in the range of 47.25, 47.53 steep K in the left eye. Looking at this, we thought it was best to observe her refraction and topography 6 monthly. She was already in the category of form thrust keratoconus, and at present, continuing contact lenses was probably the best option for her. We could decide about the need for cross-linking at a later date, but since she was a local patient and understood all her disease process well, we thought it was wise to just follow her up. That's all from my side. Thank you.
Thank you. Any of the panelists would like to comment or ask something?
We have got all our panelists joined with us. Dr. Nangia sir is there. Dr. Nangia sir, any inputs you want to give?
No, I thought that was a good talk, and it just shows us that sometimes we have this sense that every myopic patient that comes in can undergo LASIK, but I think it's really a very personal thing for every patient. Talk demonstrated that very well, that there are so many parameters that enable you to decide in consultation with the patient what sort of refractive treatment you're going to consider, considering the long-term safety of their eyes. Thank you.
Thank you, sir. Sir, we have also got Dr. Samar Basak sir. He has joined us from Kolkata. He is a lifetime achievement, Dr. Nilima Paude Lifetime Achievement Award awardee this year. So we welcome you, Dr. Basak sir. We are just running 5-10 minutes late. So we'll be winding up after this last talk and we'll start with the next session. Thank you, sir.
Yes. Sriram Lahore, he is there? Lahore?
Yes.
Sriram, he is there?
Yes.
Okay. Will you please start your talk on IPCL?
Yes, sir.
Yes. Lahore, please.
Thank you, sir. Good morning, everyone. First of all, my sincere thanks to Scientific Committee VOS for giving me an opportunity for my presentation regarding phakic IOLs. Today, we will see a new...
Dr. Laude, you have to start sharing your screen first. Start sharing your screen.
Okay, sir.
Yeah, we can see.
Okay. Today we'll see new innovations in refractive procedures. So far as the implantable phakic contact lens is concerned, it is a very easy procedure. So far as the refractive procedures, among refractive procedures, it does not need any expensive setup. It even does not need any expensive instruments or equipments. It does need your willpower, strong and positive willpower only. So far as just to start with the IPCL, so far as the indications are concerned, age of the patient should be 18 years or above. Patient should have stable refraction for at least 1 year. He or she should have high myopia of -1 to -30 diopters. So far as the hypermetropia, from +1 to +15 diopters, astigmatism up to 10 to 12 diopters, and anterior chamber depth 2.8 millimeter from endothelium and above, and the patient should not have any ocular pathology. So far as the contraindications are concerned for IPCL, the anterior chamber depth, ACD less than 2.8 millimeter of mercury, presence of anterior and posterior synecdoche, glaucoma or IOP higher than 20 millimeter of mercury. If there is any evidence of nuclear sclerosis or developing cataract, if the patient is having personal or family history of retinal detachment, and lastly, and most important is diabetes mellitus. So far as the measurements regarding this procedure is concerned, this is the very important and critical part for preoperative measurements. Patient refraction is very important, objective and subjective both. Anterior chamber depth, that is ACD, keratometric readings, intraocular pressure, and lastly, white to white measurements, which is very important among measurements. So far as the white to white measurements is concerned, for white to white measurements, digital caliper has been proven to be the very safe, simple and reliable method. To start for white to white measurements, the caliper should be well calibrated in advance. You should pre-treat the eye with anesthetic drops. You should take the measurements under microscope with the patient in supine position, preferably in operation theater. This is the caliper used for white to white measurement, digital caliper. For white to white measurements, the measurement should be taken horizontal from 0 to 180 degrees, preferably from middle of the limbus to middle of the limbus. Now, what is the significance of height to height measurement? It's a very important so far as the oversize and undersize IPCL is concerned. Now, ideal size IPCL will provide a halt. Halt means central distance from anterior surface of the crystalline lens and posterior surface of the IPCL lens. The halt should be within the range of 0.250 millimeter to 0.70 millimeter. That is half of the corneal thickness to 1.5 of the corneal thickness. Secondly, the undersized IPCL may increase the risk of anterior subcapsular opacification postoperatively, and oversized IPCL may push the iris forward and closes the angles which could lead to IOP rise and iris malfunction. We'll see, this is the implantation and explantation in cataract eye with 2.2 millimeter of incision or 3.2 millimeter of incision. We can have this trial and run case for with the help of zero power lens. Now, the surgical techniques of IPCL. Two paracentesis, one at 3 o'clock and other at 9 o'clock. Secondly, the viscoelastic injection. The corneal, the incision should be a clear corneal temporal incision, preferably 2.8 millimeter or 3.2 millimeter. Then injection of IPCL on the top of injection of IPCL or loading of IPCL into the anterior chamber over the iris. Then injection of viscoelastic on the top of the IPCL. Then you can have positioning of the IPCL behind the iris with the help of IPCL manipulator supplied by company. And lastly, the thorough irrigation and aspiration of viscoelastic. Delivery system of the lens is also very easy. The IPCL lens is quite robust, but it's quite thin and can be handled easily. We do not need any special instruments for IPCL procedure except an IPCL manipulator for tucking the lens behind the iris. Now, so far as the IPCL loading is concerned, this is very critical and important part of this procedure. You hold the cartridge in such a way as if you have been seated for temporal phaco. You hold the cartridge, keep the IPCL lens into the cartridge, have one single drop of BSS over the lens, and you can also put a drop of visco. While fixing the lens into the cartridge, you keep in mind that the optic holes, two holes on the optic part of the lens, they should face superiorly for proper positioning of the IPCL. Once you fix the lens into the cartridge, you can inject it smoothly into the anterior chamber. This is the IPCL injection. Now manipulating the haptics. You can put the viscoelastic on the top of the lens to give yourself more room, but you can use optimum visco, minimum visco. Manipulate the periphery of the lens via paracentesis, either from 9 o'clock or from 3 o'clock. Do the distal haptic first while the pupil is dilated to its maximum. Avoid going across the central part of the lens, that is optic zone. You can manipulate the body of IPCL preferably. This is the tucking of IPCL behind iris. Now the post-operative observations. 2 or 3 observations which we should keep it in mind after 2 hours post-op of the procedures. First is IOP check, which is very important. You use caution if the IOP is greater than 20 millimeter, 10 millimeter of mercury, higher than pre-operative IOP. If there is an IOP elevation, you can aspirate the viscoelastic completely, or you can have thorough visco wash if there is any residual viscoelastic post-operatively. And lastly, you can check the IPCL halt. This is the 3 months through OCT. This is the 3 months OCT evaluation. This is the ideal size IPCL position into the sulcus. This is the proper design of the IPCL. Thank you. Thanks a lot.
Thank you, Dr. Lahore. That was a nice and elaborate talk. I'd just like to ask you one thing. What is the incidence of cataract formation with IPCL in your hands, or in general? Do you encounter cataract formation?
Yes, I have experience in one case. There is some opacification in the center of the anterior capsule, and in one case I found some IOP rise also. In that case, I have to explant the IPCL, and that is quite tricky procedure so far as the explantation is concerned.
So has the IPCL with holes reduced the incidence of cataract formation?
Till that, I have experience in one case only, madam. Rest of.
So basically, the hole formation in the IPCL improves the aqueous flow and reduces the incidence of cataract formation. The new generation IPCL probably has less incidence of cataract formation as compared to the older ones.
Yes, madam. In newer version of the IPCL, there is some central hole.
Yes.
Which helps for smoothing of the aqueous flow from posterior to anterior chamber, and
Yes.
that is quite helpful.
I request Damodaran sir to present the memento to Lahore sir.
Thank you.
Yes, looking smart now. Lahore, very nice presentation. I think first time you have presented something. At least I am hearing you for the first time. With this, we come to the end of the session. I am really thankful to all the participants, the organizers, the faculty members, and also the panelists. Thank you so much. With this, I hand over the mic to Viral to continue with the further proceedings. I am extremely sorry for having exceeded the time.
Sir, thank you so much, sir. Thank you, Karandikar sir, Bhave madam, all the moderators, conveners, coordinators, and panelists for a wonderful session. All the speakers were excellent, and so many questions are pouring in. But because we have limitation of time, so we will be sending that questions personally to the speakers, and they can answer to the give their comments whenever possible. Thank you so much. Now we start with our second session, that is session 5 of today. That is VOS orations and awards. We are joined with our awardees, Dr. Kalpana Narendran Madam, Dr. Susan Jacob from Chennai, and Dr. Samar Basak from Kolkata. Dr. Jay Shablani will be joining us soon from USA. And I welcome the chairperson for today's oration session, that is Dr. Nitin Upadhyay sir and Dr. Ajay Khandewale sir, co-chairperson, honorary secretary of VOS. So without wasting much time, I would now start with the first VOS oration award, that is Dr. R.N. Gandewar award. So Dr. R.N. Gandewar award. Dr. R.N. Gandewar did his MBBS DOMS from GMC with laurels. He did his fellowship FACS in 1984. He has taught under and postgraduate students while working as a lecturer, reader, and professor at various medical colleges in the state for more than a decade. He was a postgraduate examiner during these years. In spite of his busy schedule, he pursued his training in advanced technique in the field of retina and neuroophthalmology, IOL implantation, and the subspecialty which was closest to his heart, that is pediatric ophthalmology. He has experience of working overseas at Oman for 19 long years. Coming from a very small village, Savna in Yatmal district, he had urged to serve the poor and community at large, and he did so by successfully conducting numerous diagnostic and surgical eye camps and delivering talks on eye and healthcare related issues on All India Radio. His lifelong work was presented in numerous papers in Indian and international journals. His professional excellence is carried forward by his son and daughter, who with their spouses are pursuing ophthalmology overseas. VOS acknowledges his invaluable contribution by instituting Dr. R.N. Gandewar Award to be given annually to ophthalmic surgeons who have excelled in their field of expertise. So these are the previous list of previous awardees. In 2002, Dr. Patnaik, Dr. Vijay Lakshmi, Dr. Srinivasan, Dr. Mahipal Sakdev, Dr. Pradeep Sharma, Dr. Sridhar Rao, Dr. Harminder Singh Dua, Dr. H.K. Tiwari, Dr. Debasis Bhattacharya sir, Dr. Abhay Vasawada, Dr. Roni George, Dr. S. Haldipurkar, Dr. Pramod Bhende, Dr. Karobi Lahiri, Dr. Milind Naik, Dr. Meenakshi Swaminathan, Dr. Sujata Gua, Dr. Subhadra Jalali, Dr. Rohit Shetty, and this year in year 2020, we are proud to bestow this award on Dr. Kalpana Narendran Madam, who will be presenting her oration on perspective on pediatric cataract management. Since this is a virtual meet, we were fortunate to send across the memento of the award to Dr. Narendran Madam, and she was kind enough to share the picture with the memento. Thank you so much, Madam. And I now invite Dr. Nitin Upadhyay sir to please introduce our oration awardee, Dr. Narendran Madam.
Good morning all. It's my honor to introduce Dr. Kalpana Narendran, a stalwart from the field of ophthalmology. Ma'am is a head of the department, Cataract, Pediatric Ophthalmology and Strabismus in the prestigious Arvind Eye Hospital and PG Institute of Ophthalmology, Coimbatore, Tamil Nadu. She has done her graduation from the MGR University, Chennai, and PG Diploma and DNB Ophthalmology from Arvind Eye Hospital. She is a fellow in Pediatric Ophthalmology and Strabismus from Arvind Eye Hospital. She is She has an observer fellowship in the Department of Pediatric Ophthalmology in John Hopkins Institute, Wills Eye Institute, Julie Steen Eye Institute, and Children's Eye Hospital, Boston. A very strong Rotarian. She received the prestigious Vocational Excellence in 2010, Sake of Honor 2012, Otrapudam Pengal in 2013. She received the Best Doctor from Dr. MGR Medical University 214. Dr. S.S. Badrinath SOA SN Alumni Medal in 2019. She has a gold medal in IIRSI 2019. She is a co-convener of Indian Women Network, Tamil Nadu Health and Well-being Task Force since 2017. She is a former chief editor of Journal of Tamil Nadu Ophthalmic Association. She is an honorary doctorate degree by Vignan University, Valamudi, Guntur, Andhra Pradesh, India. She is a past president of Coimbatore Society of Ophthalmic Surgeons. She has a vast experience in performing more than 25,000 SICS, more than 35,000 phacoemulsification surgeries, 4,000 pediatric cataract surgery, and around 6,500 screen surgeries. She is a reviewer for the reputed ophthalmic journals like the British Journal of Ophthalmology, Oman Journal of Ophthalmology, and Tamil Nadu Journal of Ophthalmology. More than 35 publications in the peer-reviewed journal, the latest being the Knowledge, Attitude, and Practice Towards COVID-19 among the patients, presenting to the 5 tertiary eye care hospitals in South India. It was a multi-center questionnaire-based survey in the Indian Journal of Ophthalmology, 2020 November. She has authored a book chapters in various books on strabismus and ocular injuries and emergencies. She has presented papers and presentation on pediatric ophthalmology, cataract, and strabismus in various national and international meets, the recent one being the ESCRS meet in September 2019. I proudly present Dr. Madam.
Thank you. Thank you for such a lovely introduction, and good morning, everybody. I also want to thank the office bearers, the president, secretary, and the members of the Vidarbha Ophthalmic Society for giving me this privilege of delivering the lecture in honor of Dr. R.N. Gandevar. And I'm honored to be giving this oration today here. And I think I know Ravi Gandevar and Jayashree Gandevar. We were, I think, during fellowship in Madurai. I did have some acquaintance with them, and it is really an honor to be added to this list of the preceding award winners. So coming to my topic, perspective on pediatric cataract management, childhood blindness is a public health concern across the world. And if you look at the statistics, the prevalence of childhood blindness is around 1.42 million. And in the developed countries, it's about 1.5 per 1,000 children, whereas in the underdeveloped world and the developed countries, it's about 0.3 per 1,000 population, and 11% of this is because of the lens pathology. And the prevalence of congenital cataract globally is around 1.8 to 3.6 births. And the meta-analysis, the study which gave a global epidemiology of the congenital cataract, and this says it's about 2.2 to 13.6 per 10,000 population. And when you compare the numbers, it is the least in Australia with 2.25 per 10,000 population, whereas in Asia, it's about 13.6 per 10,000 population. I'm just giving you a brief idea because most of us who are in general practice or in other specialty may not understand the magnitude of this problem. And again, roughly to share the statistics, across the 7 tertiary eye care centers of Aravind Eye Care System, down south in Tamil Nadu, we see on an average, Madurai alone sees around 607 pediatric cataracts every year. And just for you to look at the number, and then this is the number which we see in Coimbatore. We always think that the number will reduce, but if you really see consistently, still we do see a lot of, pediatric cataracts of varying etiology. So coming to the classification, it's mainly on the, presentation. If it is present at birth, it's called congenital, or later in age, infantile or a developmental cataract. And based on the morphology, depending on the location of the lenticular changes, it could be anterior subcapsular, lamellar, and also unilateral and bilateral cataract. Most of the patients present is a bilateral cataract, but then, at least 10-20% present unilateral cataract. Usually unilateral cataracts will be associated with the posterior segment pathology. The persistent fetal vasculature is usually the common pathology which is associated. Again, etiology, 50% is hereditary. It could be dominant or recessive. With varied heterogeneity, and then intrauterine infections is a major cause. It could be because of rubella, cytomegalovirus, chickenpox, measles, and herpes virus can cause. And acquired causes could be traumatic, developmental. You can see this happy family, and this was a picture taken a long time ago. That's why you can see them all with their aphakic glasses. But now the scene has changed. We implanting IOL in children as well. And the other metabolic causes and medications, especially with allergic conjunctivitis, long-term use of steroids can cause induced cataracts. And chromosomal anomalies, Down syndrome can be associated, metabolic galactosemia, and the other things which can be associated with congenital cataract. And we did a study some time ago in Aravind, which did the etiology of pediatric cataract in all cases, and you can see here very well that at least 50% of the cases the etiology was not known. And then embryogenesis was about 14%, and the other causes, and 22% was because of autosomal dominant causes. And if you see the the etiology children less than 1 year old, we can see that at least 22% was because of 29% was because of rubella infection. So after this, there was a recommendation which was given to the government, and the rubella vaccination has become mandatory in the antenatal age group of all the the child expecting mothers. And what is it so different, when you deal with the pediatric cataract? Unlike in adults, the pediatric cataract, disrupts the development of visual pathway. So this can cause a stimulus deprivation and cause amblyopia, and this in turn affects the growth of the eyeball, or rather retards the emmetropization. So that is why presence of a cataract in a child is an emergency. And how do they present to you? Usually they present with a white reflex, but not all of them. Sometimes a lamellar cataract presents with the with a gray reflex, which only can be picked up after dilatation, and might be a lack of social smile. Usually parents complain of defective vision for distance. There may be an associated squinting, again because of stimulus deprivation. They can present usually with esotropia, but then exotropia or sensory exotropia is also seen, but sensory esotropia is more common in a younger child who's affected with the congenital cataract. Nystagmus mainly because of the the poor foveation and the binocular vision being affected. So presence of nystagmus is a poor indicator for the outcome of visual acuity. So a pediatric cataract or congenital cataract which is not treated, or once the nystagmus sets in, then you have to keep in mind that it is an indicator for poor visual acuity prognosis. And when you see this child clinically, you need to assess the anterior and posterior segment to rule out any other posterior segment pathology, mainly to give the prognosis and then make you prepared for any other procedure to be added on this child. Visual acuity estimation, morphology, again will also help you to give you the etiological diagnosis, ocular motility and fixation pattern. When it comes to the preoperative assessment, history is very mandatory, because especially when you're dealing with rubella during the gestational period, in the first trimester, the mother might complain of a fever with rashes or a post-auricular lymphadenopathy. So it's very important to get a detailed history, and then family history, and parents with cataract, parents with refractive errors. So you should give a chair time to get the details of the history properly. Clinical assessment, systemic evaluation, which I'll be talking to you later. And systemic evaluation, congenital rubella syndrome should be kept in mind. And usually this cataract is a very membranous cataract. The child might look sick, but not always true. They have associated cardiac anomalies. They might have sensory neural deafness. And then a TARCH test is mandatory in the laboratory investigations, along with the blood sugar to rule out diabetes, hepatitis B, X-ray and echo to rule out cardiac problems. And always get a pediatrician's opinion and before you proceed for surgery. And more importantly, the respiratory and other neurological problems, and to see if there is any associated developmental delay. So what is different, in a pediatric cataract surgery? It's a challenging thing, because unlike in adults, you're not able to predict the functional outcome of surgery in these children, because you're treating a growing eye. And there is the chance of a myopic shift, where there is a change of the refractive status of the eye. And not only that, in adult cataract, you operate and then you're fine, you're done. Whereas the whole thing starts after surgery here. So when we counsel the parents, we tell them that don't think that everything is over with the surgery. The visual rehabilitation is the most important thing in a child, and the follow-up is very important. So as a pediatric ophthalmologist, you should always focus on this rehabilitation and trying to give the best possible vision and quality to these children for their longer living years. And when you decide on doing the surgery, first of all, it's very important because it's done under general anesthesia. The procedure may take about maybe 20 minutes to about half an hour, and you need a good anesthetic backup. This is a choice, whatever the laryngeal mask or the regular endotracheal tube should be given to the anesthesiologist. And anatomically, you should look at the eye, because when you want to see the corneal diameter is very important, or are you dealing with a microphthalmic eye. And there are other specific anatomical characteristics which are specific to the pediatric eye, is that they have a low scleral rigidity, and the anterior capsule is very elastic, and the myopic shift is a unique thing which happens in a child, and every step should be customized to every child. And one should also keep in mind the ocular dimensions, the change in axial length. And the next controversial topic in a pediatric cataract is the biometry and IOL power calculation. So you need to select an optimal IOL power for a growing child, and you need special instrumentation like the handheld keratometer should be needed, because some of these children may not cooperate under local anesthesia. So you have to put them to sleep and then do the keratometer, and then take the IOL power calculation. And we do not have specific IOL formulas designed for children yet. So we still follow the IOL formulas which are designed for the adults. And then, like I already mentioned, the myopic shift should be kept in mind. So the challenges in IOL power calculation for children would be selecting the optimal power for a small or eye of a growing child. And not much of advances and not much of studies have been done on this. And then very few evidences on accuracy of these formulae on pediatric eyes. And then again, you have to keep in mind that younger the child, the more chance of myopic shift and the more chance of, the change in the refractive power, which may sometimes lead to IOL exchange, which I'll be talking later. And, possible errors, compliance to ambulatory therapy and follow-up. Again, if you see the prevalence, if you see it is more in the rural population rather than the urban population. So like we all know that the rural population, the compliance might be sometimes poor. The socioeconomic status might prevent them to come for follow-up. So it's very important that, you need to explain to the patient regarding the compliance of ambulotherapy. In talking about the growth of the eyeball, this is just a graph, the theory proposed by Gordon Donsis. He says around 90% of the growth of the eyeball is complete during the first 18 months of life after birth. Again, here, if you look at the different parameters, in the phakic eyes, the axial length from 0 to 6 months, which is 17 millimeter, by 5 years, it becomes 24 millimeters. So the maximum growth of the eyeball happens between 0 to 2 years of age. And even there is a change in the keratometry values and the lens power values. So these are the challenges. You're treating a growing eye, so you have to predict, what is needed for this child when he reaches adulthood. And this is the roadmap for the IOL power calculation. The biometry is done, and then you calculate the IOL power for emmetropia. Then you need to undercorrect. So why do you undercorrect? You undercorrect for the myopic shift. So how do you do it? Based on the age. So I have a formula which I'll share with you in my next slide. So this undercorrection is based on the age, bilaterality, unilateral or bilateral, and what is the status of the fellow eye, and parents or siblings with high myopia and compliance. Because this myopic shift or the undercorrection itself can induce some amount of hyperopia. So, you need to really make clear to the parents that I'm undercorrecting, and the child will need glasses even after an IOL implantation. And it's important to do wear the glasses and follow up with occlusion therapy. And again, the power might vary depending on the site of fixation, whether it is in the sulcus or in the bag or an iris claw fixation. And the calculation formulas, we already talked about it, and the theoretical formulas have been more accurate for pediatric eyes. And studies have been done which have, proved that the SRKT formula holds good, and the Hoffa-Q for smaller axial length would be an ideal formula to use for pediatric cataracts. And this is the chart I was talking about. These are the chart age in years, and these are the other, the other pediatric ophthalmologists across the globe who have suggested their numbers. So these are the numbers which, like the Wilson and Rupal Trivedi's, Crouch et al. And this is what we follow at Arvind here. So if the child is around 6 months, the target refraction would be +8 diopters of undercorrection if it's a unilateral cataract. Again, if it is a bilateral cataract, it is different. So this is what we follow. Even in spite of this, sometimes you might have refractive surprises, in a child, and it is unique to every child. So the take-home pearls in the IOL power calculation would be choose an ideal power which is which will be the best help to fight amblyopia and causes the least refractive error in adulthood. And despite best efforts, sometimes a child might need an IOL exchange or a refractive surgery. And in very young eyes, the results are unpredictable. So coming to the choice of IOL, what kind of lens would you place? We prefer to place a hydrophobic acrylic lens. In older children, I personally, above the age of 6 years, prefer a single piece lens, whereas in a younger child, I prefer a 3-piece lens, mainly because we are not very sure about the myopic shift. So in case you need to do an IOL exchange, a single piece lens, surgeons who've done an IOL exchange would know that the adhesions are much more, whereas in a 3-piece lens, because of these prolene haptics, the adhesions are less, and it's easy to do an explantation of this IOL. And the contraindications, not every one of them can have an IOL implanted in them. Sometimes you have a child like this, a microphthalmus with an associated glaucoma or uveitis. And rubella cataracts, that initially there was a norm that you do not place an IOL in these children, but now with the technology and the previous experience, if the eye is quiet, if the corneal diameter is fine, we do implant IOLs in children, not very young, usually above the age of 3 or 4 months. In very young children, sometimes we also have seen studies which prove that the virus might stay a little active, and then you might even end up in an endophthalmitis. And intraocular tumors sometimes can also present with cataracts. Just to show you a pediatric cataract surgery, you can see here, this is, you make a clear corneal incision, and I use a regular, HPMC, hydroxypropyl methyl cellulose. No need for a higher-end viscoelastic, but you can definitely in the beginning of the learning curve, you can use for a better control. You can see the rexis, the capsule is so elastic. You need to do, you to do a centripetal pulling, and an adequate size. The size should be around 5 mm. If you only plan for a 5 mm, you will end up with a 5.5 because of the elasticity. And the cortex aspiration is very easy. You can use your IA cannula. And a thorough cortical cleanup is very important because of the epithelial cell migration, and the posterior capsular opacification is a major complication in these children. And you see a 3-piece lens is placed in the bag. And I prefer to do a posterior capsulotomy after placing an IOL. So I use my cyclodexis spatula to lift the lens and make a small nick with the cystotome and make a primary posterior capsulotomy. If the child is about 10 years, I just do the primary posterior capsulotomy and leave it. And the wound is always closed with a 10-0 Weichel suture. You can see this video here. I'll show you the primary posterior capsulotomy, which will be well demonstrated. So you see the rexis, how it is being done. Centripetal pulling, gently keep in mind the elasticity of the capsule. So once you complete it, you thorough cortical cleanup, and you can see the lens. The scleral tunnel, normally in children less than 2 years, I prefer to do a scleral tunnel, and the incision is always superiorly placed. So you can see here, after placing the lens, you can see the round rexis. I use my spatula to lift the lens, and you can I make a small nick with my cystotome, and then once the whole opening is made, I use my capsule forceps to enlarge the posterior capsulorhexis. You can see here, the rexis is enlarged. It is not as elastic as the anterior capsule, the posterior capsule. Okay, now it's complete. And then you do an anterior vitrectomy to clear the anterior vitreous face, and then you suture the wound. And post-operatively, on the table, they get a subconjunctival decadron, and post-operatively, they are treated with topical steroids and antibiotics. We give them cycloplegic homide, and we follow these children after 2 weeks. Suppose the child needs a second eye surgery, we recommend them to come to after 2 weeks for the second eye surgery. And after 2 weeks, if there's any underlying refractive correction and amblyopia therapy, should be started after 2 weeks of surgery. And during follow-up, what is that you would see on these children? So you have to explain to the parents the importance of follow-up, and every child who visits should have a detailed slit lamp examination, mainly to detect the presence of any posterior capsular opacification, because secondary membrane formation is one of the major complications you see in children. In spite of doing a thorough cortical cleanup, and you do not know who's going to develop it, especially in younger children. Sometimes younger children will have to put for sleep, like a small examination anesthesia should be done, and visual acuity estimation with and without correction, and always check for binocularity and fundus examination and intraocular pressure. Amblyopia treatment, if there is any underlying amblyopia, most of them would, if they don't present to you at the right age, then you need to start on the amblyopia treatment. Glaucoma in aphakia and pseudophakia is a major problem, but now it is not so, because we are seeing more of glaucoma in aphakics, but after we have started implanting IOLs in children, the incidence of glaucoma has come very much less, but it is mandatory to check the IOP of these kids who present to you every week, every 6 months or 3 months of how you recommend them to come. So, the successful IOL surgery in a child mainly depends upon the selection of cases, the suitable technique, the lens power implanted, and then the recognition, the close monitoring, follow-up, and then the cooperation of parents and their compliance. So this is just to show you an eye, which is, after an IOL implantation, and this white thing is the posterior capsular opacification or remnant of the posterior capsule. So let us look at some special situations in a pediatric cataract. So the secondary IOL is the other thing. Sometimes you leave the child aphakic and then you plan for a secondary IOL implantation. And this is mainly, one of the effective optical modality for managing pediatric aphakia. There's definitely a visual acuity improvement, and the child is, getting rid of glasses, except they need glasses for near. There's another important thing that you have to explain to the parents, that even in spite of wearing the, placing an IOL, this child will need glasses for lifetime. And, this secondary IOL will need other additional procedures like vitrectomy, pupiloplasty, and membranectomy, and so on. So I'm sharing with you 2 patients. This is a patient here, you can see, it was a traumatic cataract. So initially during the first setting, because there was so much of inflammation, the cataract was aspirated, and the lens matter was aspirated, and the posterior capsule was left behind. You can see all these synechae here. So you take efforts to release the synechae, a clear corneal incision, a 3-piece lens is placed in the sulcus, and the visual axis is clear, so we're not doing any vitrectomy or membranectomy. And this is my second patient. You can see here, the posterior capsular support is compromised. You can only see a rim here. So, and you make a side port. I'm just trying to retract and show. There is a peripheral thin rim of a PC. Such cases, what I prefer to do is that iris fixation. Here, a Pronin suture is passed through the iris and the optic of the lens, the hole through the hole, and then it fixed to the iris. This really is good, and the eye is quiet, and I've been doing this for almost 15 years, and the results are good, and I have no increased IOP or any other problem because of our iris atrophy or anything like that. So it is definitely a good option. And scleral fixated IOL is a good option as well, but then can be done only in little older children above the age of 10 or 12 years. The other common cataract children present with is a traumatic cataract here. So we should always, get a detailed history if there's any underlying intraocular foreign body. So you can see here there's a rupture of the anterior capsule. You can see here sometimes there might be extension of this to the posterior capsule. So you have to be very cautious when you're removing the cortex. You should make sure that it does not drop into the vitreous. So you can see very well here that we are able to place the lens in the bag and do a vitrectomy. For want of time, I'm not showing the whole thing. So this is again another cataract. You can see here that there is, lot of adhesions. So take time to release the adhesions, complete, you can stain. Initially, staining was not allowed in children, but now studies have shown and it's proven to be safe. So you can use a stain. Look at this plaque here. Look at this posterior plaque, how it is being removed. Gently, you just create a nick and peel it out. And you can see that there is a dehiscence associated with this plaque. So you can do a vitrectomy and close. And this is a cataract where, there is a iridodialysis and synechae. There's also some amount of subluxation. You can see here, the lens is moving while we are doing the rhexis. So the thorough cortical cleanup, and I'm using a CTR to stabilize the bag. So the bag is stabilized, and then I'm doing a vitrectomy to clear and then placing the lens. And the next thing we see in children, not very common though, but we see subluxated lenses and spherophakias. So such cases have to be, clearly the anatomical problems should be understood, and always look for surprises. And this is a patient with a spherophakia. You can see here, this child is a microspherophakia. This is a little older child. So once you see a spherophakia, I attempt to do a rhexis, and I'm placing a CTR here. The cortex, I'm trying to enlarge the rhexis here. You can see here, you have to release the hooks. Otherwise, the tension on the capsule might extend. So make sure you release the tension on the capsule, and then you, use and then put the CTR and put the lens in the bag. But these children have to be closely followed, but usually they do not, like in adults with pseudoexfoliation, they do not fall back. They stay in position. And this is a Marfan syndrome, autosomal dominant penetration. You can see here we're using this multiple iris hooks, and we are using the modified CTR, the Sionis ring. The Sionis ring is a modified CTR. This is how it stays in the bag, and then it's fixed to the sclera. The results are good, but then one thing we have to keep in mind is that later on with the age progressing with fibrosis, sometimes there is a decentration of the IOL, so you might have to go in for a second procedure. So that is the only problem, but then the results are fairly good. So you can, but the learning curve is a little, longer. But definitely, if you learn the technique, it's one of the good techniques for a subluxated lens. And the persistent pupillary membrane, again, it's not a very common thing. There is an incomplete regression of tunicovascular lentis. It can present like this with a small lenticular opacity, or it could be something like this, which completely obscures the visual, the visual axis. So the options would be a case like this, you observe, or you plan for pupillary dilatation, or a case like this, you will plan for surgical removal. So this is just to share with you these two videos where I initially, in the initial years, when a patient presents like this with an anterior capsular opacity like a cataract, then this is what I was doing. I would go and release the membrane and then go and do an anterior capsulorhexis and do the lens removal and, leave the child phakic, or IOL placement will be done. But now, for the past few years, I am doing this technique, which is, really nice that you don't do the lens removal, you release the threads, and this I did in one of the patients. It turned successful, and then I started doing this. You can see here, very gently you peel the, release all the attachments to the pupillary margin, and then gently you peel the membrane. So if you see here, the anterior capsule is not affected. This child is being followed up now for the past 5 years. She is looking very nice. There is no cataract formation, and she had this with both the eyes. So we did one eye at a time, and this is how she looks. But she did have some stimulus deprivation amblyopia, so she was on treatment for amblyopia. Then coming to multifocals and torics in children, we think that the premium IOLs do not have a place in the children, but always the question from the parents would be that, should my child wear glasses? Why are you, in spite of wearing a lens, why are you, giving them glasses? So not all patients are candidate for multifocal lenses in children, especially older children can be tried with multifocal lenses, because children lose accommodation when cataract is removed, unlike in presbyopic patients. So sometimes this lack of accommodation can lead to abnormal development of binocular visions. So for a multifocal lens, to be placed in a child, you need precise, like in an adult, precise biometric measurements and precise IOL power calculation, and always aim at emetropia. Cannot be done in children less than 10 years of age. So this is a boy, 11-year-old boy presenting with the intumescent type of a cataract. Had a multifocal lens. I used a Varian imaging guiding system for the rhexis for proper centration. Proper rexis and in the bag implantation is very important for a multifocal IOL. A thorough cortical cleanup is being done. And you can see here a multifocal lens is being placed. And in a child, we all know that the major problem is the PC opacification. I'm doing a secondary rexis here to avoid capsular phimosis and a primary posterior capsulotomy to to clear the visual axis. So and again torics. So multifocal and torics are not an option for all the patients, but it can be a choice for older children. So we all know the astigmatism in children usually to begin with is against the rule, and then they become with the rule, and as they grow older, they again become against the rule. This was again a 13-year-old child with an astigmatism more than 1.5 diopter, and the parents were insisting on, we gave the option, so they were willing for a toric IOL. It is similar to an adult toric IOL, but the marking, because it was a 12-year-old, he cooperated well for marking, before anesthesia. Otherwise, you can use the Varion imaging guiding system to mark the 180s and place the lens, which I have used in this patient. You will be shortly seeing. So this is used, and the axis is 92 is what the IOL has to be placed. So want of time, I'm just skipping this step. And last but not least, IOL exchange is another thing you have to keep in mind, because when you operate on very young children, the myopic shift sometimes may be so gross that there will be a gross anisometropia between both the eyes. So then you will have to do for IOL exchange, and then repeat capsulotomies like this, optic captures. So this will definitely affect the contrast and the visual acuity of these children. So they are ideal candidates for IOL explantation. This is again some of the optic capture patients who present to you later. These are all kids who've been operated 20 years ago, who presenting now like this, who've lost for follow-up. So you can see the tough membrane. You can see here. So that's why I said, when you do cases like this, a foldable 3-piece will be much easier to remove than a single piece. And the IATS study, the infant aphakia treatment study, I'm not going to details for want of time, but this did give a randomized study about placing a lens, a younger child. But then, the contact lens can be a good option for very young children, especially with unilateral cataracts or bilateral cataracts, if the parents are compliant. And this is just the another study which supports the placement of IOL. They say that IOL implantation in children less than 1 year old, there is a chance of resurgery, a secondary membrane formation and resurgery. So one should be skeptical whether when you decide to place an IOL in a very young child. So to conclude, post-operative rehabilitation, the main idea is to give an optimal visual stimulus, effective amblyopia therapy. And then, of course, these two are, FAK glasses are out of question, but still we do give FAK glasses, for children, because some of our children below the age of 1 year, bilateral, they still have, FAK glasses. Contact lenses and intraocular lenses are also, an intraocular lens is the best choice now. So just to share with you, this boy who got operated last week with us, you can see the eye is quiet. He had a panoptic toric IOL. He had like 1.84 astigmatism. Just to share with you, because we always have this mind, pediatric cataract, we should not do. There's so much of inflammation, fibrin membrane formation. This is POD day 1. You can see how quiet the eye is. The child is happy. I had to crop the picture. Otherwise, you would see the child is, he's smiling, and the centration of the IOL. So, pediatric cataract is definitely very gratifying to do, because the number of living years of these children, if you can help them see well, it is definitely a big a boon to the society. And thank you so much for the opportunity, and thank you again the Vidarbha Ophthalmic Society and the office members for giving me this opportunity. Thank you.
Thank you so much, madam. That was a wonderful presentation. I now request our secretary, Dr. Hannewale sir, to please propose a vote of thanks for madam.
Good morning, everyone. I am privileged to propose the vote of thanks for this oration by Dr. Kalpana Narendran. It was very nicely and elaboratively explained the important and becoming commoner pediatric cataract cases, right from the incidence from the proper history taking, examination, the main challenges the facing of regarding the biometry, and because of the early diagnosis and management is important because it causes the stimulus deprivation, amblyopia, and retarding the growth of eyeball. Even after doing a very good pediatric cataract surgery, your job is not over, but the visual rehabilitation is very important. In such a short period of time, you have covered almost everything, right? Indications for toric and multifocal IOLs, various indications for IOL exchanges, and last but not least, the interesting videos you have shown, they were really very good. I would like to thank Dr. Kapil for enlightening us with her knowledge. It gave us deep insights into the topic and also revealed some interesting facts regarding the pediatric cataracts. Once again, I would like to thank Dr. Narendran for taking out time from her busy schedule and giving this opportunity to hear her thoughts regarding the pediatric cataract. This is surely going to help us in managing pediatric cataract cases, and looking forward to hear you again. Thank you very much, ma'am. Thank you.
Thank you.
So thank you, madam. So now we move over to our next VOS oration, that is Silver Jubilee Vidarbha Ophthalmic Society Dr. Ishwar Chandra Award oration. Dr. Ishwar Chandra was known as one of the best teachers all over the country. He was dedicated and extremely disciplined person. As the professor of ophthalmology in Government Medical College, Nagpur for many years, he was responsible for shaping careers of ophthalmologists in India and abroad, either by teaching them or as an examiner for MBBS, DO and MS exam. He was truly a father figure for all the members of VOS and a doyen in the field of ophthalmology. We all the members of VOS salute him and bow in front of him. The organizing committee of Silver Jubilee Annual VOS Conference held in 2000 decided to start a special award known as Silver Jubilee VOS Dr. Ishwar Chandra Award. Award is given every year during the annual VOS conference as a token of respect to this towering personality, to an exceptional ophthalmologist who has done outstanding work in the field of ophthalmology. These are the list of previous awardees: Dr. Patnaik, Dr. P. Vijayalakshmi, Dr. M. Srinivasan, Dr. Mahipal Sakdev, Dr. Pradeep Sharma, Dr. Sridhar Rao, Dr. H.S. Dua, Dr. M.K. Tiwari, Dr. D. Bhattacharya, Dr. Ramamurthy, Dr. T.P. Lane, Dr. Santosh Honawar, Dr. B. Shanta, Dr. Ashish Bansal, Dr. Hari Priya, Dr. Kasturi Bhattacharya, Dr. Partha Biswas, and Dr. Rasik Vajpayee. And this year in 2020, we are proud to bestow this award on Dr. Susan Jacob from Chennai for her talk on treatment of advanced keratoconus. Since this is a virtual conference, we have sent the award memento to Dr. Susan Jacob madam, and she was very kind to share a picture with the memento along with her. So I now request Dr. Nitin Upadhyay sir, President of our viewers, to please introduce our speaker for today's oration, that is Dr. Susan Jacob madam.
It's an honor for me and for the Vidarbha Ophthalmic Society to introduce such a big stalwart and an innovator, Dr. Susan Jacob madam. She is a past MS FRCS DNB. Presently, she is a Director and Chief, Dr. Agrawal's Refractive and Cornea Foundations. She is the recipient of the following prestigious international awards: JRS Waring Medal, ISRS Kritik Zinger Memorial Award, Innovators Award, John Henahan Award, International Ophthalmologist Education Award from American Academy of Ophthalmology, AAO International Scholar Award, AAO Achievement Award, ASCRS Top Gun Instructor Award, Bruce Jackson Oration from Canadian Ophthalmological Society, Harold Steen Innovator Lecture from the Canadian Ophthalmological Society. She is a two-time recipient of ASCRS Golden Apple Award. She has in the bag also the prestigious Indian awards: IIRSI Special Gold Medal, UK SOS Gold Medal, AM Gokhale Award and Oration by Pune Ophthalmic Society, Dr. T. N. Gopinathan Menon Memorial Oration Award and Gold Medal, Dr. P. R. Mondal Memorial Oration Award. In addition, she has won more than 50 prestigious international awards for her surgical videos as well as the Best Paper of Session Awards on her innovations and challenging cases as prestigious international conferences in United States and Europe. Authored more than 100 peer-reviewed publications, she has more than 200 chapters in 34 textbooks and is an editor for 17 ophthalmological textbooks and reviewer for many prestigious journals. She is an avid blogger, YouTuber, and has a large fan following on the various social platforms for her surgical teaching videos. She is a surgical innovator. The best is the anterior segment transplantation, where cornea, sclera, artificial iris, pupil, and IOL are transplanted in block for anterior staphyloma. Suprabro single stab incision stosis surgery, turnaround technique for false channel dissection during intacts, glued endocapsular ring, glued capsular hook, paperclip capsular stabilizer for subluxated cataract, stab incision glaucoma surgery as a guarded filtration surgical technique, contact lens cross-linking for safely cross-linking the keratoconus corneas, endo-illuminator assisted DMEC, air pump assisted PDEC and host dismantling scaffolding for easier and better visual results, presbyopic allogenic refractive lenticule, inlay for treating presbyopia, cornea allogenic intrastomal ring segment for keratoconus and other corneal ectasia, the Jacob modified technique for pre-descent DALK as a primary treatment for acute hydrops, sutureless smile lenticule assisted resurfacing with the interface tattooing for limbal dermoid, white ring sign and sequential segment terminal lenticule side cut dissection for a safe and effective lenticle extraction in smile surgery. She has proposed a new classification of a descent membrane detachments into rhegmatogenous, tractional, bullous, and complex detachment with a suitable treatment algorithm, and a new technique of relaxing desmatotomy for bullous and tractional descent detachment. We are proud to introduce ma'am. Hello.
Yes, thank you. Thank you so much, Dr. Upadhyay and Dr. Khandeval and Dr. Viral for such a very nice introduction. I am really honored to be here at the VOS to be presenting here. Thank you so much for including me, especially for this Ishwar Chandra Award, because I saw the recipients, the past recipients of this award, and I was really taken aback that I was considered for inclusion in this prestigious list. So thank you so much for doing this honor for me. And I will just share my screen now. Okay, I hope my screen can be seen.
Yes, madam. Yes,
Okay.
madam.
So once again, I am very honored to be bestowed this oration award in the name of Dr. Ishwar Chandra. And I did just a few words about Dr. Ishwar Chandra because the award does mean so much to me. I have understood that he has been a teacher to almost every ophthalmologist in the city, and of course many in the country, which I think is a big thing because a teacher is someone who makes the next generation come up and keeps the field running. So all my respects to him, especially since he taught almost till the fag end of his life and passed away at the age of 92. Very active, very disciplined, and very dedicated person. He is known as the father of clinical ophthalmology, and his expertise in squint, I realized that he had handwritten notes in squint which are still used, which is really a testament to the effectiveness of a teacher. So my respects to Dr. Ishwar Chandra, and once again VOS for thank you VOS for having invited me to give this oration. My topic is CARES, corneal allogenic intrastromal ring segments, and this is an acronym that I have created, and it's a surgical technique that I have introduced. I have a patent pending for some of the special refines devices and processes, as well as some of the CARES segments. So that's my financial disclosures. I'll also be talking a little bit about CSCXL if time permits. Just to get straight away into the topic, we have to understand that keratoconus is really no longer a very rare disease. One of the, of course, there's a lot of variation in the geographical distribution of keratoconus, but in some places really high, and India is one of those places. A study of the prevalence in Riyadh in Saudi Arabia, where also in the Middle East also it's pretty high, they found that the incidence of keratoconus was actually as high as 1 in 21. So we really need to open up our eyes and look at this disease in a very new manner, especially with all the newer diagnostic modalities that are available. You can pick up earlier and earlier cases of keratoconus, and that becomes a big boon because it's an imminently treatable disease. And the earlier that it is treated, the better the results are. So I think as ophthalmologists, we all need to keep our eyes open and look into all the subtle telltale signs of keratoconus, which could be in the form of eye rubbing or an allergic disease, or just a cylinder, high astigmatism, and things like that. Our family history of keratoconus, and really do these diagnostic tests at early and early ages so that these patients can be picked up earlier and treated earlier. Now, when you look at the current treatment of keratoconus, we know that one of the mainstays of treatment is corneal cross-linking. And that's really a beautiful treatment that has been introduced by Dr. Theo Saylor, and it has really been a boon to the patients with keratoconus. However, cross-linking by itself has a limited role in regularizing corneal topography or in improving vision. It does cause some amount of corneal flattening, but not the amount that you would want in cases with advanced keratoconus. And so patients with advanced keratoconus may be unhappy with just isolated cross-linking alone. So what do you do for this? There are various options. You could do a DALC, or you could try to do something that's less invasive. One of the treatments that's very preferred by keratoconus specialists is basically intrastromal corneal ring segments, or ICRS. And there are many ICRS that have been commercially available for many years. And these include Intacs, Kera rings, Ferrara rings, Mayo rings, and so many more other variants. But one thing that's common in all of these commercially available ones are that they're all made of artificial segments. They're made of PMMA or plastic, and that definitely can be dangerous because plastic is not really, it has been proven time and again that artificial or synthetic substances within the cornea do not stay there safely. So here are some of the complications. These are from my personal library, and these are things that I have seen. Here you can see the overriding and of the segments, which has actually increased with time. You can see it in anti-segment OCT also, progressive necrosis and melt of the cornea overlying the intact segments. There are different cases. This is a Kera ring with the same complication, and we had to explant all these segments. Infectious keratitis, which could even lead on to the need for a therapeutic keratoplasty. So all these really are significant complications which can keep on increasing with time. And there are more and more papers that are coming out which are talking about these complications that do happen with synthetic segments. Up to a 30% rate of reported complications. Really, it was high time that an alternative was looked for, which would still give you the advantages in terms of improvement in visual acuity, but would make the procedure much safer. So here is the trephine that I designed. I got this idea basically at one of the conferences, and I wondered why we could not use allogenic tissue to instead of synthetic segments, and how would you but prepare these allogenic segments. And the idea that I got was to make a double-bladed trephine. And here is the trephine that I designed with Madhu Surgicals, and it is currently available with Madhu Surgicals. I have a patent pending for this trephine, and here is the way it looks. This is the corneal stromal tissue that has been basically prepared, and here is a technique that I've described, which again is called CARES. First of all, what you do is remove all the epithelium and the endothelium from the donor cornea. It need not necessarily be donor cornea. It could be preserved cornea. It could be, various forms of modified corneas that are available commercially. Any of these could be used, which are available from different eye banks. And what you do is basically you take this double-bladed trephine and you use it to punch out this stroma alone, because you've already removed the epithelium and endothelium. So now you have that ring of tissue, and that ring of tissue can be further divided. As you see, you have this ring of tissue, you can divide into two halves, and then you can, these are just simple modified instruments that I've made from your cataract surgery set, and just curved it. And you can see how easily these segments can just slide into the channels. Now the channels have already been prepared in the patient's eye using the femtosecond laser, just similar to how you prepare for Intacs. And you just slide these in. So you would think that this is softer tissue and how would you be able to push it in, but really it goes in easily. And in most of the cases, if it's progressive or if it's a younger patient, I generally combine it with cross-linking. So here's a post-op patient and appearance. And you can see that here, it's a very quiet eye. You can see these two segments superiorly and inferiorly placed. And also basically a very clear visual axis in between. And here is the broad beam appearance of the same patient. You can see It's really very quiet, almost invisible segments. And even though you could see them, you can always see them, of course, with slit lamp. When you see the patient just like that, when you're talking to the patient, you really cannot make out that these segments have been placed. So it's cosmetically also, it has great results. So as we already mentioned, the disadvantages of synthetics implants can be done away with these cares. Synthetics, of course, have other problems also associated with it. The facts that you cannot implant synthetic in very advanced keratoconus simply because you don't have enough stroma in these advanced cases to lie above the synthetic segment. So if you are putting in an intact, you have to make sure that you have at least 400 microns of stroma above the intacts to prevent a melt. But this particular limitation does not exist with CARES, because CARES is allogenic tissue, and so there's no problem of melts above the cornea, and so you can implant it in very thin and very steep corneas as well. And also you don't have to go so deep as you're forced to with synthetic segments, so you can implant it more superficially as well. In fact, what I do is generally a 50% depth of implantation. It's biocompatible, biointegrable, and can be, as I said, implanted not only thinner and steeper corneas, but also another big advantage is that you can also put it in mild and early cases as well. So it covers a large spectrum of your patients, and I'll show you some mild cases as well, and you get greater effects. And also you don't have to have a huge inventory of segments. You can just have that same cut, same tissue, and implant even segments with arc length of up to 360 degrees. So you can easily vary the arc length of the segment that you're implanting. So these are lots of advantages that this particular procedure has. The indications, as I said, mild keratoconus, moderate keratoconus, advanced keratoconus. Of course, you wouldn't do it in those cases where the corneal tissue has become so thin that you cannot combine it with a CXL, but there are special techniques of thin cornea CXL, one of them described by me, which is CSCR or contact lens assisted cross-linking. So if you can do any of the thin cornea cross-linkings, yes, you could combine it with CARES and actually increase the effect of that CXL. But if if the patient is so thin that you cannot even do a CSCR, then you would do a DALC, of course. So you can also put it in other causes of ectasia such as keratoglobus, PMD, and so on and so forth. And another big advantage is you can also use it to treat the melts or migrations and other complications that have arisen secondary to synthetic segment implants. So here's a synthetic segment related melt, and you can see in comparison how different a CARES eye looks. Very quiet eye seen with a CARES eye. This is a video of how I treated this segment, and now I'm happy to say that many surgeons around the world have started doing CARES. They've been employing it for treatment of keratoconus, for treatment of synthetic segment related melts, and so on. So you can see that that is the CARES segment that's being prepared. I have cut it out, and you have different sizes of trephines also available to kind of give you different thicknesses that can be implanted. That's the area of melt. And if you look at this, the actual area of melt is generally larger, because when you remove the epithelium, you'll see the actual extent. I have pulled that segment out basically. And what we'll be doing is I've put that CARES segment on top, marked the length that I would need, cut it out slightly so that I have the thickness that I would like to have, and just push it into that original channel. I've also put sutures that anchor it in place on either end. And I've also got these bridging sutures that go over the segment just from side to side so that it doesn't pop out in the post-operative period. I've also just, as a precautionary measure, applied a little bit of fibrin glue on top, not necessary though, but you could do it, and put in a BCL, and that's basically the end of the case. And here is the patient with the suture still in place, and after suture removal about 3 months post-op, and you can see a very, very good effect, good integration of the CARES segment, the intacts on the other side still remaining there, but the CARES on this side. So post-operatively, what I give is just simply a routine cataract post-op regimen, which is basically steroids 6 times a day for 4 weeks, and then 4 times for 2 weeks. That's what I do for cataract. That's what I do here. Why no long-term steroids? Because really the risk of rejection is very low with this, because the amount of tissue that's transferred is so low, as compared to a DALC, where you put so much more of tissue. About if you actually calculate mathematically, the amount of tissue that's transplanted in DALC is between 25 to 35 millimeter cube, whereas in CARES you just transplant only 1 to 6 millimeter cube. So just that decreased volume of transfer decreases its antigenicity even more than DALC, which itself is quite not very antigenic. In addition, there's no epithelial or endothelial transfer, and it's placed far from the limbus and limbal blood vessels. There are no sutures there, and also it gets very rapidly repopulated with the keratocytes, host keratocytes. So in all these reasons add on to the decreased risk of rejection. In the worst case scenario, even if the segments do reject, that's a question that's asked to me often. What happens if the segments reject? It really doesn't matter. It's not like a rejection that happens in DALC or in PK, because here these segments are not placed in the visual axis. It's outside the visual axis. So even if the segments do become hazy or semi-opaque, it does not affect the vision at all, and the patient continues to do very well. Here are some post-ops again of the segments placed. These are when I was using a larger optic zone. I've cut down my optic zone further now, and I use an optic zone of about 5 millimeters now. This picture is courtesy of Dr. Jack Parker, who is also doing a large number of cases now in US. And you can see this is pre-op. It's a beautiful shine plug photograph from the Pentacam, which shows the difference that CARES has made, the amount of flattening that it has brought. So this is pre-op and this is post-op with the CARES segment seen there. And you can see how beautifully the cornea has flattened. If you look at the corresponding keratometric maps, you can see that the pre-op was about 83.6 or 86.5 diopters, which is really, really advanced keratoconus. And it has come down to about 62 diopters, which is a huge amount of flattening. So this patient was saved from a DALC. And that's how CARES really helps you. So here you can see the same patient, a difference map with about 25 diopters of flattening got post CARES. This is my own patient, and you can see again here it's a double CARES actually. There's one segment here and one segment here. Again the shine plug imaging, and the orange is pre-op and the blue is post-op, and you can see the flattening that's brought. We have matched the lens to the lens, so you know that this is correctly aligned. You get a lot of beautiful topographic results in these patients because that's what we are basically bothered about. So here you can see pre-op on the left-hand side and post-op on the right-hand side, and see the decrease and the regularization of the topography that's been brought about with an improvement in the uncorrected visual acuity from 624 part to 69 part, a decrease in the cylinder, and much better visual quality. So what we generally see in these patients is a decrease in regular and irregular astigmatism, a decrease in the refractive error, improvement in uncorrected and miscorrected visual acuities, improvement in topography, centralization and flattening of the cone. So these are all huge advantages that you can give your patient. Again, look at the amount of cylinder pre-op and post-op and the decrease in the topographic values, keratometric values as such, from about 54 is decreased to about 40, 42 and so on. Again, all of these are pre and post-op, and again you can see the decrease in the steepening. Again, regularization of topography in this map, much better topographies in this map. The cylinders decreased from over 7.8 to about 4.9, and here again you can see a large amount of flattening and almost a normal topography. If you look at these also, these pictures, these are the post-ops, and you can see that the CARES segment, the arc of the CARES segment can really be altered according to your wish. So in this case, I've used about 330-degree arc, here also 330-degree arc. You could make it even 360, so that's a big advantage in case of CARES as compared to synthetic segments also. Some more interesting case reports. Here's a patient who's again got a lot of flattening. Now in these difference maps, the post-op comes on the left-hand side, the pre-op is the middle one, and the difference map is on the right-hand side. And you can see from a refractive error of 5.5 and 4-cylinder 2020 part, he improved to -1 with 3-cylinder 2020 part, and those are the segments there. Here's a patient who had high astigmatism. Again, the center one is pre-op. This is post-op. And if you look at the difference map, you can see that you've got really a beautiful result, because wherever the cornea was steep, that's in almost the vertical axis, it has flattened out, and the pre-op flat axis has steepened out, which is exactly what you want, because that is what is known as regularization of the topography. The 5 diopter cylinder has really come down to a huge amount, and that has given a great advantage to the patient. Here's a single segment CARES for eccentric cones, which is basically inferiorly located cones. And you can see in the difference map, the amount of flattening that you've got here. Again, the central one is pre-op and the one on the left-hand side is post-op. Another patient, he's a stage performer actually, and he came all the way from Calcutta for treatment, went back very happy because he didn't want to wear contact lenses or glasses while he was on the stage. And now he's able to perform without any of these. You can see that from 76 diopters, it's come down to about 61 diopters, a single asymmetric segment, about 14 diopters of flattening, and a very happy patient. And this is a day one, because this patient had already been cross-linked somewhere else and he came only for the CARES treatment. This is a day one post-op. You can see a very quiet eye post-operatively. Of course, if you have combined with cross-linking, you would see some amount of the corneal haze that's associated with cross-linking in the initial few days. Here's another patient. You can see a higher degree of refractive error, 0.75 with 7 diopter cylinder, and we put in a thicker CARES segment, managed to get a much greater effect. If you look here, you've got about 6-7 diopters of flattening here, and also exactly what I spoke to you about earlier. Sorry about that. Exactly what I spoke to you about earlier, that you get a regularization, which means a flattening of the steep axis and steepening of the flat axis, leading to an overall regularization as seen here. The post-operative refraction was a much better value, which is -2 sphere with -2.5 cylinder. And he was so happy with the right eye that he opted to go for the left eye also. And if you notice, the left eye had a very low refractive error. which was only -1 and -1.25, 20/40 part he came to 20/20 part, and you can see the difference in the, the way the two segments look. So here we put in thicker segments to get a greater result, and here we didn't want as much of a result. We wanted mostly a regularization, and we got that because uncorrected improved from 20/40 part to 20/20, and you can see the segments are also much thinner in comparison. Again, a patient who underwent cross-linking and cares in the right eye, only cross-linking in the left eye. You can see not much effect in the topography in the left eye, but with cares, you've got a great flattening effect. And her improvement was from, I cannot read this, but I think 624 to 66 part or something like that. And the refraction almost came to a clear 0 with the improvement to 66 part uncorrected. So lots of different, different maps here you can see, and for lack of time, I will skip through them, but you can see that some of these are advanced keratoconus, some of these are extremely advanced keratoconus. Here's a patient who had 72 diopters of steepness, and he came down to about 60 diopters. Again, we can avoid cares in DALC in all these patients. Ashwin, here's a patient with 71 diopters, and you've come down to about 18.5 diopters here. So again, a lot of flattening. The change in segment thickness can be seen with time. A change in segment thickness, is it seen with time, is a question that's often asked to me. Really, it's not substantial in our experience, possibly because of the intrastromal location. Shape change is not a mathematical calculation and therefore not very crucial. The cross-linking actually freezes it in place. Okay, so post cross-linking, the uncorrected visual acuity is 6/60. Here in this case, as you can see here, it's improved to 6/9 part with this eccentric segment. And here again, you can see this is a kind of a lot of different softwares that can be used for planning. This is the same patient, and you can again see a lot of flattening here. And what I wanted to show you here is also the decrease in coma or the improvement in the aberrations. So here from 2.46, it has decreased to 0.76, and from 3.48 in the 6 millimeter zone, it's come down to 0.35. So really a huge amount of decrease in the coma, and that improves the visual quality. Again, here, if you look at the Zernike maps, from a 3.407 value, it's come down to 0.177. And that again, you can see even in the map here, the decrease in chromatic aberrations. CAS is a better alternative to DALC. It's a new mid-peripheral, mid-stromal anterior lamellar keratoplasty. Many patients with advanced keratoconus would require transplantation early in life, and many of them do require more than one graft over their lifetime, with increased risk of failure in the successive transplants. But CARES really avoids all this by avoiding or even at least delaying corneal transplantation. It retains and reshapes the patient's own cornea to improve uncorrected and best corrected visual acuity, does away with disadvantages and complications of a more invasive and extensive procedure that is DALC, and as a standalone procedure in non-progressive cases, together with cross-linking techniques in progressive cases, it has become an advantageous solution that is reversible, does not take away the ability to do DALC or any other treatment modality that may become available in the future. It can also be used synergistically with other treatment modalities such as topography-guided ablation or phakic IOL for those surgeons who prefer to. I think with that, I will come to the end of my presentation. Thank you so much.
Thank you. What a great presentation by Susan on the treatment of advanced keratoconus. As you have rightly pointed out, the incidence of keratoconus is gradually increasing. And one of the reasons modern with the advent of modern equipments and techniques to diagnose keratoconus is quite easy. The treatment for early keratoconus is almost fixed. But for the advanced keratoconus, CARES, that is corneal allogeneic intrastromal ring segment, has really great some advantage over the synthetic segments. And this is really boon for the advanced keratoconus patients. Various advantages, and you can use it synergistically with other procedures also. It has proven superiority over the synthetic segments. Dr. Susan, your tips have enlightened our minds and shown our new path regarding the management of these cases. My sincere gratitude to you for gracing the occasion and sharing your knowledge today. Keratoconus is becoming more common. Your views regarding the management of advanced keratoconus will surely prove to be very helpful in our practice. Thank you once again for this wonderful talk. Thank you.
Thank you so much, sir. And thank you so much, VOS, again for inviting me.
Thank you so much, Susan madam, for taking out time from your busy schedule, especially during the Christmas weekend, and also because you are busy with your children's admission process. I understand. Thank you so much for sharing your views with the Ophthalmic Society.
Thank you. Thank you so much once again.
Now we move ahead to the next award oration, that is led Dr. Nilima Paude Lifetime Achievement Award. Dr. Nilima Paude, a coveted member of our organization, met with an untimely death on 5th November 2006. Dr. Nilima Paude did her MBBS and MS Ophthalmology from GMC Nagpur. She then quenched her thirst for learning by doing her FRCS Edinburgh from UK in the first attempt. On coming back to India, she joined Lata Mangeshkar Hospital and NKP Salve Institute of Medical Science and Colleges. She was instrumental in starting the eye department there. In short time, due to her talent and dedication, she developed the eye department to such a height that it was considered as a referral center for complex eye problems by the colleagues. She was a gifted surgeon and excellent academician and teacher par excellence. She is blessed with two sons who are now pursuing their careers in animation and computer engineering. With generous donation from her husband, Dr. Milind Paude, a radiologist of repute, Vidarbha Ophthalmic Society has led Dr. Nilima Paude Lifetime Achievement Award in year 2008. This award is given to an eminent person in the field of ophthalmology who has done outstanding work. The previous award is being Dr. Babu Rajendran, Dr. Jeevan Tatyal, Dr. K.K. Mehta, Dr. Vimla Menon, Dr. Anil Kulkarni, Dr. H.S. Dua, Dr. Rajiv Chaudhary, Dr. Rajesh Sinha, Dr. Vishali Gupta, Dr. Lalit Verma, Dr. Ragini Parekh, Dr. Tanuj Dada, and in this year 2020, we are fortunate to have with us Dr. Samar Basak, on whom we have bestowed this Lifetime Achievement Award, and he will be giving his oration on Boston keratoprosthesis, my experiences. We have already sent the oration plaque to Dr. Basak sir, and he was kind enough to share a picture with the plaque for our members and for the delegates. Thank you so much, sir. I now invite Dr. Upadhyay sir, President of VOS, to please introduce our Dr. Samar Basak before he starts his oration. Dr. Upadhyay sir.
Thank you, Dr. Viral. It's my honor and the honor of the Vidarbha Ophthalmic Society to have once again another big stalwart from the ophthalmology. Dr. Samar Basak has done his MD, DNB, FRCS. At present, he is the director and founder member of the Disha Eye Hospital, Kolkata, India. He is the recipient of the 10 gold medal awards from AIOS Congress, 8 other gold medal oration and prestigious Professor L.P. Agrawal oration from AIIMS, New Delhi. Internationally, he has received the American Academy of Ophthalmology conferences, Best of Show Video Award 6 times, Best Poster Award 4 times, Best Video Award 2 times in ESCRS, and People Choice Best Video Award in ASCRS 2012. He has received the Achievement Award by American Academy of Ophthalmology in 2008, APAAO in 2011, Senior Achievement Award in AAO in 2015, Senior Scholar Award by the AAO in 2017. Dr. Basak, he is also an FRCS examiner since 2008. He has written 6 textbooks in ophthalmology. The most popular one is Essentials of Ophthalmology, 7th edition, for undergraduate MBBS students. He has 41 publications in the national and international peer-reviewed journals. He is currently the reviewer of 11 prestigious peer-reviewed journals, including Ophthalmology and Cornea Journal. He is involved with teaching and training program for Phaco, SICS, DSEC, DMEC, Boston K-Pro, One Skill Transfer course with the Orbis and Sight Life in India and Southeast Asia regions. He is a bulk Phaco surgeon. He is performing 2,500 surgeries per year, and keratoplasty is a field of interest. He is doing PK, DALG, DSEC, DMEC, Boston K-Pro. He is performing more than 350 surgeries per year. He is obsessed with DMEC in the recent year, performing close to 250 per year. In the leisure time, he is busy with his unique hobby, ophthalmophilately, ophthalmology plus philately. He has a collection of more than 650 stamps in his collection related to the ophthalmology, and has written a book entitled Ophthalmophilately, Sir, we are proud to present you.
Thank you, Dr. Upadhyay and Dr. Viral and office bearers of Vidarbha Ophthalmic Society. For this, just wait a minute. Cannot share my presentation.
Or you need to put it in
I am sharing. Just wait. Can you?
Yes, sir. Yes, sir. Perfectly.
Okay. Thank you.
You have to, yeah, that's it, sir.
Yeah. So thank you very much once again for including me in this Dr. Let Nilima Pade Lifetime Achievement Award. And I am grateful to you. My deepest respect to Dr. Nilima. And I'll be presenting my experiences on keratoprosthesis in severe corneal diseases. I do not have any financial interest to disclose. So keratoprosthesis actually started since 1789, and the history of K-pros is with riddles with failure and surgical complication. However, a set of K-pros is having very good success over past 3 decades, and these are routinely used for some severe corneal diseases. So there are basically 2 types of eyes and 2 types of K-pro. One is with wet, good ocular surface. We have Boston K-pro 1, Oro K-pro, Lucia K-pro. And when we have bad or dry ocular surface or lid problem, we have Pintucci. Now it is not available. And we have modified osteoodontokeratoprosthesis and Boston type 2 keratoprosthesis. We have also recently introduced LBP keratoprosthesis. So here is a patient, 51-year male, only eye, 6-time failed graft, 360-degree deep vascularization, 2 eyes strap done, but the patient has a good surface and lid. BCVA only PL, IOP within normal limit. So what to do next? The option is K-pro 1. And you see that this patient after 2 weeks, 636, after 10 years, is maintaining 624 with normal IOP. He has actually macular scar, so he didn't improve beyond that. This is the good prognostic cases 1. We have another group of patients like 360-degree deep vascularization, otherwise no surgery done previously, only eye. And we know that there is a poor chance of PK survival in this patient. So we have done Boston K-pro 1, and you see that patient is enjoying 6/9 and 6 vision with normal IOP. This is called primary K-pro, P3 K-pro, and this is actually good prognostic cases 2. We have another set of eyes like aniridia with 360-degree LSCD, chemical burns, thermal burns, blinding VKC, vernal keratoconjunctivitis. These are the cases where the prognosis is moderate, and we always say that these are the guarded prognostic cases. Then a group of cases which we call autoimmune group of cases. Like we know that Stevens-Johnson syndrome is one. And you see that this child eye is like this. We can do K-pro, but there is a lot of trouble and a lot of complication. Normally, we do not prefer to do Boston type 1 K-pro. Then also another group is mucous membrane pemphigoid or MMP, that is the ocular, previously called ocular cicatricial pemphigoid. Here we can attempt if the surface is relatively good and we may have a better prognosis. But when we see this type of cases, like the surface is dry, skin-like, severe keratinization, severe vascularization, lot of trichiatic eyelashes, symblepharon, etc., we need to do modified osteoodontokeratoprosthesis, Boston type 2, or other type of keratoprosthesis. If we do, like in this case, that type the knowledge was not so great, like 10 years back, I did K-Pro in this case and seen that even after K-Pro, the keratinization has progressed and ultimately this patient presents with microbial keratitis after 2 years. So there will be more chances of retention failure and more complications. So pin tissue keratoprosthesis is popularly done by Kuresh from Mumbai, and it is basically a different device, but now it is not available because of death of Pintucci. Now they have made Chavan Mascati Pintucci prosthesis, and they are using now. We have yet to see the result of this prosthesis. So Pintucci keratoprosthesis, the Kuresh has shared some of the photographs and many patients are doing well, and he has published this in 2006 in Indian Journal of Ophthalmology with a moderately good success rate. Osteoodontic osteophysis, you know that a tooth for the eye, otherwise called, it is a multi-stage procedure. That is a problem. And you need a multidisciplinary approach. You need a dental surgeon, you need MRI and several other things to do this staged procedure. It is done by only 2 people so far I know. One is Dr. Srinivas Rao from Chennai, he used to do it, and also Geeta Iyer in Shankar Nethralaya. She used to do it, and it is a total institutional procedure, multi-stage, relatively better results than other type of type 2 procedure. This again shared by Srinivas, and you see that it is so much complicated. Many people do not wish to go forward with this kind of surgery. And these are some of the photographs shared by Srinivas Rao with MOKP. Sorry. Shankar Nethralaya, they have shared, Geeta also shared their data, and you see that the success rate is good, and also the patient presents with more than 660 vision is about 52%, and 66 about 13%. And they have crossed 100 eyes over last 30 years. And this is Boston type 2. Actually, I do this kind of surgery because this is single stage surgery. Only thing that optical cylinder, which is the length of the optic cylinder is little longer so that it could come out of the lid. And these are the ultimate look of the patient. Mind that all these cases are single eye, other eye is not there. So this is the appearance after the surgery, and many patients actually do not want to do this kind of surgery because of this appearance. So these are my patients, and you see that over last 2 years I have done only 3. You see this is 1, this is 2, and this is 3. So these are the patient, and they are all happy patients. So most widely used K-Pro so far across the world is Boston type 1. It is designed by Professor Dahlman. It is FDA approved in 1992. It is made of PMMA. Recently, it is with titanium backplate. and it is the most widely used K-Pro in the world. You see that in 2002, only 50 K-Pro used across the world. And now in 2019, you see that 10,000 Boston K-Pro implanted so far across the world. So why it is so popular? Because it has the longest track record in terms of K-Pro retention and result. It is one-stage surgery under local anesthesia plus minus IV sedation or under GA. It is simpler and faster than other K-Pro procedure. It requires about 1 to 1.5 hours to complete. Visual improvement is dramatic, usually on the next day. It is the least costly in our country if you compare with other type of K-Pro, because we get at a subsidized rate from the Boston lab. Auto K-Pro is similar to Boston Type 1. Technology transferred between Boston and Auto lab, and their designs and the metrics are same. Pilot project I was a part in 2009. Initial hiccup was there, but that was solved, and since then Boston K-Pro is using like for last 8-9 years. It is our only difference is the price is about $100, whereas Boston K-Pro Type 1 pricing is about $550. It is a cost-effective alternative to K-Pro, to time-tested Boston Type 1. So there are two types of Boston Type 1. The one is aphakic or Auto K-Pro, one is aphakic type. That is for primary surgery. Power is the actual length of the eye. Like we get this type of power, we tell that we want 24 millimeter. That is all. Pseudophakic, it is a standard. It is actually in diopter. We actually replacing the corneal part, so it is 45 diopter always. But aphakic depend on the axial length. It may be 54 diopter, 58, 59, 60 diopter, something like that. And backplate. Backplate is, there are two types of backplate. One is pediatric type, which is 7 millimeter backplate with 8 holes. And one is adult type, which is 8.5 millimeter. You may see that there are 16 holes, and this to flow the aqueous into the carrier cornea. So only difficult part of K-Pro is assembly. You see simultaneous video and two types of K-Pro, both are almost same. Only little difference is that the packaging, and they give a sticker. This is very nice for Boston K-Pro, but Auto it is not there, but you can easily used in there. They give a small block of silicone, and actually you can put the thing. And the most important thing is that fitting of the titanium ring. Titanium ring is actually, you hear a click sound, and always this white called is pusher. If you concentrate on the left side, you see that this is actually the back plate, first front plate, then carrier cornea. That normally the corneal size is around 9.5 because the back plate is 8.5. And after that, this is the titanium ring. You see that you place it nicely, and with the pusher, you just fit snugly so that you can hear a click sound. And the surgery is just like a similar kind of keratoplasty surgery, penetrating keratoplasty. You see that at the end of the surgery, only thing you need to put a bandage contact lens. And this bandage contact lens actually is every month or every 2 months or 3 months, you have to change this contact lens till the patient continue it, maybe 5 to 10 years. All K-Pro requires some degree of additional surgery like crystalline lens management. We do a lot of ICC with anterior vitrectomy, ECC or with PC IOL. So we put 0 to plus minus 1 diopter lens. sometimes we need to do IOL explantation with anterior vitrectomy. We need to do iris management, only anterior vitrectomy, pars plana vitrectomy. We also additionally, we give glaucoma drainage devices. So I'll talk a little later on glaucoma drainage devices. And many cases we have to do lateral tarsorrhaphy for shorter period of time, or maybe it is a permanent lateral tarsorrhaphy in these cases. So my journey started with Boston K-Pro, started in 2009, almost 12 years. And you see that this was my first case, very good case I choose. And this lady was fine till 2 years after that she died, aged patient. And I was very excited with the success of this patient. And my recent K-Pro was done before, I have done few during lockdown period, and this was done in February. And you see that this child has actually 5 times failed graft in shade, and their parents and grandparents did not allow me to touch the left eye. Whatever you do in the right eye. And I have done the right eye surgery, and there is no place to do a repeat PK in this case. And you see that the child in the day 1 is enjoying 6/18. He recently visited, and he's actually 6/9 part vision. And now I am giving option for left eye surgery planning. So this is my first auto K-Pro in 2009, November, and you see that this was the indication, and the patient was very happy, and 6/24 vision. And this patient was happy. BCL was not in place. BCL was very important for the corneal surface, because part of the cornea is not there. It is a hole here. So this ring of cornea should get adequately epithelialized every time. So you see that there is a gap here. You see there is a gap here. So this gap actually, I was not happy. So 6/12 part vision, patient happy. I was not, 48 years male, only eye. So was this gap. And you see that after 3 months, again, he lost it. I put a Bendix contact lens and he lost to follow us. After 3 months, he come with this picture. So patient lost both the eyes. So, but the third K-Pro, April 2000, had still doing good, almost 10 years now. And he is enjoying very good vision with good optic and all these things. So we have published our paper in several journals. If you see that ophthalmology journal, they have a report on K-Pro in 2015, and they have that only the 45 to 80%. This is a meta-analysis. Have 6/60 or better vision, and 6/12 or better vision in 11 to 39%. K-Pro retention rate, depending upon the follow-up period, is 65 to 100%. Commonest complication is RPM, then glaucoma, endophthalmitis is also there, and sterile vitritis. These are, and stromal melt is also another important complication. So we have published our data because as it is a small number in individually, we always combined with other multicentric trial, and also the California, UCLA, we published our different series and different period of time. So complication, as I said, that you see that K-Pro is good, almost total cupping, temporal island. These are initial. We didn't know actually how to manage. This was in 2009, 10, 11, like this. You see that auto K-Pro, everything is fine. The patient has total optic cupping and no perception of light. So in the glaucoma, the dictum is, when the patient is a primary patient, it didn't receive any kind of glaucoma preoperative or didn't suspect any glaucoma. So we, from the very first day, we advise anti-glaucoma medication. Whereas if a patient is having a known glaucoma on one drug, two drug, whatever may be, you have to give simultaneous or prior, you have to give glaucoma drainage device. I prefer Ahmed glaucoma valve. Stromal melting, as I said, this is also another complication mostly seen in immunological problems like Steven Johnson, MMP or VKC patient. And you see that similar stromal means no infection that way. And we actually replace the K-Pro second time and that man is going good. But the most dreaded complication is the infective complication. You see that patients sometimes miss the follow-up and fungal colony grows over the contact lens. You see the contact lens. Then there are bacterial keratitis. So it happens between 6 months to 2 years, and sometimes patient comes with endophthalmitis, severe kind of endophthalmitis. In fact, it is a kind of panophthalmitis because cornea is also involved. The risk factor is persistent epithelial defect. As I said, BCL is one of the issue, poor patient follow-up compliance and poor patient selection. These are important. So there are some problem with the distant patient because they cannot come timely, and political unless social problem, there is a definite relation. Out of 21 infection, almost it is in my hand, it is 18 to 19%. 10 are from other state or other countries, wherever. So there is one infection. So in Bangladesh, I got a lot of infection, and during COVID time, I got 2 infection. So you see that unless the patient are compliant for follow-up, or you have a very good colleague who can take care of that particular patient, it is very difficult to continue treatment in this, and they come with this kind of picture. So Boston K-Pro since March, I have done around 148. Overall Auto K-Pro and Boston. Boston is just 101 crossed, and Auto is 44. Re K-Pro is 14. Type 2 is I have done 3. So during this 11 months period, I have learned so many things, so many additional terminology. I know that the meaning is different of this terminology for Boston K-Pro patient, unlike a PD in normal subject and persistent epithelial defect in a Boston K-Pro, they are different. So I also have learned that case selection is one of the important things we need to learn. So in my series, the retention rate is 64%. Follow-up 1 to 130 months with a mean of 58 months. Recently, I am changing my dialogue, like in cardiac stent surgery or other surgery, they used to take about the 5-year survival. So I used to talk about 5-year retention failure or functional rate. So I say that it is 50-50 chance. So you don't think that patient, unless they counsel in this way, they always blame you. It will not go lifelong. It will stay for 5 years, 50%. It may go up to 10 years. I have only experience of 12 years, so I cannot tell whether it can go up to 20 years. So this is hard reality. The K-Pro learning is going on. Every surgery is different. Every surgery is technically challenging. It is a new learning going every day. So this is my favorite slide. I always show and tell this. You see 3 circles. One is surgery. Second one is case selection. Third one is follow-up. You see the size of this circle. And I always compare this Boston K-Pro as a whole with a marriage. So like marriage, K-Pro surgery is relatively easy. You just go and marriage. It is an event. So you just marry. It is surgery, anybody can do penetrating keratoplasty, especially the therapeutic keratoplasty. They can easily do post-on type 1 any day. Case selection is like partner selection. It has a little bigger role. So you need to select the right case from the very beginning. Then there will be problem. Third is the keeping the honeymooning period for a longer time is the biggest challenge. So we know that follow-up is the most one important part of overall K-Pro surgery. So unless the patient follows up with you, it is a lost case. So these are my two lovely ladies. One is I operated at 3 years of age, and now she is 11.5, and she is having only 636 vision. You see the smile. And this is my K-Pro 2 case, 72 years lady and 1.5 years, vision 6.9. And see the smile of both the faces. Both are, the only seeing eye is the K-Pro eye. Thank you very much for your patience hearing.
Thank you, sir. What a great talk on Boston keratoprosthesis. Frankly speaking, this topic was new and details regarding the Boston keratoprosthesis was unheard by many of us. The Boston keratoprosthesis has revolutionized the treatment for autoimmune diseases like Stevens-Johnson syndrome, cicatricial ocular pemphigoid, advanced chemical burn, and thermal burns. You have nicely elaborated various keratoprostheses, various indications, and rightly pointed out that the doing the surgery doesn't complete your job, but the follow-up and maintenance of follow-up is very important. I would like to thank Basak sir for providing the fantastic feast of knowledge. Today's day is really full of learnings. I am glad to have Samar Basak sir to share his knowledge with us. Everybody was listening to you very carefully, and we all really enjoyed your teachings. It was really a great experience. I would like to thank from my bottom of my heart. Looking forward to hear you once again on newer topic. Thank you, sir.
Thank you. Thank you once again.
Thank you, Khandewale sir. So the next talk is, our next oration is on VOS Young Achiever Award. Just a second. So our next award is VOS Young Achiever Award, instituted in 2013 from the savings of Drishtikon 2010 VOS conference. The award is given to young ophthalmologists less than 40 years doing exceptional work in the field of ophthalmology. The previous awardees were Dr. Dulani, Dr. Sabyasachi Sengupta, Dr. Sayandas, Dr. Srinivas Joshi, Dr. Rupesh Agrawal, and this year in 2020, we are awarding this to Dr. Jay Chablani, who is joining us from Pittsburgh, USA, and he will be speaking on this, the topic of central serous chorioretinopathy, newer classification. Before Dr. Upadhyay sir, President of VOS, introduces him, we are joined by AIOS President Padma Shri Dr. Mahipal Sakdev sir, so I welcome him. We are also joined by Dr. Ragini Parekh Madam, our national faculty. We welcome you all. Dr. Upadhyay sir, please introduce Dr. Jay Chablani.
Thank you, Dr. Viral. It's the honor of the Vidarbha Ophthalmic Society to introduce Dr. Jay Chablani. He is a MS, FMRF, and ICO in the retina and ocular oncology. At presently, he is an associate professor of ophthalmology in the University of Pittsburgh Medical College, Pittsburgh, USA. Uh, Dr. Jay Chablani is a vitreoretinal specialist at the University of Pittsburgh Eye Center, Pittsburgh, USA. Uh, he has completed a clinical vitreoretinal fellowship from Shankara Netralaya, Chennai, India, and has won an International Council of Ophthalmology Fellow at Gonin Eye Hospital, Switzerland in 2009. He was a clinical instructor at the Jacobs Retina Center at Shiley Eye Center, University of California, San Diego, USA from 2010 to 2012 before joining the faculty at LV Prasad Eye Institute, Hyderabad, India from 2012 to 2019. His areas of interest are macular disorders and recent imaging techniques. He published more than 350 articles in the peer-reviewed journals with a focus in the field of choroid. He is the editor of books Choroidal Disorder and Central Serous Chorioretinopathy. He is on the reviewing boards of all high impact journals, including Science Translational Medicine. He is also an edit on the editorial board of several journals, including American Journal of Ophthalmology. He is a member of Macula Society and also a member of various committees in international societies, including the American Academy of Ophthalmology. He has won several national and international awards and delivered inaugural Ian Constable Lecture at Asia Pacific Vitreoretina Society in 2016. He received inaugural Nam Perumal Swamy Young Researcher Award in 2018 presented by Vitreoretinal Society of India. So I proudly present one more stalwart from the field of ophthalmology, Dr. Jay Chablani.
Good morning, everyone. Thank you so much for the kind introduction, respected Upadhyay sir. Thanks, Dr. Viral. Thanks, Dr. Kandalwa, and overall VOS Society for giving me the opportunity to speak about some of my research. I'm very honored to receive this Young Achievement Award, and I see that many people before me have contributed significantly in this field, and this is very encouraging for the younger generation. So I'll go ahead and share my screen, and if I hope everybody can see my screen.
Yeah. It's
All
fine.
right.
Yeah.
All right, so I'll be talking about the multimodal imaging-based central serous chorioretinopathy classification, which we have recently introduced. These are my financial disclosure, but none of my financial disclosure are with this presentation. So as we all know, central serous chorioretinopathy is a very common disease, particularly in India, and that is where my interest started in this disease. It usually presents in young males, and we believe that it has an association with steroids and type A personality. And unfortunately, we all think that this is a self-resolving condition, but we all have learned over the years that this is a chronic disease as well. So if you really look at the typical classification of CSCR, which we have been doing over many decades, is that we conveniently divide our patients with, if they have complaints of less than 3 months, we call that as acute, and if they have more than 3 months of complaints, we call them as chronic CSCR. However, we understand that we are still not utilizing the most of the information which we have available. We are still not using any of the multimodal images in classifying these diseases. Just on the basis of patient's complaint, we call this as acute or chronic. So I'm just going to share some of the interesting work which we published in early 2018 with the publication in BJO with the title Discrepancy in Current Central CSCR Classification. I'll just take you a little bit into this paper. In this research, what we did was we picked up 100 eyes with CSCR and distributed among 6 masked observers. And you can see that most of these 6 masked observers are very well renowned in this field. They have contributed significantly in the CSCR literature. So we asked them to see these cases and classify these cases, and you will be surprised to see that we found a very poor agreement for the classification. The fleece kappa was only 0.134. So you can understand the classification which we have right now is not consistent. It is not reproducible. Just to surprise you more, just look at this graph and you will be surprised to see that there were more than 200 and more than 100 terminologies which people used for these cases, ranging from acute or chronic, which is still okay, but some of them used terminologies like chronic persistent, acute on chronic, resolved, acute persistent, multifocal acute on chronic. So you can see that there is no consistency in giving a class to any of the patients which come to our clinic. To give you an example, this is an example of a 56-year-old man who presents with a visual acuity of 0.9 with a duration of 12 months. 4 observers believed it is a chronic CSCR, 1 observer said it is a recurrent CSCR, and 1 suspected this to be an acute CSCR. Another case of a 60-year-old man who had a visual acuity of 0.83 with a duration of 6 months. This could easily go into a chronic, considering it is a 6 months duration. So 3 of them called this as a chronic CSCR, 2 called acute CSCR because the shape of the SRF was suspecting to be an acute CSCR, and 1 observer called this as an acute recurrent CSCR. So you see that there is such a discrepancy for such a common disease which we see every day in our clinic. So what is missing in the conventional classification for CSCR? As I described, there is no clear definition. We still don't know what is happening with the extrafoveal leaks with no ocular symptoms. Is there any difference between a non-resolving or a chronic CSCR? There is no discussion about CNV associated with CSCR. We don't talk about bullous exudative detachment, which we see so often in India. And the most important part is that we are still not utilizing multimodal imaging, which is now the backbone in our retina clinics. So definitely there is a need for a new classification for CSCR, for which I have been working since 2015. To start with, we made a CSCR international group, more than 20 experts around the world. As you can see, from all parts of the world, we had more than 20 people. They all have contributed significantly in the CSCR literature. Many of them have came up with imaging findings. They have contributed significantly overall in understanding the CSCR. So we all worked for almost 4 years. We had 2 in-person meetings, n number of emails and phone calls and the video conferences. And then we recently published our multimodal imaging based CSCR classification, which came last month in Ophthalmology, which is the Journal of American Academy of Ophthalmology. So before we really get into the CSCR classification, we wanted to establish the diagnostic criteria for CSCR. So we came up with a major criteria, which the patient has to have both of these criteria, that is presence or evidence of prior SRF, documented on OCT involving the posterior pole unrelated to any other disease process. Look at the bottom, you will see that many of our CSCR are misdiagnosed as CSCR, though they have a dome-shaped macula or a staphyloma-related maculopathy or uveal effusion syndrome. So first thing is that we have to rule out these diseases which are called as CSCR masquerade. And once you have established that this SRF is not because of these diseases, that is your first criteria in the major criteria. Then the patient has to have the one of the minor criteria, that is the mid-phase hyperfluorescent choroid areas on ICGA, or 1 or more focal leaks on fluorescein angiography, or the subfoveal choroidal thickness should be more than or equal to 400 microns, considering the age and axial length of the patient. So let's move on with the classifying the CSCR. The first thing is that you classify CSCR into simple and complex, which is based on the total area of RP alteration. If it is less than 2 disc area, then it is a simple CSCR. Or if you have a more than 2 disc area or multifocal RP changes, then it is a complex CSCR. Or you can have an atypical CSCR. Atypical CSCR could be a bullous variant or a CSCR associated with a large RP tear or any other associated retinal diseases. Let's go back into the simple CSCR. As soon as you decided that it is a simple or complex, then you talk about what kind of presentation is this. Is this a primary case, which is like the first known episode? Or if it is a recurrent case where you can see the SRF with history or signs of resolved episode, or you see it is a resolved CSCR, that is, there is no SRF, but there is an evidence. Then you talk about whether it is a persistent CSCR, whether it is a more than 6 months or less than 6 months. Then you look at the OCT more carefully, look for the outer retinal changes, and then you need to look for the CNV, whether there is a CNV present or not. Just to bring your attention to the bottommost part, that if your fovea is involved, then you give a plus sign, because that is going to define the visual acuity outcome. This is something which we are currently working on. So this is a simple algorithm to classify CSCR in your clinic. As soon as you are suspecting CSCR, your first job is to divide them into a typical or atypical, which is very simple because atypical is bullous variant or RP tear or association with any retinal diseases. Once you have made sure that this is a typical CSCR, then you look at the total area of RP alteration, either on autofluorescence or on IR or on OCT. We understand that it is impossible to have all the modalities. So that's why we wanted to be more flexible in terms of the non-invasive methods of understanding the RP alteration. That's why you can look at the RP alteration either on autofluorescence or on IR or even on OCT. If your RP alteration is less than 2 disc diameters, then it is a simple CSCR. And then, like I explained, that then you look at the SRF. And if SRF is not there, that is, it is a resolved CSCR. If the SRF is present, then you need to talk about whether it is a primary CSCR or a recurrent CSCR. Then you think about whether it is a sporadic case or a persistent case, because these are various terminologies which are eventually going to define your treatment strategy and treatment outcome. And going back to the RP atrophy, and if your RP atrophy is more than 2 disc area, then we will call this as a complex CSCR. Then you go and discuss the same thing about SRF, outer retinal atrophy, intraretinal fluid, which is definitely a sign of a complex CSC, and presence or absence of CNV. So I would say that what are the strengths of this classification? We feel that this is a pretty objective way of looking at CSCR and classifying it. The best part is that we have utilized all the multimodal imaging which we are using in our clinic, because this is definitely important to understand the treatment plan or the outcome in these patients. We have a couple of studies going on with various groups where they have validated this classification with almost correlation kappa of 0.87 to 0.92. With this data is under review, and we have noticed that this is a reproducible classification. Right now, we have submitted a paper where we are correlating this classification with visual acuity, and we found that this classification is pretty correlating with the visual acuity. And we found that outer retinal atrophy and the foveal involvement are the 2 parameters which correlate most with the visual acuity at presentation. However, we understand that there are still many challenges with this disease. We know that this can have a varied presentation because the CSR always surprises us. We do notice that we did not include OCT angio, which is up and coming technology in our clinics, just because we are still unsure about OCT angio and the reliable data from this. That's why we did not include OCT angio right now in our classification. However, I'm sure that in a few years, we will be including OCT angio, particularly in evaluating CNV and classifying CNV in this disease. And as you might have noticed that we did not include the term pachychoroid, in spite of having Bailey, Froh, and Rick Spade guys in the group who have actually given the terms pachychoroid. We just wanted to keep this word away from this classification because we still have a lot of controversies about this term, and we are yet to understand this term, particularly in normal healthy population. We know that we have not there is definitely an influence of the fellow eye, because we aren't sure that how reliable this classification is going to evaluate the fellow eye. We are doing some studies where we are trying to understand that how the fellow eyes should be classified. And as we understand that many of our patients are present to us as a CSCR, we are unsure that how this classification is going to get influenced by systemic medications or systemic diseases. Overall, I would like to conclude by saying that we are glad that now we have one objective, validated, reproducible, multimodal imaging-based classification. We are really looking forward to everyone to start using this classification in the clinics, and I am very much available to receive any feedback. We are really ready to learn and make it better. I'm sure that there is no perfect classification for anything, but there is always a way to improve. And we are really looking forward to work on the future steps in establishing the treatment guidelines for this complex disease. I would like to thank all of you for listening. And if you are interested in understanding this classification more, I would highly recommend to go and read this editorial in Ophthalmology Retina, which describes this classification in much more detail. Thank you so much for this opportunity again, and I'm honored to receive the Young Achievers Award, and I hope you enjoyed listening to this talk. Thank you so much for your kind attention.
Jay, CSR is a very common problem for anterior and posterior segments. A famous quote is, "Patient sees nothing and doctor also sees nothing." But the newer classification has simplified the diagnosis of it. My sincere thanks to you for sparing this type and giving this opportunity to hear you the simpler classification. This will be particularly helpful for the PG students and the fellows who are doing VR fellowship. We are looking forward to hear for future step, that is management guidelines also. So concepts regarding newer classification were really informative. I'm pretty sure that precious knowledge of Jay Shavlani gave us definitely help us in our private practice to understand and manage the CSCR cases. Thank you very much, Jay.
Thank you so much for your.
Thank you so much, Dr. Jay. Thank you, Khandewale sir. So that concludes our VOS Awards and Oration ceremony. Dr. Jay, we cannot present to you a memento in person. So once the pandemic is over and you are able to visit India anytime, please do call the VOS office bearer. We will be happy to join you and give it to memento to you in person also. So now over to our next program, that is the inaugural ceremony. And I request the organizing committee of Akola Academy of Ophthalmology and VOS-VRCON 2020 to please start the inaugural proceedings. We are joined with our guests of honor, Dr. Mahipal Sakdev sir, Dr. T.P. Lane sir, and also our chief guest, Dr. Dhotre sir, has also joined us. So I welcome all the respected, our president of Maharashtra Ophthalmic Society, Dr. Parikshit Gogate sir is also there. We are joined by Dr. Amar Agrawal sir, our star national faculty from Chennai, and all our national faculties are here. So I think without wasting much time, over to the master of ceremony, and we should start with the inaugural ceremony.
Thank you, Dr. Viral sir. So it's time to welcome our chief guests and to inaugurate the culinary delight that has been carefully crafted by our VOS master chefs. In view of important appointments ahead for one of our chief guests, Member of Parliament, Sanjay Ji Dhotre, we shall be reshuffling the schedule of events for today. And without delay, I would request my colleague, Dr. Our chief guest, Dhotre sir.
Our today's chief guest Shri Dr. Sanjay, our today's chief guest Shri Sanjay Ji Dhotre is hailing from Palsobade district of Akola. He is a parliamentarian, agriculturist, engineer, and an industrialist. He has remained active in social and political life since last 4 decades, making his mark on all important positions held in fields ranging from academics to agriculture. His special interests are infrastructure development in rural and semi-urban areas, water conservation, organic farming, yoga, and personality development. Spirituality and reading are his hobby. Over to you, sir, for a few words of wisdom on this occasion.
Good morning, everyone. Welcome, Lahane sir. Welcome, Ragini ma'am. Madan sir, welcome.
Good morning to all. If he is yet to join, Master of Ceremony can proceed with the further agenda. As soon as he joins, we will take his talk. Yes.
Till now, I request our esteemed guests, Dr. Padmashri, Professor Mahipal Sajdev, Padmashri Professor Dr. T.P. Lahane, and special guest as Dr. Ragini Parekh, Parikshit Gopte sir, and Dr. Amar Agrawal, to accept our virtual welcome.
Dr. Nitin Upadhyay,
Thank you.
President of VOS, to have a seat on the dais, please.
Let me invite the VOS Secretary, Dr. Ajay Khandewale, to have a seat on the dais.
Of Scientific Committee of VOS, Dr. Viral Shah sir, and VOS Treasurer Dr. Neha Deshpande to join virtually.
I request the Secretary to the MOS, Dr. Shirish Thorat sir, to have a seat on the dais. I also request the Chairman of Organizing Committee, Dr. Prashant Ladda, to have a seat on the dais.
Let me invite the Secretary of Organizing Committee, Dr. Rajesh Shugle, to the dais.
I also invite the President of Akola Academy of Ophthalmology, Dr. Lahore, Secretaries of AO, Dr. Anand Shivare and Dr. Wadhwani, to have a seat on the dais.
Yeah, Masters of Ceremony, I think the Honorable Minister, Union Minister, Shri Sanjay Ji Dhotre has joined us. So if he is ready, we can take his address. Sanjay Ji Dhotre.
Namaskar.
Namaskar, sir. Welcome.
नमस्कार, माझा आवाज येतो?
येस सर. नमस्कार सर.
नमस्कार, कशा आहात?
बस मजेत सर. कशा आहात सर?
येतो आवाज येतो, तुमचा आवाज येतो. नमस्कार
सर. नमस्कार. आजच्या या कार्यक्रमाला उपस्थित डॉक्टर महिपाल सचदेव, पद्मश्री डॉक्टर तात्यारावजी लहाने, VOS प्रेसिडेंट डॉक्टर नितीन उपाध्याय, सेक्रेटरी VOS डॉक्टर अजय खांदेवाले, चेअरमन ऑफ सायंटिफिक कमिटी डॉक्टर विरल शहा, VOS ट्रेझरर डॉक्टर नेहा देशपांडे, MOS सेक्रेटरी डॉक्टर शिरीषजी थोरात, चेअरमन ऑफ ऑर्गनायझिंग कमिटी डॉक्टर प्रशांत लड्डा, सेक्रेटरी ऑफ ऑर्गनायझिंग कमिटी डॉक्टर राजेश उगले, प्रेसिडेंट AO डॉक्टर श्रीराम लावळे, सेक्रेटरी ऑफ AO डॉक्टर अनंत शेवाले and डॉक्टर सनी वाधवानी, उपस्थित सर्व मान्यवर, मी सर्वप्रथम आपण विदर्भ ऑप्थल्मिक सोसायटी त्याचे सर्व 478 मेंबर आपलं सर्वांचं मी अभिनंदन करतो. आपण अनेक जे उपक्रम राबवता या प्रसंगी आपलं कार्य किंवा तुमच्या कार्याचं महत्व याबद्दल मी काही सांगणं हे काही संयुक्तिक होणार नाही, परंतु आपण अनेक जे उपक्रम राबवता विशेषतः विदर्भ आणि महाराष्ट्रात आपल्या क्षेत्रात जे कार्य झालेलं आहे ते खरोखरच संपूर्ण आपल्या देशाला प्रेरणादायी ठरेल असं कार्य वैद्यकीय क्षेत्रात सध्या तरी अशी परिस्थिती आहे की सर्वात जास्त आदरानं तुमच्या क्षेत्रात काम करणाऱ्या सर्व डॉक्टरांचं अतिशय आदरपूर्वक नाव घेतलं जातं आणि तुम्हाला मार्गदर्शन करण्याकरता डॉक्टर तात्याराव लहाने सारखी जी व्यक्ती आहे ती जवळपास गेल्या 3 दशकापासून त्यांनी जे कार्य केलं आणि त्या कार्याची पावती म्हणून त्यांना जे पद्मश्री पुरस्कार मिळालेला आहे, मला असं वाटते की तात्याराव लहानेंपेक्षा त्या पद्मश्री पुरस्काराचा सन्मान तात्याराव लहानेंना तो पुरस्कार मिळाल्यामुळे झालेला आहे. आवाज येतो का माझा?
येस सर.
नीट ऐकू येत आहे सर.
ठीक ठीक ठीक. ओके. जवळपास आपले 10 ते 11 महिने जे आहेत ते कोविडची जी अनन्यसाधारण परिस्थिती होती आणि त्या परिस्थितीतही आपण स्वतःचा जीव धोक्यात टाकूनही जी रुग्णसेवा केली आणि मला असं वाटतं की मी असं म्हणणार नाही की वैद्यकीय क्षेत्रातील इतर मंडळी काही काम करत नाही, परंतु जेवढं सामाजिक कार्य विशेषतः आदिवासी ग्रामीण भागातील लोकांकरता आपण जे कार्य करता ते खरोखरच अभिनंदनीय आणि स्तुत्य असं कार्य आहे. मला असं वाटतं की यामध्ये अजून सुद्धा थोडस समाज प्रबोधन, लोकजागृती होण्याची अत्यंत गरज आहे. विशेषतः आपल्याकडे जे नेत्रज्ञानाचा जो विषय आहे त्याबद्दल अजूनही पाहिजे त्या प्रमाणात लोकांमध्ये जागृती झालेली नाही. काही लोकांनी त्यामध्ये अतिशय चांगला पुढाकार घेतला आणि त्यासोबतच डोळ्याचं आरोग्य सांभाळण्याकरता जे काही प्रबोधन व्हायला पाहिजे, अनेक लोकांना लहानशा कारणामुळे, कारण की मी काही ठिकाणी पाहिलेलं आहे की आपल्या देशात काही जिल्ह्यांमध्ये एवढं चांगलं काम झालेलं आहे कोणीही मोतीबिंदूचा रोगी सापडत नाही, एवढी तिथे जागरूकता आलेली आहे. तर तशाच प्रकारचं कार्य आपल्या इथे जर झालं तर एक अतिशय चांगली परिस्थिती निर्माण होणार आहे. तुमच्या निश्चितच आमच्याबद्दल काही अपेक्षा असतील आणि जे कोणी सत्कार्य करतात त्याला आपोआपच अनेक सहकार्याचे हात पुढे येतात. आणि मला असं वाटतं की विदर्भ ऑप्थॅल्मिक सोसायटी असेल, महाराष्ट्र ऑप्थॅल्मिक सोसायटी असेल, यांना निश्चितच तुमचा कोणताही जरी उपक्रम असेल तर त्याकरता एक भारत सरकारचा प्रतिनिधी म्हणून आणि आपल्याला डॉक्टर तात्याला लहाने साहेबांसारखा एक मार्गदर्शक सुद्धा आहे. कोणत्याही विपरीत परिस्थितीत कसं काम करावं, कारण की महाराष्ट्रात त्यांच्या नेतृत्वाखाली या वर्षी जी कोविड सारखी महामारी आली त्यामध्ये अतिशय सक्षमपणे त्यांच्या नेतृत्वाखाली आमच्या संपूर्ण वैद्यकीय अधिकाऱ्यांनी, पॅरामेडिकल स्टाफ असेल किंवा तुमच्यासारखे जे प्रायव्हेट प्रॅक्टिशनर आहेत त्यांनी सुद्धा अतिशय चांगलं काम त्यांच्या नेतृत्वाखाली केलं. त्याबद्दल मी त्यांचं या प्रसंगी अभिनंदन करतो. आणि आपण लोकांनी जी इच्छा व्यक्त केली की समाजाकरता विशेषतः ग्रामीण भागात आदिवासी क्षेत्रात जाऊन कार्य करायची, तर निश्चितच शासन आणि आपली सोसायटी दोन्ही मिळून एक चांगल्या प्रकारचं कार्य झाल्याशिवाय राहणार नाही. आपण मला आजच्या प्रसंगी बोलावलं त्याबद्दल मी आमचे अध्यक्ष, समितीचे सर्व सदस्य, पदाधिकारी यांना पुन्हा एकदा धन्यवाद देतो. आणि आपला हा जो उपक्रम आहे याला माझ्या मनपूर्वक शुभेच्छा देतो. आणि आपल्याला सर्वांना आता नवीन वर्ष 2 दिवसांत सुरू होणार आहे, त्या नवीन वर्षाची शुभेच्छा देतो. आणि परत एकदा सर्वांना नमस्कार करून आपली रजा घेतो. धन्यवाद. नमस्कार.
धन्यवाद श्री धोत्रे साहेब.
Thank you, sir.
Over to the Master of Ceremonies, please. You have to unmute yourself, Master of Ceremonies. Master of Ceremonies, please. You are on mute.
So now let's begin by having a bite of the efforts taken by the Master Chef of today's feast, the Chairman of Organizing Committee, Dr. Prashant Ladha. Over to you, sir.
Good morning to one and all. Myself, Dr. Prashant Ladha, I feel extremely honored and privileged to welcome all the speakers, seniors, everyone present here, and who have joined us virtually in this chilly Sunday morning to grace this auspicious occasion of 45th Annual Convention of Vidarbha Ophthalmic Society, hosted by Akola Academy of Ophthalmology. In this challenging and uncertain COVID-19 times, life have really changed a lot and everything has taken a different shape. We all had fear of uncertainty in our minds about hosting this conference virtually, but we had a better, greater faith and hope to do the same. As you know, faith could move mountains. So we have come with a new format that is virtual come real conference of this Vidarbha Ophthalmic Society under the able leadership of Dr. Nitin Upadhyay and his dynamic team. Conference is sharing our clinical knowledge and skill and our unending zeal to learn. So we have stalwarts of ophthalmology as an eminent speaker to fulfill our quest of knowledge. Not taking too much time, I would like to thank from the core of my heart our chief guest for inaugural function, Dr. Shri Sanjay Dhotre, Member of Parliament and Union Minister, Government of India, for gracing this occasion. Our gurus, whom we just not admire but really worship, Dr. Mahipal Sajdev and Dr. T.P. Lahane sir, for gracing this occasion. I once again welcome you all to this 45th Annual Convention of VS and thank you for making it a grand success.
Thank you, Prashant. The kitchen is now off.
Good morning, all. Honorable Sri Sanjay Dhotre, Member of Parliament and Union Minister, Government of India. Honorable Padma Shri Dr. Mahipal Sajdev sir. Honorable Padma Shri Dr. T.P. Lahane sir. My respected Dr. Parikshit Gokte, Honorable Professor Mahipal Amar Agrawal sir, our respected scientific chairman, Maharashtra Ophthalmic Society, Dr. Ragini Parekh madam, the dignitaries on the dais and off the dais. I welcome you all to the inaugural ceremony of the 45th annual Vidarbha Ophthalmic Society conference. We have organized it in a virtual and on a Zoom platform and physically in Akola. As a president of Vidarbha Ophthalmic Society, I was a little reluctant to have a virtual conference. But as the technology is advancing and we are having so many advancements, so we decided to have it in a virtual form. But on my call that we should have in partly in a physical form, so the delegates from the Akola and the nearby Akola can join physically. So I thank you, the Akola Academy of Ophthalmology, for accepting and working hard to make it a successful conference. Because of the virtual platform, we have the honor to have the galaxy of the speakers, star faculties from India and abroad. Also, we have the honor to have Honorable Shri Sanjayji Dhotre, Honorable Honorable President of VOS, Dr. Mahipal Sachdev sir, my Guru, Honorable T.P. Lahane sir, also Dr. Ragini Parekh madam, Parikshit Gokte, Professor Amar Agrawal sir, to have virtually present in the inaugural function. And we are also honored to have for the oration big stalwarts from the field of ophthalmology who are known nationally and internationally. Dr. Kalpana Narendran ma'am, Dr. Samar Basak sir, Dr. Susan Jacob ma'am, and Dr. Jay Chablani from USA for the oration. This was possible because it was a virtual conference. So in future also, we can have this virtual plus physical conference. So it saves a lot of time for the faculties to come and also for the delegates who can't be there physically present in the hall. But my insist on the physical conference, partly physical conference will be there as all the delegates from home who are logging are not that much attentive. So, so the physical presence is also must who can come easily for the conference. As a part of the Vidarbha Ophthalmic Society, we had started a screening program, school screening program in the Melghat district area. We had done the screening, school screening for 2 or 3 times, but because of the COVID-19, we have to stop the project. But after the situations are normal, we will again, once again, we will start the program with the help of the Vidarbha Ophthalmic Society and Maharashtra Ophthalmic Society. So my tenure will end in a few months, but for the project and for the benefit of the poor patients, with the association of the Vidarbha Ophthalmic Society and Maharashtra Ophthalmic Society, I will continue the charity work in future. I wish you all a COVID-free and a joyful 2021. Thank you.
Thank you, Dr. Upadhyay. The real nutrition holds a prominent place, and so is Dr. Viral as scientific committee chairman. So let's spice up the dish with his address. Over to you, Dr. Viral.
Thank you. Thank you. Wonderful MOCs for today. Good afternoon, everyone. Respected Chief Guest, Honorable Union Minister Shri Dhotreji, Guests of Honor, President of AIOS, Padma Shri Professor Dr. Mahipal Sachdev sir, Padma Shri Dr. T.P. Lahane sir, President of Vidarbha Ophthalmic Society, the Organizing Committee of VOS-VRCON 2020. All the national faculties who have joined us, Dr. Amar Agrawal sir, Dr. Ragini Parekh madam, Dr. Parikshit Gokate sir, and all my seniors, friends, and colleagues. It is really a great privilege for me, Dr. Viral Shah, as a chairman of Scientific Society of Vidarbha Ophthalmic Society, to welcome you all for this academic and scientific feast of VOS-VRCON 2020. As you all know that due to COVID pandemic and various government regulations, we have to take this hybrid conference predominantly in the virtual form. We had many hiccups and doubts at the starting about how to conduct this conference. But once the president of Vidarbha Ophthalmic Society, Dr. Upadhyay sir, gave the go-ahead for the hybrid form, we did not look back. The results are there in front of you, all of you, to see. 3 days of program, we had to make 7 sessions, including cataract, refractive surgery, and all the allied subjects. 15 national faculties, 30 VOS faculty talks, 13 surgical videos by members of our VOS for competition, 26 e-posters, 38 free papers, and 4 awards and oration. All were done, and we did not have to compromise on any of the scientific aspects of this conference. We had more than 388 pre-registered delegates for this conference, for which MMC has granted 4 credit hours. And also this conference being beamed live on Facebook and YouTube channel, where more than 1500 hits were there yesterday, and today it is expected to cross more than 2000. I am extremely thankful to the Executive Committee of Vidarbha Ophthalmic Society, the Supervisory Board, and the Organizing Committee of Akola Academy of Ophthalmology for providing a free hand to the Scientific Committee for taking ahead its programs. I must acknowledge the help and support of my Scientific Committee members, Dr. Rajesh Ugale from Akola, Dr. Naveen Soni from Amravati, and Secretary of Scientific Committee, Dr. Shamik Mukaddam from Nagpur. I am most thankful to the advisory board members of Scientific Committee, Dr. Shubhangi Bhave Madam, Dr. Prashant Bhawankude sir, and Dr. Rajesh Joshi sir for their guidance, support, and constant motivation throughout, without which this scientific program would not have been possible. Thank you everyone. And just before I leave, an important announcement: awards and prizes for various competitions for our viewers members will be declared during the valedictory program, expected to take place around 3 p.m. Thank you, MOCs, and thank you.
Thank you, Dr. Viral. It's time now to introduce the soul of our today's feast, the guest of honor, Padma Shri Professor Dr. Mahipal Sachdev. He has graduated and post-graduated from the prestigious All India Institute of Medical Sciences. He showed his academic excellence since his residentship and topped in his MD exams. After working for a few years as a faculty member in AIMS, he stepped out with a dream of creating a world-class hospital. Center for Sight is an outcome of that. He is a visionary and a leader. He has always been the torchbearer in the field of eye care, pioneering several procedures, including laser-assisted bladeless surgery for cataract and LASIK. He was among the first to introduce LASIK and phakic IOLs. He has pioneered blade-free femtocataract and femtosecond laser technology for LASIK. He has adored many positions in Delhi Ophthalmological Society, and currently he is a president to the AIOS. He is the Indian representative at the Asia Refractive Council and has over 100 published articles to his credit. Apart from being worked on editorial board of various journals, he has authored over 10 books on cataract and refractive surgery, which are referred by every budding ophthalmologist. He is an active contributor of articles on eye health in mass media for the benefit of general public also. He has been recognized globally with fellowships and scholarships from many parts of India and abroad. Let's be thankful to a brilliant surgeon, an entrepreneur, and a compassionate human being for being with us today. Sir, मैं तुम्हें गुजारिश करिया कि तुसी अपने कुछ शब्द अपने तजुर्बियां दे साढ़े ना जाहिर करो.
Good morning, everybody, and thank you very much for having me here. Indeed, a pleasure to be at the 45th annual conference of the Vidarbha Ophthalmic Society. I remember having been to several of Vidarbha Ophthalmic Society conferences, the earliest one being in Yavatmal. I think that was more than 15-20 years ago. I think the medical college did a live surgery there. And the kind of love and affection that one gets when one comes to Vidarbha is really fantastic. It is indeed a pleasure to be here at the inaugural function. And as we all know that Vidarbha Ophthalmic Society consists of 9 districts of Maharashtra, and Vidarbha Ophthalmic Society only this year got affiliated with the All India Ophthalmological Society. So welcome Vidarbha Ophthalmological Society as an associate member of the various societies that are affiliated to AIOS. I remember the love and affection that I've got, and there have been many stalwarts from Vidarbha Ophthalmic Society, consisting of Professor Dr. Ishwar Chand, late Dr. Sudha Sutaria, late Dr. Madan Gopal. They have all contributed significantly and have been active in AIOS, president of AIOS, Maharashtra Ophthalmic Society. And there is an oration also on the Vitreoretinal Oration Awards, etc., which has been dedicated to these stalwarts. Over the year, as I have seen, I think 2 years ago or 3 years ago, I also went to Amravati, and here the number of people who are there at the Vidarbha Ophthalmic Society has strengthened. One thing that stands out among the members of Vidarbha Ophthalmic Society is the kind of excellent presentations that they make, and also the zeal that they have for doing community service. Wherever you talk to them, they have a lot of them, or almost all of them, do surgeries for the people who cannot afford, go to outreach centers and come to the base and do these camp surgeries in the base hospitals. So I think Vidarbha is contributing significantly to the eradication of blindness in India, as also the scientific excellence that is there among the members of the Vidarbha and the younger generation of ophthalmologists who are coming in and spreading their wings. And I would say great innovations that are coming out of the younger ophthalmologists who are there. I think Vidarbha Ophthalmic Society is doing great, as also the parent AIOS is wanting to nurture the younger talent, because that is the future of ophthalmology. I am really honored to be in the presence of Shri Sanjayji Dautre, the president of Vidarbha Ophthalmic Society, that is Dr. Nitin, or president of LOC, Dr. Prashant. We have Dr. Thora, Dr. Rajesh, Ajay Viral is there, Dr. Neha Ragini, who is the chairman of the scientific committee, and Dr. Amar Agarwal, Dr. Gopal Arora. I think it's indeed a pleasure to be joining this virtual meeting with all these stalwarts who are there. And I wish everybody who is on the dais and off the dais a very, very successful conference of the Vidarbha Ophthalmic Society. And I'm sure it will add significantly to the understanding and the skills of the surgeons, of ophthalmic surgeons of the region of Vidarbha and outside also, who would be watching this program. Thank you very much, and all the very best once again. Thank you.
Thank you very much, sir, for taking out time from your busy schedule and spending with us your pearls of wisdom. I now take the privilege to introduce Dr. Tatya Rao Lahane, sir, a very humble and loved ophthalmologist and social activist, son of the soil, who is a stalwart who does not need any introduction. Highlighting just a few of his many achievements, he holds the world record for performing the highest number of cataract surgeries. For his achievements and social work, he was awarded the highly prestigious Padma Shri Award in 2008. His stupendous journey from Dr. Baba Amte's Anandwan to being head of Department of Ophthalmology at prestigious Grant Medical College and JJ Hospital, from HOD to becoming the Dean of Grant Medical College, and then going on to become the Director at Directorate of Medical Education and Research, that is DMER, has inspired and will keep inspiring coming generations. The fact that a movie depicting the life and achievements of Dr. T.P. Lahane was released in 2018 and has garnered a huge success speaks volumes about his popularity and appreciation of his work. We are indeed honored to have you with us today, sir. I request you to address the gathering.
Thank you very much. I think I am not such a big man, but you introduced me, but I am a Lahane. In Marathi, Lahane is a small man. So Honorable Sanjay Dhotre sir, who is my best friend, now he is a minister in Government of India. My friend Dr. Maipal Sachdev, Amar Agarwal, and my own people, that is Parikshit, Siris, then the Viral, then the Prashant, and all the can say on the dignitaries, those who are sitting on the dais of Vidarbha Ophthalmic Society, and those delegates who are attending from there physically and online, and all the faculties. I'm very happy that the VOS is conducting this annual conference, and as the series was saying, that it should be a partial, some physical attendance and some virtual attendance. And I'm really agree that what he says is correct, that yes, few people should come there, they gather together, so that we will come to know that yes, now we are forgetting each other, and the mask, the face is always masked. Because of that, we are not recognizing each other unless and until there is a name in written. Now we'll have to write the name also. So I think it is a very good. I have heard two talks now, and I think what Vidarbha is doing, like they are doing an excellent work in Melghat, or they are. I am very much proud that as the Mahipal told that 3 stalwarts name from the this one, but another people who are guiding today is Dr. Mukadam sir, Dr. Karandikar sir. So these people are there, and I think when I joined as a president of Maharashtra Ophthalmic Society, so I tried and successfully united Vidarbha Ophthalmic Society and Maharashtra Ophthalmic Society, and I'm very happy that now the Maharashtra Ophthalmic Society is working together. So I wish you best of luck to the conference, and I wish a grand success to you, and also I wish you best of luck for your social work. Thank you very much for inviting me as a guest of honor.
Thank you very much, sir. We are really honored to have you with us today. With this, due to the slight change in the protocol of today's ceremony, we would now like to welcome our dignitaries on the dais with a floral bouquet. To begin with, I would like to request Dr. Prashant Ladda sir to please welcome Dr. Nitin Upadhyay sir, President of VOS, with a floral bouquet.
Thank you. Thank you. I now request Dr. Rajesh Ugle to please welcome the VOS Secretary, Dr. Ajay Khandewale.
Now I request the Chairman of Scientific Committee of VOS, Dr. Viral Shah, and VOS Treasurer, Dr. Neha Deshpande, to please accept virtual floral bouquets from our side.
To welcome.
Thank you so much, Master of Ceremonies and Akola Academy of Ophthalmology. Thank you.
To welcome the Secretary to the MOS, Dr. Shirish Thorat, I would like to call Dr. Sriram Lahore. Thank you. To welcome the Chairman of Organizing Committee, Dr. Prashant Ladda, I would like to request Dr. Anand Shivare.
I request Dr. Sunny Wadhwani to please welcome the Secretary of Organizing Committee, Dr. Rajesh Ugle, with a floral bouquet.
Thank you. To welcome the President of Akola Academy of Ophthalmology, Dr. Sriram Lahore, I would like to invite Dr. Pradeep Agrawal. Thank you. To welcome the Secretary of AO, Dr. Anand Shivale, I would like to call Dr. Priya. Dr. Priya, to welcome Dr. Anand Shivale. Thank you. To welcome the Secretary of AO, Dr. Sadi Wadhwani, I would like to invite Dr. Gurudasani.
Thank you. So to conclude the speeches here, I would request Dr. Rajesh Shugle, the Secretary of Organizing Committee, to address the gathering.
I deem it a great honor and privilege to propose the vote of thanks on the behalf of Organizing Committee VOS Virtual Conference 2020. We are extremely thankful to our Chief Guest, Honorable Sri Sanjay Ji Dhotre, Union Minister, Government of India, for his gracious presence for this inauguration ceremony. We are honored by presence of our guest of honor, Padma Shri Dr. T.P. Lahane sir, Padma Shri Professor Mahipal Sachdev sir, Dr. Ragini Parekh madam, Dr. Amar Agrawal sir, for gracious presence for the inauguration ceremony. I like to express sincere thanks to Dr. Sunil Mulchandani sir, who is a MMC observer for this conference. We are delighted to have MOS President Dr. Parikshit Gokte, MOS Secretary Dr. Shirish Thorat sir, for their presence and support for this conference. We express our sincere gratitude to all pharma companies for their financial support. The pharma companies include Intraocular Care, Microvision, Sun Pharma, Eye Care, Ajanta Pharma, Sunways Pharma, Vision Sales, Intas, Lupin, White and Trust, Cipla, and Genova Pharma. And special thanks for the Entod for coordinating all these programs on live on Facebook and YouTube. We are thankful to all faculties and PG students for their participation in the conference and excellent presentations. I wish to acknowledge Yash Vision and their team for their audiovisual support. I think I am failing in my duty if I do not mention the untiring efforts of our vibrant, enthusiastic team of VOS and Akola Academy of Ophthalmology towards success of this conference, and I extend a special thank to each one of them. Thank you all again.
Thank you, Dr. Rajesh. It is a time now to stand for the national anthem. So welcome back. So this marks the end of the inauguration ceremony. Over to you, Dr. Viral sir.
Thank you so much, Akola Academy of Ophthalmology, Organizing Committee of VOS-VRCON, and the Master of Ceremony. So as we are already learning behind the schedule, and we are all our panelists, chairpersons, and the faculty with us online. So we move ahead with our session 6, that is Cataract Management Updates 2020. I request the chairpersons, Dr. Prashant Agnihotri sir and Dr. Anil Harwani sir, to please unmute themselves and join us for the session. We have got moderators, Dr. Umesh Revanwar sir, convener Dr. Manoj Saktepar, and coordinator for this session is Dr. Shamik Mokadam. The panelists today for this session is Dr. Ashok Madan sir, Dr. Anil Dhamorikar sir, Dr. Deepak Nilewar sir, Dr. Gopal Arora sir, Dr. Abhijit Patil, Dr. Shaunak Mokadam, Dr. Rajendra Vishwakarma, and Dr. Krishna Bhojwani. So over to the chairpersons, Dr. Prashant Agnihotri sir and Dr. Anil Harwani sir, for further proceedings. Sir.
Good afternoon, everybody. At the outset, I'm thankful to all the organizing committee and the chairman organizing committee, Dr. Shah, for this opportunity. Actually, it's one of the most important sessions. We have such stalwarts with us, and along with me, we have Anil Harwani, and we have Umesh Revanwar, and Shamik, and Dr. Satyapal with us, and rest of the faculty is there. But let me just begin with saying that it's really a fortunate times that we can really discuss and dwell on such topics. And I'll request the secretary to start this proceeding, because we are running short of time and we have such wonderful talks in front of us. So over to Shamik to continue the proceedings. Shamik.
Thank you very much, sir. I would start off by introducing Dr. Ragini Parikh, madam, who's professor and head of Regional Institute of Ophthalmology, Grant Medical College, and Sir JJ Group of Hospitals, Mumbai. She is a president awardee for 100 Women Achievers Award, Achievers India, and she has operated over 75,000 patients in camps and at institutions. She is the chairman of Scientific Committee of Maharashtra Ophthalmological Society and the Bombay Ophthalmic Association. Over to you, ma'am, for your
Thank you. Thank you, Dr. Shamik. Respected Padma Shri Dr. Mahipal Sachdev sir, respected Padma Shri Dr. Lahane sir, respected Amar Agarwal sir, and thank you Dr. Prashant Agnihotri sir, thank you Dr. Anil Harwani sir, thank you VOS, thank you Nitin Upadhyay, thank you the whole faculty of VOS. So I'll start my talk with conversion from SICS to Phaco. Why should we convert? We must convert today because it's a cataract refractive surgery. All the patients want cataract, spectacle-free vision and natural vision. They want as natural a vision for distance, near, without glasses. With the advent of flags and modern technology and modern generation IOLs, we need to convert because Phaco is the surgery of today. So these are the basic steps that when you convert, that you have to first make a sclerocorneal tunnel, Capsulorhexis, hydro procedures, nuclear rotation, cortex aspiration, and IOL implantation, out of which all the steps are very, very important, and I will be discussing them in detail. So as you can see over here, why do we make a sclerocorneal tunnel? We always make a sclerocorneal tunnel in an SICS. But when we are learning Phaco, if we make a sclerocorneal tunnel, it's very, very easy to convert. In case there is a complication or if you're not able to complete the surgery, then you have to just deliver the nucleus by SICS. But if you make a corneal tunnel, what would happen is if you had to extend it, it would be very shabby. There would be a lot of astigmatism. So the best thing is to make a sclerocorneal tunnel, and the only thing is that here when you are making a tunnel, what you would actually do is, this is a tunnel as you can see like in SICS with the pockets and everything. The side ports are very, very important for the use of the chopper. That is the port for the AC maintainer, so that if you have to convert, it's very easy. And you put in the AC maintainer to do a rhexis. The most important thing over here is that when you enter, You have to enter and make the entry only 3.2 millimeters. This is a representational video where you can see the complete extension, but one must remember that the entry should be the size of the phaco probe. So that's very, very important. The second is the rexes. Now, when we are first learning rexes, a fully dilated immature cataract is important. As you can see over here, the rexes is being done with a capsulotome, and it's a smaller rexes than in an SICS. SICS can be done without a capsulorhexis, but in phacoemulsification, if you do not know a rexis, or if you break the rexis, you break the commitment to phacoemulsification. So knowing a rexis is very, very important to knowing phacoemulsification. Now, in case, even if it is an immature cataract, one can go ahead and do a dye-assisted rexis, which my residents are doing, so that you can easily see the capsule and the way it is moving. Now here it is being done with the Utratas forceps. So either a needle or a forceps can be used to do the rexis. The rexis is small, but the rexis is compulsory by learning phacoemulsification, and that is one of the most important steps. So without knowing a rexis, one must not proceed to do phacoemulsification. After rexis is the hydro procedure. The hydro procedure, as you can see over here, this is the golden ring and the nuclear rotation. A free nucleus which rotates, so that when you are dividing it, there is rotation, is extremely important. Hydro procedure is the separation of the nucleus from the epinucleus, the cortex, and the endonucleus. It decreases the size of the nucleus and it provides an epinuclear buttress to keep the posterior capsula safe. So hydro procedure is very simple. It is just separation of the capsule and the epinucleus and the endonucleus, and it can be easily learned, but it's extremely important. After that comes the trenching. This is a representational video, hence there is a corneal tunnel. The trench is nothing but moving the phaco probe using the ultrasonic power, one phaco tip wide, and the depth is depending on the depth or the thickness of the nucleus till you can see a glow. The trenching or the first division is very, very important. And if one is comfortable to go ahead, then the nucleus is rotated, and then more pieces can be made with the chopper. But unless and until there is a complete first division with two equal sizes, the phaco will fail. So trenching is very, very important in learning phacoemulsification and remembering that the central part of the nucleus is the thickest. After the trenching, what one can do is, when you are learning, either the phacoemulsification can be completed if you are confident of having made two pieces, rotating it and chopping it further, or if you are still learning, then you can end it over here and extend the tunnel and deliver the fragmented nucleus by visco expression in the earlier cases. So as you can see over here, whether you do Phaco or SICS, over here you already have an AC maintainer in place. This is Blumenthal technique, and the nucleus can be delivered after the first division in small pieces. So either this can be done, or as you can see over here, this is a trenching again. So this is a stop and chop technique. This is the chopper which is used to rotate the nucleus and to support the phaco probe. The nucleus is divided once there is a complete deep trench, and then only it divides without manually pushing the nucleus, and then it can be chopped into further 4 pieces. So if one is confident, these pieces can be chopped. But at any given time, the beauty is that if there is a sclerocorneal tunnel, one can deliver the nucleus safely if one feels that there can be a problem, or one is going to land up into complication. After that comes the cortical removal. The cortical removal, as you can see over here, is going to be different because the incision is smaller. So what we are using is the Lahane's cannula, the single port aspiration cannula, and the AC maintainer. One can learn to use the automated irrigation aspiration, but it is important that the incision is going to be very, very small, and using of these ports or interchanging them can help one to make a complete 360-degree cortical removal. We are using this in all our cases because they are autoclavable, they are very, very economical, and you don't need to remove the phaco probe and reattach it again, but whatever works in your hand. So this is a phaco incision where the cortex is completely removed. The bag remains inflated, as you can see over here. Now this is an SICS incision where you can see where the SICS was done, but the cortex can still be removed after you have finished the phaco emulsification. If you're not comfortable, it can be extended. But to learn, keep the incision 3.2. As you can see, using the ports, the main port, the side port, the AC maintainer and the aspiration can be interchanged. One can also see that this is also used to polish the PC, the Lahane cannula, so that there is less posterior capsular opacification. It can also be used to polish the undersurface. And so all the ports can be used, and the IOL can be implanted after extending the incision if it is a sclerocorneal incision. Hence, learning phaco is a very gradual procedure, and one must observe. Practice is very important. Start with a sclerocorneal incision. Make sure that you know your X's is perfect before trying to go to phaco. Learn hydro procedures while doing SICS. Learn the correct technique, which I was lucky enough to learn because I had Dr. Lahane sir to teach me. I have gurus like Mahipal sir, Amar sir, and all the teachers who are present here today. And if you know your SICS well, you already know half your phaco. But please remember, today is the age of phaco emulsification. One must not be scared because we have to learn this to give the best results to the patients like you would want it for yourself. Thank you so much for giving me this opportunity, VOS. Thank you, Nitin Bhai. Thank you, Viral. Thank you, the whole society. And a big hello to Parikshit Bhai and everybody, Anil Harwani sir. Thank you, Dr. Agnihotri sir. Thank you very much.
It was wonderful talk, Ragini. And can I ask the Shamik to go ahead with the second talk, please?
So I think that is...
Shamik, are you there?
So Lahane
Yes,
sir is sitting in the second cabin.
Sir,
Okay,
I would like to invite Dr. Revanwar sir to introduce Dr. Lahane sir for his and continue with the session.
So, good afternoon, everyone. I am Dr. Umesh. Its organizer has shared me, informed me that you should introduce Dr. Lahane sir. I am very much a small person to introduce Dr. Lahane sir, but this and thanks to organizer. Dr. Lahane sir is known everyone in heard of the every ophthalmologist in the world. Not only the ophthalmologist, but also in the poor and village community also know the Lahane sir. So I will share my video for his biodata about his journey in ophthalmology.
Ragini, to the
I think
Yeah,
he's
I
already
will
shared his screen.
stop sharing.
Yeah. It is, everyone is able to see?
So we can see you, sir.
About the video?
No,
we are not. Can you, because Dr. Lahane is an internationally acclaimed surgeon.
So he is from
So I
basically.
think because if you are taking more time, let's go ahead with his talk.
Yeah, sir. Yeah, he is from a small village, and his graduation is from both graduation and post-graduation is from Marathwada University. He is at first associate professor, then professor, then HOD, then dean, joint director. Now at present he is a director of DMER. He is awarded with the Padma Shri by Government of India. And for VOS, it is that Dr. Ishwarchan Award oration was given to Dr. Lahane sir at Yavatmal. And I only say that for the youngers and every ophthalmologist, घार जरी आकाशात किती उंचावून जरी फिरत असली तरी तिचं लक्ष हे आपल्या पिलावर नेहमी असतेच. थँक्यू सर.
I think.
Ragini सुरू कर.
Yes. Welcome, sir.
हाँ, उमेश तुमचा शेअरिंग बंद करा. Okay, thank you. Ragini तू शेअर कर.
Ragini, can you share your video, please? Yeah, that's great.
अच्छा, प्रशांत, thank you. Anil, thank you. Thank you, Nitin. Amar and Mahipal are there. Thank you very much. So I'm going to speak on the management of supra-hard cataract safely. Ragini, next. No financial interest. The Brunson cataract. We always see that. I always say this is a Latur cataract. As you know, there is a scarcity of water in Latur, and so we get such type of hard cataract as I am from Latur. The hard brown and black cataract problems, because there is a no glow for the rectus, no more endothelial damage should happen there, difficult trenching, and risk of PCID is always there in the such type of cataract. Second, the management strategy, I think here, I think this dye-assisted larger rexis, because here the cataract is very hard. Generous use of viscoelastic as an epinicular plate is absent. Use of hyperburst or the burst mode Phaco. Multiple small pieces, very, very important for the nucleus to emulsify. Complete separation of the posterior interdigitating, because there are the leathery fibers in the posterior portion, and that is very, very important. The caution, whenever you are doing any surgery here, the endothelium protection is a caution. Use of Phaco power efficiently. You have to power. Why? Because do not push the nucleus manually. The sharp nucleus segments can tear the PC. What happens? These leathery fibers can bring them down, and keep provision for the conversion and vitreoretinal backup ready. The techniques, you can basically use the stop and chop, because to start with, you don't go for chop and make a multiple pieces. And then Nagahara chop, yes, direct chop without trenching you can use. Here you require a sharp chop. Next. Now see, this is the rubra. You see, the cataracts where the glow is seen very well. And because of that, we get confused. Yes, I can see the glow, but this cataract is a very hard cataract, because this is a rubra cataract, and in the posterior part, there are very leathery fibers in this. So in such situation, whenever you are doing, can you see this? You make a trench. Now, when you are making the trench, now this trench should be not only the one tip larger, but it should be slightly larger than the one tip, so that you can go deep. And not only the deep, but you go up to the periphery. See, the fibers are there up to the periphery in the posterior digitating area. Now see here. And once it is a deepened 2/3 deep of the nucleus, see here, center and periphery is now, the trench is done. And once that trench is done, then you can separate this. And when you are separating, it is very, very important in rubra cataract. See here, to separate it and here up to the center of the nucleus. And again you go on the other side. And once you go on the other side, again you separate it. And once you separate it, see here, and you will have to separate complete two pieces. And if those two pieces are not separated, then the interdigitating fibers may bring down the tip, and that can tear the PC. That time you always feel that you have not done anything, but that fiber which was attached there, that causes the tip. Now here you see I have made another piece, and after making the piece, you can just emulsify it. So emulsification in such situation in the rubra cataract is gradual. You will have to emulsify it, because though Phaco we say, but Phaco is not a fast procedure. It should be, if it is done gradually, slowly, it is a safe procedure. But sometimes what happens, as it is Phaco, we move everything fast, and that causes the problem. Again, you can take the another piece, and here again you will see that I am making the another piece. And whenever you are, see here, separation, complete separation. Unless and until you separate it, you should not emulsify or catch that piece. Otherwise, the tip of that piece causes the PC tear. Now always it results sometimes, and now here you will see I am just emulsifying the such type of hard rubra cataract, but it is a gradual, and once you finish it, the last piece, whenever there is a last piece, as you know, the here you will have to take care because there is no support of the cortex here, and because of that it will also can tear because of the cells, the posterior capsule. Here again you will see I'm separating the fiber, interdigitating leathery fibers which are attached to the tip of the two pieces. So I have separated that, and after separating, then the gradually you can remove. And though this is the rubra cataract, you can also protect the endothelium also, and you will see I am doing it in the posterior part, not coming in the anterior portion more, and avoiding the injury to the endothelium also. See here, so this is what the rubra cataract we can operate. It is not easy, but it is not difficult. You can definitely do it. So that completes the cataract, and this is the aspiration. So aspiration that I am doing with this cannula we have made in 1996, and that we are using. You can go for the automated irrigation aspiration by Phaco also, but we are having this. We use this cannula only. That can also help us for polishing and everything. Next. Now the another cataract I will show you is the hard cataract. You can see this is the brown cataract. Here you can see that was a rubra cataract, and here you will see it is a brown hard cataract. Now what happens in such situation? The central portion of this cataract is very hard than the peripheral one. And what sometimes if you go in the periphery, you can tear the piece. So in such situation, you should remain in the center only, and you can see here. You can remain in the center, and then you can make the pieces. But the central portion is very hard. You can say like a stone. So such type of cataract. Here you have seen in that cataract, I went to the periphery, but here I am not going in the periphery because the periphery, the cataract is not much hard. It is more hard in the center, and I am making the chopping. See here, whenever you are making the chopping, your tip should be properly engaged in the nucleus, and when it is engaged in the nucleus, then the sharp chopper you can go for the vertical chopping, and it is possible. Here again I am rotating, and after the rotation you will see again, you can see how I am just lifting the piece. After lifting, then I will put my Phaco tip in, and because of that what happens, it always goes in the inside, that inside the like a burhole in the hard area of the cataract, and that because of this it supports properly for the separation, and we can make the pieces. But if the Phaco tip is not, you can see in the hard area of the cataract, then it always slips, and then you are unable to do the can say the pieces of the cataract. So that is what, whenever you are chopping, here you must pass your tip the area where that can hold the nucleus properly. So here you will see I'm just doing this chopping, and here I remove this. Though it is a hard cataract, it is possible to remove the pieces. So like this, you can say whenever I am picking up, that time you will see the blackish appearance of the cataract, and this is the central portion. Okay, so I think somebody's mic is on. Somebody is attending from house and mic is on. So we are also listening the music from house. So I think this is a complete hard cataract. We have seen now here you will see now. Can see here the another cataract. Can see this is a if you can see the pupil also. In the eyes there is a sclerosis of the cataract. There is also sclerosis of the pupil, and in such situation you will not get much dilatation of the pupil. Again, you will see this. My mantra here is I always go for the stop and chop, and I make two pieces first. And two pieces, making two pieces is half done in the hard cataract. So this is a half done, And once the two pieces are made, then I make the other pieces. And this other pieces, then it is possible to aspirate. So that may be any type of hard cataract. So that can be tackled whenever you know the technique. So I always advise that don't go for the Phaco in the hard cataract unless and until you know how to operate a mature cataract. So you do the cortical cataract, and if you are done the, you can say 20-25 cortical cataract, then you can go for the immature nuclear cataract. Once you do that, then you think of the more hard cataract. But if it is a black cataract or it is a rubra cataract, in that case you must know how to do it. Unless and until you have the experience of doing more than 100 cataract, you should not use the this cataract to do with phaco emulsification. And it is better to go with the SICS so that you can sleep well. Otherwise, second day patient will be unable to see, and you will have to tell them that you have got the air inside the next. This is my last phaco. You will see this. This is the Latour cataract, and here you can see here the very hard cataract, and also the pupil is not separated. And now you see I am doing the direct chop here. Can you see this? The chopping. And when you are doing the chop, here you will have to go in, and once you go in, then you separate. So here the chopper should be sharper. Chopper, if it is not sharper, then you can't do the chopping in such cases. Again, you will see I am going in, and once I go in, then I am separating it. But here also, whenever I am doing chopping, I do the first two pieces. And when the two pieces are done, then I go for the this one. Again, you will see the this type of cataract. You will have to take care while operating. Again, you will see black cataract. And here, whenever I am catching this, or by this, you have to lift the tip. And once you lift it, then pass the tip of the phaco emulsification, and then you catch that piece. And when you catch that piece, then it is possible to emulsify this. So though it is seen as a hard cataract, you can see here I am using both longitudinal and torsional phaco. So automatically the phaco power, I always say that use phaco, and this optimum use of phaco will definitely help you. If you are not using phaco, then you just have a friction and the movement of the tip of the phaco, and that can push the nucleus behind, and that goes in the vitreous, and then you will have to go to the prashan. So better to avoid that. Sometimes, yes, we can ask the prashan, but every time we should not trouble prashan. Now see, my experience in such cases, what counts is the experience. So these are the cataracts. 98 I was doing, 2000 I was doing, and now the 2020 there is no SK. The same person is same, but experience counts. So I always say that if you are experienced enough, go for phaco. If not, SICS. Next. And take home message is machine. If any machine can work now, it is not required that high-end machine. Sharp tip, stop and technique, effective use of ultrasound energy, and choose your own technique. Now this is presentation is made by Dr. Ragini. Thank you very much, Ragini, and thank you, the Vidarbha Ophthalmic Society.
Thank you so much, Dr. Lahane. And it is as usual, your art of handling such difficult cases is really praiseworthy. Over to Shamik for the next talk.
Sir, Prashant sir, before we move ahead, this being a virtual conference, we would like to present a token of appreciation from Vidarbha Ophthalmic Society to our national faculties, Dr. Ragini Madam and respected Dr. Lahane sir. Sir, thank you so much.
Thank you. Thank you.
Please accept this, sir, and Ragini, we will send you the hard copy.
Thank
send
you,
you the
sir.
hard
Thank
copies.
you, sir.
Definitely, sir. Definitely.
Okay.
Over to you, sir.
Let's go to the next one. Shamik?
Sir, it is Dr. Amar Agrawal, sir.
Okay, so here comes the master of the orchestra.
Yes.
Amar, it's very difficult to introduce him because I have seen him grow from his times in Ahmedabad to today in a world scene, or he's one of the brightest star in world ophthalmology or the international ophthalmology, scion of two great people whom I knew, Professor Jaivir and Professor Tahira. He is a past president of International Society of Refractive Surgery. Well, if I want to introduce Amar in one word, he's a pioneer. You know, anything, his mind is always active, rather hyperactive. And that shows with him pioneering things like Phaco net, where under 1 millimeter cataract surgery, and he coined a new term, ameropia, which all of you must be knowing. He has done enormous number of surgeries with his innovations like glued IOL scaffold is his giving to world ophthalmology. And he also has devised this pre-descemet endokeratoplasty, Pediatric, single pass 4-throw pupilloplasty is again one of his innovation. But let me tell you, one of the most developed thing which he is working on is vitreous. Vitreous is a hypersonic vitrectomy. Now this is going to be the future of vitrectomy, and I'm really happy that he is with us. As far as numbers are concerned, he has more than 150 live surgeries, written 60 books, and he is running 75 eye hospitals in the world. Welcome, Amar. And I'm sure he is going to enlighten us with something new this time.
So more than 100 now, sir. I was counting.
100 eye hospitals.
So it is. Wow. It was 108 when I counted because it was auspicious and that was last year. So it is must be 125 now, sir.
Thank you very much, Lahani, Professor Lahane, Prashant, Ragini, all of you. I'll start sharing my screen now.
Please do that.
And let me start this first thing. And let me know if my presentation is seen on your screen.
Yes, sir.
Is it seen there?
It's there. It's there.
Okay, it's full screen now for you?
Yep. That's
okay,
it.
Lovely. So basically, let's look at this first case, which I thought I'll show you. And basically, you see here, the patient has got a pseudophakic bullous keratopathy. I want to thank the Vidarbha Society for inviting me here, Viral, and all of you for this lecture here. But what I wanted to show you here is, look at the scarring. It's quite bad. I made two flaps 180 degrees apart. I'm making my scleral tunnel. You can see there. Now I'm trying to take off this epithelium because I cannot see anything. And that's hypertrophic epithelium. Now inside you see there is an ACIOL. So I've now fixed my infusion cannula in the pars plana. If by chance the flaps are not 180 degrees, see that they become 180 degrees, and you can see I'm making that correction now. Now I'm doing a 22 gauge needle entry inside. In such complicated cases, I always do a posterior vitrectomy because I do not know if the previous surgeon has dropped a nucleus, dropped an IOL, anything. So here you can see I'm doing a vitrectomy there, posterior vitrectomy, and you can see the disc there. Once I have cleared up this mess inside, I now enter inside the eye, and you can see I'm making my scleral tunnel incision. The problem is when you take out these IOLs, they are always entrapped into the iris or to the angle. That's the big problem in these ACIOLs. So you have to take them out very carefully. I'm taking them out, and you can see they are already partly broken inside while removing it. There you can see part of the lens come out. Now there's another portion of haptic inside. I'm pulling it out. Now there's still one more portion inside which is locked onto the iris. Now I got to be careful when I remove it, because when you remove them, you can produce a bleed, which will create a big problem for me in my hand. So here you can see I removed it. There is a bit of bleed there, but it's not too much. So once I have done that, I'm now going to do my vitrectomy, clear up this whole mess. Now the next step is to part my glued IOL. Since I already have an incision large enough, the same lens I can put in like a non-foldable, catch one haptic, catch the tip, externalize. Now watch, I go in from the side port. Now I'll tuck it inside this haptic inside, transfer it to the forceps. Now this second forceps will go through the sclerotomy. This is the handshake technique. So now watch, I'm catching the tip of the haptic and I pulled it out. So far, so good. Now watch the amount of haptic externalized. It's a lot. That means I know I'm safe. So here you see I'll create a 26 gauge needle tunnel, the Gabor-Charier's pocket, and tuck the haptics inside. Now so far, so good. Now look at the iris. We have to make this pupil small. The reason is very simple. A closed angle will become open. 2, I want air in the anterior chamber. I don't want it going back because remember there's no capsule. And 3, I'm going to create a pinhole pupil for astigmatism. So the technique is very simple. It's single pass, 4-throw pupillasty. Take a Proli needle, go through clear cornea straight into iris. From the other side, remember there's a paracentesis. So paracentesis is required only on one side. Pass a 30 gauge needle, railroad the 2. Bring the suture out. Bring this loop out. This is the single pass. Now remember the number 4. 4 times you pass it, and that's game, set, and match. That's all you do. See, normally when you do pupiloplasty, you do 3, 2, 2. Here you have just done once, 4 times, and it's over. So here you can see I'm passing the needle, bringing it out. Now you see I'll bring that loop out, which is a single pass. My assistant is using an endo illuminator from outside to help me see better. Now I pass the number 4 times. So remember the number 4, and that's over. Anybody in Vidarbha or anybody watching this conference, please go back and try this out and you'll find life change for you because it's so simple, this procedure. Once I have done that, now my next step is to put in air in the anterior chamber. Now I create my bubble. Now watch this. This is the cornea. You're looking at the endothelium. I've taken a 30 gauge needle. I'm going through sclera. We first started Pediatric in 2013. And you can see there the bubble created. Now remember this bubble. This does not go to the periphery. So this is a type 1 bubble. Where is the air? You have endothelium, you have desmes, you have the pre-desmes or Duas layer, then the air. If the air went to the periphery, that's a type 2 bubble. That means you create a DMEC graft. Now you see I'm entering inside his eye. Once I entered, I'll stain it with trypan blue. Once it's stained with trypan blue, all I do is dissect it. That's my Pediatric graft. Now I create my second trocar in the anterior chamber. This will give me air. So remember, I've got fluid in the back and I've got air in the front. Once I've got continuous air inside, all I do is strip this whole desmes endothelium complex. And you can see me doing that. Just like how you will do in normal endothelial procedures. Once that's removed, I take my Pediatric graft, load it into any injector, any technique you want, and inject it inside. Then check where it is, right or wrong, unroll it, put in air. Now question comes, see how I'm just injecting air on my air pump. I've got continuous infusion of air now through the trocar AC maintainer. Watch, I can move my graft. It's not like in DMEC. So just to tell you all, in Pediatric, we get just 25 microns. In DMEC, you get 15 microns. DSEC, you get 80, 100, depending on it. So why do we only do Pediatrics? In Agarwal, we do about 100 keratoplasties a month. And we do only Pediatrics. We do 0 DSECs. We do 0 DMECs. Please understand, in DSEC, I'm taking 80, 100 micron. That means my thickness of the cornea is increasing. It's not the way. In DMEC, why do we not do DMEC? One, in DMEC, my donor is always above 50 years or 40 years. Because you cannot strip the endothelium from a donor under 40 or 50. Second thing is, I cannot manipulate it. It's too friable. In Pediatric, I use any donor age. I only take donors under 40 years of age. So keep that fact in mind. Now you see I've applied the glue, seal everything down. Now the question comes, how did this patient behave? So let's see how this patient behaved at the end of the day. Remember, I've done an ACIOL explantation, I've done vitrectomy, I've done glued IOL, I've done 4-throw pupillasty, and I've done Pediatric. This is the pre-op. Remember the picture, how it was? Post-op 1 month, and now you can see the same patient post-op 2 months. Now you can see the same patient 3 months post-op. And look at how the patient looks now, 9-month post-op. So this is a big difference between Pediatric, and you cannot get this sort of results with other procedures. One more case I thought I'll show you, and then we'll be able to take it from there. Look at this case. This patient came to me from Poland. I can't see anything. But if you notice carefully, the whole cornea is bad, no doubt, but the iris is damaged. And the reason I'm going to show you this is I'm making a scleral groove. I thought I'll show you this case to show you this new technique which we have just started. It's called the trocar assisted iodialysis technique also. Now look at that iris. It's right in the center. I'm fixing a trocar AC maintainer in the eye. That will give me my fluid inside the eye. Now, once I've got fluid in the eye, my second thing is I'm going to fix a trocar opposite the iodialysis. This again, please remember, such a simple procedure. Anybody watching this video will be able to do this when you go back and you have an iodialysis in your hand. So watch my technique here. This technique is very simple. I'm fixing a trocar in the AC just opposite the iodialysis. Now, once I have done that, remember on the opposite side, I had a groove. Now, what I'm going to do now is I am taking a double-armed Prolene needle. Remember that. A double-armed Prolene needle. That means there are two Prolene needles. Now, I'm passing it through the trocar. Once it goes through the trocar, I will now pass it through the iris. So, I'm holding it in one hand, passing it through the iris. And you can see it's gone through the iris. Now, through the scleral groove, watch the scleral groove. I've taken a 30 gauge needle. I'm passing it through that. Now, I'll railroad the two. Once I've done that, my Prolene needle will come out. Once it comes out, remember, this hangback technique, which was started by Michael Snyder, has become easier because of the trocar-assisted iodialysis. Now, I take my second double-arm Prolene portion, pass it through the trocar. Now, again, once it goes through the trocar, I will now make it pass through the iris again. And you can see me passing it through the iris there. Once it's done there, here you can see I'm going to catch that iris, pass the needle through that other portion of the iris there. Once that's done, again, pass from the other side a 30 gauge needle through the scleral groove. Now remember, you've got two of them. All you do is pull them. That's it. That's again, game, set, and match. And you'll see that fixing just now. Here you can see now the both arms pulled out through the sclera, and you can see the iris suture coming out. And that's it. It's very simple. But remember, when you do an iodialysis like this, you see what's happening to the iris? The pupil is getting distorted. Now I've got more of the iodialysis. All I do is repeat the same procedure. So all I do is take another double arm. My trocar will just rotate. So when you have a trocar, the advantage is you don't go through cornea. Sometimes when you pass, if you make an incision, paracentesis, you'll go through clear corneal, means go through the corneal tissue. You'll have to cut the suture. In this case, you don't have to do that. Here you notice now I fixed a second double arm Prolene. I'm refixing my iodialysis back. You can do it as many times as you want. This suture gets buried into the scleral groove. Now watch. There is a closed angle glaucoma. This patient has high pressure. So I'm going to break this synechiae also. And now, once I have broken it, see the pupil has become distorted. I'm going to do it combined with a single pass fourth row pupillasty. In other words, you're doing a twofold technique. You're doing first, you did a trocar assisted iodialysis technique. Now I'll do the single pass fourth row pupillasty. In this case, I don't need to do a glued IOL because I can see my lens is quite stable in the bag. So all I'm doing is now I'm passing my needle through this area there. From the other side, a 30 gauge needle, as I told you before, railroad the two. Okay, Maipar has got a great technique in this, in which he's doing it in phakic eyes, in which he puts an ICL inside, and he calls it the scaffolding of the fourth row pupillasty, which is a great technique coming out soon in the IGO. Now I brought this loop out. Now, remember the number 4. You can do this as many times. You can do here, then I can do it on the top. Since it's such a simple procedure, you can just keep on repeating it. Now watch, I've done this side here. I'll do one on the top. Now when you do the top one, the game plan is very simple. Watch the 3 dots which you are seeing there. That's the Purkinje image of the microscope. Your Purkinje image got to be centered on the pupil. That is the chord mu. That means the optical center or the pupillary center and the visual axis will be together, which is angle kappa. So now it's not like that. So I'm going to take my vitrectomy probe and I'm going to enlarge this pupil a bit to see that the Purkinje image, which is P1, is centered on the center of the pupil. Now look at that. It's bang centered. Now I know I'm bang on track. This is like a pinhole pupilplasty. These patients will be extremely happy post-operatively. Now the rest of the procedure, very simple. all I need to do is connect my trocar ACM to air. Take off my other trocar I don't need because my iodization is repaired. Now I take off my endothelium. I prepare my PDEC bubble, and you can see that being prepared. Stain it, dissect it, take it out, inject it inside the eye. So now you can see I've taken the graft. There it is. I'm going to inject it inside the eye there. And you can see the graft being injected. Once it's injected, now all I have to do is unroll the graft. So here you can see there, I'm going to inject it inside. It just goes in like a DMEC graft. But big difference between DMEC and PDEC. So please remember, I use only young donors. We never do DMECs at all. And I can manipulate the graft whichever way I want. Now the question comes, how did this patient behave? So let's see how this patient looked at the end of the day. Remember, this patient came to me from Poland, so I was very particular about it. 3 weeks post-op, you can see how the patient is already. And look at the patient, 2 months post-op, the patient vision improved to 6/6 vision. So saying that, ladies and gentlemen, what I'd like to say is, finally, I'll just tell you about this. This is the book which we had published on PDEC, which is brought out by JP Brothers. This was the first book on PDEC which we brought out. Subsequently, we brought out others also. I'll just now close up this thing and stop sharing my screen. Thank you very much. I'd like to thank Prashant, Viral, and entire Vidarbha Society, Maipal, Professor Lahane, Professor Ragini, all of you who are such great stalwarts. Thank you very much.
Thank you so much, Amar. As usual, you know, it is something very eye-opening to us to see such great surgeries. Shamik, over to you for the next talk. Because we are running short of time.
Yes, sir. So the next talk is by Professor Mahipal Sachdev sir, and I would like to call upon Harwani sir to say a few words about him, and we can start the talk.
Thank you, Shamik. As Dr. Padma Shri, Dr. Mahipal Sachdev doesn't require any introduction, but formally he has already been introduced by Master of Ceremony. And we are running short of time, so I'll just straight away invite him for the lecture by saying just one sentence, which reflects my heart about him. He is a rare combination of brilliant surgeon, master of academics, and a successful entrepreneur as well, and also a compassionate and humble human being who is loved by all, not only by his relatives, friends, colleagues, but all of his patients. So I'll invite straight away Dr. Padma Shri, Dr. Mahipal Sachdev for his talk.
Mahipal is a great friend, you know, great friend. Mahipal, welcome.
Thank you very much, Dr. Prashant. Thank you, Dr. Anil, and thank you, Dr. Mukaddam. Pleasure being here, Dr. Lahane, Dr. Ragini, and Amar. It's always a pleasure being with you. I'll be talking about, my slides are visible?
Yes, sir.
Okay. Well, I'll be talking about subluxated cataracts. How do I manage this particular challenge by the use of technology of femtolaser assisted cataract surgery? Now, when you're looking at subluxated cataracts, the surgical challenge is to preserve the capsular bag because there is subluxation and there is a communication that happens between the anterior and the posterior, and there could be vitreous that is coming out. And you could have the extension of the subluxation. So therefore, the bag preservation is the main thing that is required, and reduction in the vitreous loss, and having a stable intraocular lens if you are able to implant, which is central in position. Now, the first thing is that whenever you are looking at a subluxated lens, you have to be, you should have diagnosed it pre-operatively rather than end up in a problem that you have seen it only on the table. There is the phacodonosis, there is an increase in the space between the iris and the lens, and the lens edge can be seen on extreme gauge. So it is very, very essential that you have a full dilatation of the pupil. And also you could assess the patient in a supine position, and the ultrasound biomicroscopy, if you have, that can actually tell you the extent of the zonular loss that is there. Now, there are obviously several reasons, but trauma stands out to be the #1 reason that you have for subluxation. Otherwise, Marfan syndrome, the homocystinuria, etc., you have these. high myopia, the zonules become lax, chronic uveitis, glaucoma patient, pseudo exfoliation syndrome, etc. These are the other causes where you can have subluxation. So if you see any of these, you have a history of trauma, you have pseudo X, etc. So you need to look at the subluxation and try and quantify the amount of subluxation, because if the subluxation is huge, the type of techniques that I am going to talk about may not be useful. But if you have subluxation going more than 5 clock hours, or depending upon the age of the patient, the density of the cataract, etc., you have to take a call. Now, the other important thing is that what is the etiology of the subluxation is also very important, because if you have a traumatic subluxation, it is unlikely to extend. But if you have a Marfan's or a homocystinuria, then the subluxation is going to extend and may not be a great idea to try and put the lens in the bag. As I said earlier, the grade of the cataract is something very, very important, because if there is a hard cataract, you have to do more manipulation and there could be problems of increasing the subluxation. Now, this is what I follow, that if the subluxation is less than 3 clock hours, that is less than 90 degrees, and you can just put the CTR ring and the IOL haptics which are there. And if it goes from 3 to 6 o'clock, then you have to fixate it. So the CTR has to be with either a Abbott segment, or you have to have a Sionis ring where you have to fixate the lens to the sclera, or you can go out for the glued IOL. And if it is progressive disease, then under those circumstances, I will prefer a glued IOL even if the subluxation is less. And if the subluxation is more than 210 degrees, there is no option of, I don't follow the option of a ring fixation, but I go ahead and do a glued IOL. Now, what are the challenges that are faced when you are doing a subluxation? If there is a subluxation, the elasticity of the capsule is lost, and the counter traction and the traction force that you need while doing a capsulorhexis, which is crucial, is not there. So if you are using a needle capsulorhexis, it is very difficult. So then you have to use a two-handed capsulorhexis technique to kind of do a capsulorhexis. If there is excessive lens mobility or a lens tilt or a displacement, and the presence of vitreous in the anterior chamber, this makes capsulorhexis extremely difficult, because it tends to increase the subluxation from there. Also, if you end up with any discontinuity of the capsular ring, that becomes a contraindication for putting in a ring, because it is going to extend that tier of the capsule and you can get it posteriorly. So there is a problem, and placing of a PCIOL becomes difficult. Now, the other challenge which is there is that during surgery, you need the least turbulence, and your bottle height should be less when you're doing a phaco emulsification, and the parameters should be slightly less, because the continuous vitreous hydration during phaco emulsification, this causes the hydration of the vitreous, and more vitreous tends to come out from the wound, and this increases the communication between the anterior and posterior chambers, and also leads to fluid accumulating and causing positive vitreous pressure and shallowing of the anterior chamber, which happens. Now, how can we make it more easy for us to do these cases? So there are two pearls that I will give. The first is that if you have access to a femtolaser, that makes certain steps of the surgery much easier. And the second is the step to do a vitreous decompression, which will reduce the hydration and which will not allow the pressure of the eye to go up and the shallowing of the anterior chamber, and you can do the surgery pretty well. Now let us see this case, which is a small pupil, irregular, shallow, had an attack of angle closure glaucoma on tamsulosin, hard cataract. How does one go and kind of work on this particular case? So you can see here that this is the case. You can see iris atrophy patches which are there. You can see a peripheral iridotomy has been done before, and you can see in this particular case there is a subluxation. If you can note, there is a clear difference in the AC depth at that particular area. So this is the case, and you can again see that we can see that there is a subluxation. I'll just show you. So can you see the phacodonosis? It's very apparent. You can see that there is a phacodonosis because the pupil is not dilating fully. We are not able to actually ascertain as to how much is the zonal loss which is there. Now let us see how does one go ahead and do this. So you will have to go and put a Malugan ring in the OT, and once you have the Malugan ring, you can remove the viscoelastic and put in a suture if you want. Otherwise, if you have a watertight wound, it doesn't matter. So you can see that clearly the iris is moving here, and this is the subluxation. It is not a flat iris which you normally get on an OCT. You can see that it is bent like this. So once you center the capsulotomy, and you can see the capsulotomy taking only 1.2 seconds, which is there, and we are making into 6 quadrants. So you can see that these are the 6 quadrants. Now the important thing is that in spite of the subluxation, there is no traction on the capsule. Even if there is vitreous, which I'll show you in the next case, you are able to get a perfect capsulorhexis which is there. And you can see that what we do is that we are disassembling the nucleus. You are easily able to cut it into 6 parts, as you can see here. And we go forward, and now we'll take the patient into the OR. So you can see in this particular case, the capsulotomy is perfect. We have removed the capsule, the ring is already there, and you can see that the manipulation, this is a low phaco, it's not a very aggressive, the bottle height is less, and we are not using very high parameters, but you have to be very gentle when you have done a hydrodissection. You can see that these are the first moves that one is trying to get to see that there isn't a falling back of the nucleus, because you have to be sure as regards if you have to put capsular hooks at this particular time or not. So you can see that we go in and gently, the gentleness of the procedure is something which is very important. So you can see that there is a difficulty in rotation. So what we will do in this particular case is that we are taking 2 instruments and gently trying to rotate. You can see that there is still some resistance despite hydro, and one has to be very clear that this is not going to work. No chopping is going to work till you are able to rotate the nucleus, and you have to put viscoelastic, do hydro, and now there is the support of the capsule. Ideal would be to use a capsular hook, but in this particular case, we are using an iris hook, which works almost as well, but better is to use a capsular hook if you have. So you can see that we have done this, and now we are going in, and you can see that the separation is possible very easily because we have pre-chopped, and you can see I'm just running it forward. The nuclear disassembly becomes a kind of a piece of cake if you have already cut it into smaller pieces. So this is something very, very important that you have to assess before you actually go full-fledged in the Phaco procedure as to what you are doing and what you are going to have in this particular case as regards the stability of the lens. So you have to use, in this particular case, a Malugin ring, plus we have used a stabilization at one part of the capsule. So now you can see that we are trying to just gently rotate out, put some viscoelastic. You can see that we are going to put some viscoelastic, and there is a second hook that has been put here to get more stability. And once you have more stability, you are using an epinuclear mode on the Phaco machine to remove the epinucleus, which can come out very gently. And then you use, in this particular case, we are using a bimanual irrigation aspiration to remove the cortex which is there. Once this has been done, you put viscoelastic, and you can see that this is a ring that is being implanted because there is no clear-cut big subluxation that we can see. So we are just putting in an endocapsular ring which is there. Once the endocapsular ring, and it's preferable to use a single piece lens rather than use you can use a 3-piece lens or a single piece lens. But in this particular case, because there is no specific subluxation that we have noted as to where we have to place the lens, so we will, it is always slightly more gentle when you are using a single piece lens. So you can choose the lens that you want in this particular case basis what it is. And you can see that now we will remove the hooks and then the Malugin ring which is there, and just to see that there is no vitreous, and put an air bubble, and that is the end of the surgery. Now, femto-assisted cataract surgery is, the advantage is that it is not dependent on zonular counter traction for doing a capsulorhexis. Most important is that you don't need a zonular counter traction. It can be done in a closed chamber. That means that before you have opened the eye, there is no increase in the subluxation, etc. And it allows lens fragmentation without any additional stress on the zonules. Now, the second part that I am going to talk about is a vitreous decompression, which I am going to show you. A valve trocar is placed at the pars plana site around the zonular defect, which allows a limited dry vitrectomy. So you have to do a limited dry vitrectomy before and during phacoemulsification. Intermittent vitrectomy with a moderate cutting rate and low vacuum parameters accompanied by temporary halting of the phacoemulsification procedure is what is required. And triamcinolone can be injected to ensure adequate vitrectomy. So this was a doctor who came to me from Bihar, 44-year-old non-diabetic, post-traumatic subluxation. And you can see this was how the lens looks. So pre-operatively, we have assessed that it's a 6 clock hours temporal subluxation. There is phacodonosis and the nucleus is grade 3, rest fundus and pressures are normal. So we plan to go ahead with a femto-assisted cataract surgery along with vitreous decompression. So this is pre-op. I'll just show you that this is the femto that we are doing. I'll just stop at the relevant point. You can see that this is the OCT which is happening. This is the OCT. Just watch here. Can you see this vitreous blob coming here? Can you see this vitreous blob? So this is a vitreous blob that is there. You can see that the iris has come down and we will have to manually take onto the posterior capsule because the configuration of the lens which the machine is recognizing becomes slightly different. You can do a capsulotomy based on the scanned capsule, but when we go on to the scanned capsule, you can see that it is cutting the iris. So we will go on to going on to a manual capsulotomy. So you can do what is known as a customized capsulotomy and try to get it wherever we want, because there is going to be, once you have a ring, there is going to be a change in the position of the lens. So you can do a customized capsulorhexis so that it can be centralized after the ring, etc. has been put. So you can see that this is the capsulotomy which has happened. You can see that, so sorry, I've just come forward. You can see that this is the OR. We have got the 6 pieces which are done. We have the capsulotomy. This is the dry vitrectomy that we are doing. You can see here that there is a vitreous tag which is coming here. We have put triamcinolone, and from the pars plana, we are decompressing the vitreous so that the communication of the vitreous from the back to the front is taken care of. Now, this is something very, very important, and you can see that the capsulotomy has been done without any problem. The earlier case also. And in this particular case, because there is a huge subluxation, we are putting a ring before, and you can see that the ring goes into the capsular bag. Now again, see the ease with which we can do the nuclear disassembly. We are not using any high fluidics. You can see that the nucleus, because it has been cut very well by the femto, can be easily aspirated. And you don't have to actually, in the previous case, there was difficulty, but in this particular case, there is a significant ease that we are having in rotation, etc. Now you can see that this is the epinucleus which is there that we are trying to bring out. This is the bimanual irrigation aspiration that is being done. That becomes more gentle. And you can see that we are able to remove the all the cortex. Once we have done that, keep the infusion on. It is very important that you keep the infusion on, put viscoelastic. And because in this particular case, there was a huge subluxation, we are using a 3-piece intraocular lens. We have already put a CTR, and you can see that the lens is pretty central. Now we go back in and do from the same pars plana approach, remove the excess vitreous which has come forwards or which is actually got hydrated. And then we will switch our hands. You can see that there is a tag of the vitreous which is with triamcinolone. We have put the plug in, and we have put a suture here, and we will take the cutter from the other side. And you can see that we are putting in the infusion now from the back. And with this cutter, you can see that whatever was the was the attachment of the vitreous from back going into the wound, that has been removed in this particular case. And that is the end of the surgery. And you can see that this is the post-operative result which is there. So friends, I have been able to just tell you 2 things, that there is the advantage of the femto laser, and the second is the advantage of the vitreous decompression, which prevents the vitreous herniating into the anterior chamber. And this helps in limiting the extension of the zonular compromise. It deepens the anterior chamber, pressure remains under control, creates adequate working space, and relieves the positive vitreous pressure. It also allows safe phacoemulsification with appropriate capsule expansion and fixation devices. which are very, very important, that you have to have these fixation devices and you can implant an intraocular lens. So this is what I wanted to show, that the surgical things have to be taken care of, and the take-home messages are low fluid settings to prevent surge of fluid into the vitreous cavity. That is very important. After doing a femto, tamponade the area of zonular defect with dispersive OVD. Femto-assisted capsulotomy reduces the risk of further complications, and the technique of surgical decompression allows safer phaco emulsification in your cases. So you can therefore take care of these subluxated lenses with this proper technique after good preoperative evaluation. And these difficult situations, as one says, often yield the best rewards, and it is the most joyful experience both for the patient and the surgeon to get out of such difficult situations by using appropriate surgical methodologies for taking care of them. Thank you very much for your kind attention.
Thank you so much, Mahipal. Excellent surgery. Since we are running short of time, can we go for the last talk?
Yes, sir. We'll go ahead, and the talk is by Dr. Gokte sir. And to introduce him, I would like to call upon Dr. Manoj Satyapar sir.
Good afternoon, everyone. It's my privilege to introduce our guest speaker, Dr. Gokte sir, who is going to present pediatric cataract management. He is a gold medalist and first amongst in Shivaji University in EMS Ophthalm. He has done FRCS from Royal College of Surgeons, MSc in Community Eye Health with distinction from UK. He was also visiting faculty in so many institutes like African Vision Research Institute, Durban, South Africa, LVP. Also honorary lecturer at School of Medicine at UK. He presented more than 90 papers in national and international journals, and he is having interest in cataract surgery, community eye health, pediatric ophthalmology, and training and research work. He is presently doing private practice since 2010. He is trustee of Community Eye Cares Foundation, Pune, faculty at D.Y. Patil, Pimpri, and he is medical director of Atharva Netralaya Private Limited, is group practice at Pune. I welcome Dr. Parikshit Gokte sir to deliver his topic.
Thank you for the kind introduction, sir. Can you see my screen, sir?
Yes, sir. Visible.
Yeah. My talk is on how to improve the outcomes of pediatric cataract surgery. And I would like to thank Dr. Nitin Upadhyay, President, VOS, Dr. Viral Shah, the Dynamic Scientific Chair, and my friend, Dr. Shirish Thorat, the chairpersons, Dr. Agnihotri, Dr. Hirwani, Dr. Revanwar, Dr. Saktepar, and Dr. Mokadam. It's an honor to be presenting among such stalwarts like Lahane sir, Mahipal sir, and Amar Agrawal sir. We are short on time. I'll just get on to what we know is the standard practice for pediatric cataract surgery. We know it is cataract extraction with AV plus PPC till 12 to 24 months of age. IOL after that. The AV and the PPC can be dropped after 6 to 9 years. The IOL has to be in the bag, and well, sutures are a must. Child's eyes, they grow and develop, and the axial length changes a lot, and the maximum is in the first 2 years. In the first year itself, the IOL power changes by about 10 diopters, and there is a further change of about 3 to 4 diopters over the next decade. That's the reason why we don't put in an IOL in very young children, because it is going to change. And when we are choosing an IOL power in a child, what should we choose? Should we choose an adult IOL power in a child which is less than 2 years old? Well, with expected growth, myopic shift will occur. If we think only of adulthood, it will result in significant hypermetropia. There will be a problem with near vision because accommodation is lost, and there will be dense amblyopia. So we, I think, must choose for emetropia in children less than 2 years of age, because the amblyopia management is easier, especially for children with poor compliance, and later with myopic shift and the ocular growth. We can later do a refractive surgery, or perhaps we can put in a piggyback IOL. As I always say, if you want to choose between the emetropia now and emetropia in an adult, well, we can't look at the picture of a 2-year-old baby and looking at him stitch his wedding suit, which he's going to wear 25 years down the line. So how can we choose an IOL power for children now, saying that this is how the IOL power will be after 25 years? Well, in a unilateral cataract like this, what will we do? It's a 7-month-old infant. So yes, perhaps now because it's unilateral, we'll put in an IOL. In a bilateral cataract like this, what will we do? Will we have it in single settings or will we do it in 2 settings? And suppose we see cataracts like these, should we operate them? I think not. If we have a patient whose vision is better than 618, then it's better to wait because accommodation is going to be lost. So AVPPC till when? I think till about 10 years of age, an automated vitrector is a must. And what to do first? Well, anything, but I would prefer to first put in perhaps the lens and then do an anterior vitrectomy. I am a great proponent of manual small incision cataract surgery, but this is one place where phaco emulsification is definitely superior. And as Dr. Mahipal showed us, even femto has definite advantages because we can have a good anterior capsulotomy and a posterior capsulotomy. And even though it's a small incision surgery, suturing is a must because children's sclera have less rigidity and there are chances of scleral collapse and having wound leak later. Anesthesia, of course, nowadays we do sevoflurane, but for elder children, we can have ketamine and block, and later perhaps using laryngeal masks. And as since all of us are excellent phaco surgeons, perhaps after the age of 13 or 14 years, just using vocal and topical anesthesia is good enough. So again, IOLs to put in how early? In a unilateral, well, not before 12 months. In a bilateral, perhaps not before 30 months. And we know hydrophobic acrylic lenses are better. But this is one place where we should not put in multifocal implants. We take so much of time trying to calculate the power of a multifocal implant because we want to put in the exact power. Here we know the power is going to change for the next 15 or 20 years. So it makes no sense putting in a multifocal implant. Again, compliance to follow-up is very, very important, as we saw in the Meerut's pediatric cataract study. Just doing a good follow-up improves visual acuity by 2 lines. And this has been seen in studies in other parts of the world too. So what finally affects vision? Multivariate analysis have shown that age of surgery, preoperative vision, and type of surgery are the chief factors. So if the pre-op vision is good, the post-op vision is going to be good. Younger the child, less is the vision. Again, secondary glaucoma is very common in infantile cataracts. And it's not just about vision, it's about stereopsis, and nearly 1/3 of them do get good binocular stereo acuity after doing pediatric cataract surgery. Also, in children, traumatic cataracts give better results. This is something we had seen from series in Zambia, in Durban. Why? Because the visual system is better developed. And so if the cornea and the retina are not harmed, we generally get very good vision after traumatic cataract surgery. So I would like to summarize that visual acuity after surgery is better when preoperative vision is better. It is a developmental rather than a congenital cataract. We are using phaco or automated vitrectors. When we ensure a good follow-up and there is no post-operative uveitis. And these are series from all over the world. And you can see 3 of them are our series from India. And even here, even in the United States with Dr. Wilson series, who's perhaps one of the most famous pediatric cataract surgeons in the world, only 46.6% children have vision better than 618. In adults, we have 95% of our patients better than 618, which is why we should think twice before jumping in for a pediatric cataract surgery when the vision is good. So my final takeaway would be, in a pediatric cataract surgery, we should worry about the sphere, not the cylinder. Multifocals are a no-no. Torics are rarely needed. But children tolerate progressive spectacles very well. Spectacles will always be needed. It's best to counsel the parents about it. And finally, surgery is just one important step in a series of steps that are needed to improve a child's vision. Thank you for your patient hearing, and thanks to VOS once more for their kind invitation and giving me a chance to make this presentation.
Thank you so much, Parikshit. I think we can have 5 minutes of any questions or any panel discussion, because we have panelists with us. Any questions to the faculty?
Yeah, we have got Dr. Gopal Arora sir, Dr. Madan sir.
Yeah, because whatever little time we are left with, we'd like to really ask some questions. I have a question for Mahipal. Whenever there is a subluxated lens, is femto difficult to get a proper clean cut? Mahipal is there or he is left? Anyway, I think Mahipal must be operating. So, Parikshit, great study. You know, I really always appreciate your scientific approach to all the issues. But like we heard another talk in which they said toric lenses also been put in congenital cataracts. What is your take on that?
We would put in a toric IOL only if the astigmatism would be 2 diopters or more than that.
Okay.
In which case,
that's your
yes.
cutoff. Your cutoff is 2 diopters.
Yeah. Not 1, as it would be none other.
Ragini, any other tips for the congenital cataracts? Because you must be handling a lot of them.
Yes, sir. Lahane sir does a lot of congenital cataracts. In a week, and we get a
You
lot of
also do
referrals.
it, ma'am.
He's operated children from around 10 days old to so many years, and traumatic and all that. So the most important thing is the understanding of the mother. You always remember to give the child aphakic glasses on discharge, because if they don't have vision, they're going to go amblyopic. And it's always when to put in the IOL. So every time the child comes for follow-up, we do a proper B scan by a senior person to see whether the eye has developed enough to take in the IOL. And sir, we have never put multifocal IOLs in children.
Now, what about progressive lenses? Because this is something revealing to me also. That should we advise progressive lenses to these children? And how do you find out the the centration and everything? Yes, Parikshit?
Sir, because accommodation is lost, we always earlier would give bifocal spectacles, which is what is normally done. But if parents can afford it, then even progressive lenses, children tolerate very well, because they have a different power for use on computer, and nowadays everything is online. And of course, they use a lot of mobile phones. They have to read and write. So most of the studies that were before 2010 were all focusing on distant vision. But now this is that for children, near vision is also very, very important. And well, yes, progressive and bifocal specs are given. Mahipal sir is
good take home. Do we have Amar with us? No. I think again,
sir, one more thing is the need to explain to the patients and the parents about multiple surgeries, sir. PC polishings and IOL replacements and all. So they need to be mentally prepared for so many GA preparations, so many surgeries. Because if you leave a child with an opacity or a PCO, then the purpose is not served. So we end up doing so many surgeries in children. And one more thing is that even I don't touch pediatric cataracts when Lahane sir is there. It is very difficult to revert a botched up pediatric surgery. So, they have to be handled and they have been treated very delicately, to be done by the best, because there are so many more years to live.
Very true.
I am here. You were asking for me or whatever.
Yes, sir.
Mahipal, I'm here.
Mahipal, you're there. Mahipal, I just wanted to know when there is a luxation and if there is the anterior, how do you manage settings in femto? Like
Okay, so, settings in femto, there are 2-3 things. The most important thing is the alignment. So as I showed you, what happens is that it is a 360-degree OCT which is happening, and it is an automatic centration as to what the machine is picking up as the anterior capsule. So supposing there is a bend in the interior capsule, so you can manually change the location of what the machine has picked up on the capsulotomy. So if there is a gap between where the actual capsule is, the machine has picked up, then you will not get a capsulotomy. So that is the first thing. If there is vitreous coming out, as we saw, you could increase the energy level for the capsulotomy. That is about it that you have to do as regards the setting. And obviously the other thing in the setting is that if you have a small pupil, you can go and put a ring and then come back and do. So there are 2 parts to it. If you have put a ring and you have left behind viscoelastic, then again you have to increase the energy setting. But if you can wash it out and you are sure of the water tightness of the wound and you put one suture, actually it's in the same OT, then you really don't have to change any of the settings. The important thing is that if supposing the lens is dangling like this, there is no way that the femto can cut it. So there has to be a limit up to which there has to be a subluxation and a tilt in the capsule which is there. Apart from that, basis the cataract, if the cataract is hard or small, hard or soft, etc., you can increase the energy levels that you are using for cutting the nucleus. The essential thing is that the disassembly has to be as peaceful as possible. So that when you're using the Phaco, you don't have a turbulence in the chamber. So a pre-cut good nucleus is something very important. So if you are going on to a grade 4 cataract or a grade 3, grade 4 cataract, under those circumstances, you will wish to work with slightly higher energies for the nucleotomy. And as we do the normal settings, the energy levels used for the posterior nuclear plate are much higher than as you come higher. So it cuts from down up. So that is there are now studies to show that you need not increase the repetition rate. Otherwise, you could increase the repetition rate also for the nuclear disassembly. But if you are good enough high energy, even rep rate can cut the
any correction for the IOL power, Maipal?
No, you are expecting the whole thing to come back. So you are actually putting it in the bag only, and you are either putting a CTR or you can have a MH segment and fix it to the. So it is supposed to be at the same.
Okay.
Thank you.
Any other questions for the faculty? Because
yes, many questions are pouring in from our attendees, but I think we will.
But I think we have to hand it over to the chairpersons.
Yes, next session.
Thank you so much once again on behalf of our co-chairperson, all our faculty. I am really grateful to the faculty for such illicit talks. Thank you so much once again. Thanks, chairperson.
Thank you, sir. Thank you, ma'am.
Wonderful session, chairpersons, faculty, and panelists. So we now move with
Thank you, Prashant. Thank you, Viral. Thank you.
Thank you, Ragini. Best wishes for the election.
You are there now.
Dr. Lane is there. Sir, we look forward to you herding the AIOS.
He needs to be there as president.
Thank you.
Thank you, sir. Thank you, sir. Thank you. Thank you so much.
Thank you.
Bless you. Enjoy.
So thank you, everyone. Thank you. So now we move over to our last session of this VOS-VRCON, that is session number 7, Ophthalmology Beyond 2020. For this session, we have got our chairpersons, Dr. Praful Mokaddam sir and Dr. Shrikant Malpani sir as a co-chairperson. We have got our moderators, Dr. Abha Sonakia madam, convener Dr. Shashank Banais sir, and coordinator for this session is Dr. Naveen Soni from Amravati. We have got our esteemed panelists also joined with us, Dr. Anand Gade sir, Dr. Varsha Pandey madam, Dr. Sunil Agrawal, Dr. Rafat Khan sir, Dr. Anand Junjunwala, Dr. Durgesh Chole, and Dr. Shivani Sude. So without wasting much time, I think I hand over to the chairpersons, Dr. Praful Mokaddam sir and Dr. Shrikant Malpani sir. Sir, please.
Thank you, Viral. At the outset, I would like to thank President Dr. Upadhyay, Dr. Khandewale, Secretary, the entire fraternity of ophthalmologists from Akola for giving this chance for us to be involved in this session, the last session. We are starting exactly an hour late, and therefore we are sorry for the inordinate delay that has has already occurred. Along with me in this session will be Dr. Abha Sonakia, Dr. Malpani, Dr. Shashank Banait, and Dr. Naveen Soni. Naveen Soni is the coordinator, Dr. Banait will be the convener, and Dr. Abha Sonakia from Gondia is the moderator. To give you a little background about Vidarbha Ophthalmic Society, we all know it started 45 years back. It is 45 years that in 1975, we had probably had the first VOS conference at Nagpur. And this was because of an All India Ophthalmic Conference, which we had hosted at Nagpur in 1973. We had a huge amount left over out of the conference at Nagpur AIOS conference. And the amount was, in today's context, it sounds very petty amount, 27,000 rupees. But we really didn't know what to do with those 27,000 rupees. And therefore, the idea came to the mind of our seniors. Why not we have Vidarbha Ophthalmic Society, and why not we have our Vidarbha Ophthalmic Conference? So that's how it started. आता असं वाटतं की 27,000 म्हणजे काही चिल्लर वस्तू आहे, पण if we consider the cost of gold at that in those days, 1972, I got married, and I know I had purchased gold at the rate of 225 rupees per 10 grams. हे 225 आजचे 50,000 झाले. So if you calculate that way, the cost of things has gone up 200 times. So those 27,000 rupees which we saved because of the All India Conference, in today's context, they are worth 500 crore, 45 lakh, 54 lakh होतात. So आम्ही महाराष्ट्र ऑप्थॅल्मिक सोसायटीने मागच्या वर्षी जे सेव्हिंग दिलं त्याच्या मानाने पुष्कळ जास्त सेव्ह केलं होतं असं तेव्हाच्या कॉन्टेक्स्ट मध्ये म्हणता येईल. Anyway, but then that's how probably it's not the amount of gold or the cost of the gold and the amount of money that we had saved. त्याचा जो बेनिफिट झालाय आज माझ्या जनरेशन पासून तर आताच्या जनरेशन पर्यंत, everybody has been so highly benefited with the tremendous knowledge that has come our way. And I feel that we have done, the Vidarbha Ophthalmic Society has been doing great service as far as in improving the academic level of the ophthalmologists at large in the Vidarbha Ophthalmic Society. So without wasting much time, I will request Dr. Abha Sonakia to introduce our first speaker. This is a very interesting topics are there. It's ophthalmology beyond 2020 is the name of the topic that is given to this session. And our first speaker is Dr. Saurabh Patwardhan. He's from Sangli. I'm sure Saurabh, you are ready. Dr. Saurabh, you are ready. Okay. So here is our pretty Dr. Abha Sonakia from Gondia to introduce you. And may I request Dr. Sonakia, madam, immediately after your introduction, Saurabh, you may please start.
Thank you, sir. Good afternoon, everybody. We are here now to start our last session. So I am here introducing first speaker, Dr. Saurabh Patwardhan from Sangli, Kolhapur district. He is the director of Nandadeep Eye Hospital and PG Institute, Sangli of Kolhapur district. He is head of Phaco training and fellowship program. He is also a chief mentor of 3D coaching courses, teaching courses. He is pioneer in live surgeries on YouTube and Facebook, more than 10 publications and more than 30 chapters in various books and journals. He is inventor of toric hybrid chopper. He has a wide experience. He has performed more than 30,000 surgeries. His specialties are cataract, retina, glaucoma, and refractive surgery. He has performed live surgeries in various conferences. He is ex-member, Scientific and Managing Committee, MOS. He is also invited faculty in national and international conferences. Thank you, sir. I also invite now Dr. Prafulla Mokaddam, sir, our chairperson, who is a very close friend of Dr. Patwardhan, to give a short introduction of his friendly friend. Thank you, sir.
In fact, it is, I'm not a friend of Dr. Saurabh. His father, Dilip Patwardhan, is
Yes.
my friend. In fact, Dr. Dilip Patwardhan, myself, and five of us from Maharashtra, we had been to Israel to attend Dr. Blumenthal's SICS workshop. So we were together, Dr. Jhamar from Pune, Dr. Haldipurkar from Panvel, myself, and five of us, we were there. So since then, दिलीप नागपूरला आल्यावर मला भेटल्याशिवाय राहत नाही, अँड इट्स व्हाईस वर्सा. मी एकदाच सांगलीला गेलो, कोल्हापूरला कॉन्फरन्सला गेलो होतो तेव्हा, अँड दॅट टाइम वी हॅड बीन टू पटवर्धन्स अँड दे हॅव अ ह्यूज हॉस्पिटल देअर. सो इज द चिप ऑफ द ओल्ड ब्लॉक as we call. So Saurabh, please go ahead. Thank you.
Thank you, sir. Thank you so much for kind introduction, and also Dr. Abha madam. And at the outset, I would like to thank Managing Committee and Dr. Viral in particular for inviting me for this talk. I think this is not the typical talk of a scientific session, but I think it is beyond 2020. So what I will be sharing is few of my experiences from my experience of managing pharmacy in our eye care hospital. So what I'm offering here is a guidance based on our experience and understanding the laws of in India and specifically Maharashtra, but I am not a law or accounting professional. So do verify all the rules, laws in particularly your district or state before implementing the advice. And now the basic question is why you should consider dispensing medicines or operating a medical store. So there are 3 points which I feel are very important. One is that it helps patient to get very easy access to necessary medication at one place. That's most common demand from the patient nowadays. And it also allows you to make your preferred medicines available to patient and also explain them well once they get the medicines. And also it contributes to your revenue of the hospital. I think during COVID time, we all felt the pinch because the revenues were significantly down and still we had to manage our hospitals. Now, there are many questions on top of our minds whenever we think about, managing a pharmacy here. So there are 2 options principally for dispensing medicine. So one is dispense directly from own clinic. This is very relevant for single practitioners. And then second option is to operate a retail drugstore. Now, first part is dispensing directly from your own clinic. So what the law says about it. So I will just clarify a few things. So doctor can dispense medicines in his own clinic, just one moment, or practice without a drug license, but for those who are being treated by him. So such place is termed as in-house drugstore, and such in-house drugstores cannot sell medicines over the counter, or they cannot employ a staff or pharmacist to dispense medicines. So the medicines have to be dispensed by the doctor himself or herself. And they have to buy these medicines not from a retailer, but from a licensed stockist or distributors. A registered doctor can stock all the medicines required for his practice and dispense to patients only what he prescribes and get his consolidated fees. So you cannot give receipt of medicine to the patient, but what you have to give is a consolidated fees receipt like this. So the doctor can charge treatment charges as consolidated fees, but not by selling the medicines. So what the Indian Medical Council tells us about this, so what this section says is that a physician should not run an open shop for sale of medicine or dispensing prescription which is prescribed by doctors other than himself. So we cannot dispense in our clinic something which others have prescribed. But at the same time, it is not unethical for a physician to prescribe or supply drugs, remedies, or appliances as long as there is no exploitation of the patient. What the Drugs and Cosmetic Act tells us is that there is a Schedule K, Item 5, which exempts the requirement of a drug license. So what is that exemption? So again, to state the same, the drug supplied by a registered medical practitioner to his own patient is excluded. So if the registered medical practitioner is giving or dispensing medicine to his patient, he doesn't require a drug license if it is a single practitioner. But despite even if you are a single practitioner and you are dispensing drugs, you have to maintain the drugstore just like a retail pharmacy. You should have all the records maintained for use of those medicines in your drugstore. Now, second option is to operate a retail drugstore. This is better for group practice or where there are more than one practitioner, or if you have a bigger practice, because you cannot dispense each medicine by hand yourself. Now, to operate a retail drugstore, what basic requirements you need is a registered pharmacist, which we should have at least B Pharm or D Pharm, and it should be registered. And we need minimum 2 registered pharmacists, okay, for a pharmacy. Now, it is better to have an agreement. These are practical points. So it is better to have an on-paper agreement or bond with the pharmacist, because once we take the license in his name and in between he leaves, we have to again apply for a fresh license in another pharmacist's name. And as far as ownership of a pharmacy is concerned, though the law doesn't seem to be explicit that doctors should not own a pharmacy, but I think from various practical point of view, it is preferable to create an arm's length with the pharmacy, like you can operate it through HUF, family member, or make a LLP or partnership and run the pharmacy. So now let's come back to the economic, because if you want to start a retail drugstore, whether it is really economical or feasible to run that. So we have to consider the 2 points. First part is the revenue. So you have to calculate the revenue you are going to get from your OPD. So for example, your average OPD is 500, and you calculate the average, the prescription or the average amount that the patient is going to pay for the prescriptions. So suppose it is 400 rupees average revenue per patient. So your revenue at the end of the month is going to be around 2 lakh rupees. But if you consider the profit margin, say suppose your profit margin from the medicine is 35%, then you are going to take the gross profit of 70,000. But against that, there are some fixed costs, as I mentioned. So there might be a rent. Even if you have your own premises, there might be some other costs which are you have to bear. Salaries of the pharmacist, electricity, and other miscellaneous charges. So you may have to spend around 40,000 rupees for those, or maybe more depending on the salaries in your area. Now, if you consider gross profit minus the fixed cost, then 30,000 rupees per month will be your basic profit, operating profit from the pharmacy. So you have to understand this and decide whether you really need a retail drugstore in your clinic or not. Now, the key factors here which determine it is, of course, the monthly OPD and the number of prescriptions you are going to give, and also the right product mix to maximize the margins. I think this is very crucial. So for example, taking the same example forward. So if you have OPD of 500 monthly, and you have a brand mix which gives you a gross profit of 25%, then considering the same 40,000 as your basic cost, you will be left with operating profit of just 10,000 rupees for that month. But if you have product mix of 50% gross profit overall, then you are left with 60,000. But if you have product mix which gives you 70% gross profit with the same 500 OPD, you are left with 1 lakh rupees per gross profit margin. Local brands, Indian brands, give around 30 to 50% of the gross profit margin. While like what I do, we do a group purchase by a group of ophthalmologists. We have a group of gross profit margin. So then with this, we can increase the operating profit almost 10 times as compared to normal. Now, I'm not going to go through the details of how to open a retail drugstore because this is beyond the limits of my talk, but you can always contact me. I will share the presentation for those who want details of how to start. Just one more important point which I would like to share is that always maintain very proper record of all purchases and sales. And this is usually taught to pharmacists and they can do it very well. It's not big headache. But another important thing which many times we make a mistake once we start a retail store in the eye hospital is that you cannot make a sale to a hospital. So even if you have a retail store, you cannot buy your irrigation solutions and IOLs and etc., and then you cannot sell it to the hospital. A retail pharmacy store can only sell to a patient against prescription and not to a hospital. So make sure that you don't make this mistake, otherwise you will have issues with that. Now, managing purchases is, as I said, it's very important to choose the brands very carefully, and most important things are the 80% of your sales are made up of by lubricating drops, antioxidant, antibiotics, etc. So those have to be of good quality and with good gross margins. So always negotiate all the payment terms with distributors and also try to make it more easy. Whenever you have a purchase, always make sure you use a pharmacy software to enter the drugs in your software. It is very important to avoid any pilferages, which I will explain again later. So you have to tally that all the drugs and the exact quantities and the amount is being entered in your pharmacy software. So always it is important to maximize sell, that every prescription that you give should reach the pharmacy. So if you have an in-house clinic, in-house pharmacy, it is important that every patient you prescribe, the prescription must reach the pharmacy. Otherwise, patient may just walk away without purchasing. Also ask the pharmacist to maintain a notebook for any prescriptions that bounce. That means we couldn't fulfill. So find out the issues why the prescription bounce, and you can make corrections. Make payments easy for the patient by using QR code, etc., swipe machines, which make things very easy for the patient. And also nowadays we also courier these medicines to patients, though particularly those who require frequently these medicines like lubricating drops and anti-glaucoma medication, and it increases our sales as well. Now, managing inventory is not very difficult as many people think about. It just requires weekly or monthly audit by any third-party person or accounting team. And you just have to tally the actual stock against the stock which is there in the software. And just like as many NABH rules are there in medicines, that look alike and sound alike should be kept in different racks. And also it always generate the near expiry report. Do not keep any expired medicines in your pharmacy, which is very important. And all the manufacturers are bound by obligation that they have to take back all the near expiry or expired medicines. So we don't lose any, on that account as well. Always generate the closing report every day so that you can keep track record of the sales. Against against stock checking, look alike, sound alike, I'm just take medications, etc. It's always important to have two lock and key model, and also you must maintain a proper narcotic register to avoid any issues. Generate the near expiry report, as I said. Take out a simple record like total prescription issued, sales receipts, bounce prescriptions, reason for bounce, total sales, and this gives you daily output from your pharmacy. And this is very important aspect, patient satisfaction. So always set a protocol to be followed by the pharmacist for each interaction. So pharmacist must greet the patient, review the prescription well. Clear guidance should be given to each and every patient about how to utilize those medicines. Every medicine should be labeled, and he must give a signed receipt, which is important. And in fact, if you have an in-house drugstore, the patient satisfaction increases because all these things can be explained to the patient. For the lack of time, I will just go through this video. I will later maybe. And so this is a very important thing, that what are the main potential avenues for mischief, because that is something which we are worried about always. So one thing is that, as I said initially, that if you keep certain drugs at maybe a discount, that should be entered in the software, so that cannot be tampered by the pharmacist. And selling without bill, you have to make sure that you have a CCTV camera over your pharmacy, and make sure that every patient must receive a receipt from the software that ensures that they don't pocket the cash. The stealing, again, CCTV camera is very useful with audio recording. And also at the purchase level, I think that is something has to be done by random check, that every bill, every quantity of the medicine has to be correctly entered in your software, and that avoids these issues. Then directing patient to other pharmacies, again a CCTV with good audio and video recording is good enough to monitor the staff behavior. And weekly or monthly audit, depending on the volume of your pharmacy, is very important, and just match with the software record. In these softwares, you have a master key password, so the others cannot edit any record without your authorization. And make sure that all patients take the printed receipts. So it has to be made compulsory to avoid the pilferage. So thank you so much. To know more about the group orders, you can also contact this group number, or you can contact me if you want to know more about it. And regarding the retail pharmacy details, you can also WhatsApp me, and I can share the entire presentation with you, because there are many technical details which you may benefit from. So thank you so much, sir. This was a few things from my side, and over to you, sir.
Thanks, Dr. Saurabh. That was an excellent presentation, and I'm sure thoda वेळ exceed झाला, but then it was worth listening to all the expertise that you have and all the input that you have given. May I now request Dr. Malpani to invite the next
Rahul sir, this is a virtual conference. We would like to present a
Sure.
certificate from on behalf of VOS to Dr. Saurabh Patwardhan sir. I know he is on vacation and traveling, but even then he agreed to join us for this conference from his holidays. Thank you so much. Thank you, Saurabh sir.
Thank you, Dr. Thank you. Thank you so much.
Okay, thanks, Saurabh. And
hello, good afternoon. A very warm welcome to everyone for our last session of the day, Ophthalmology Beyond 2020. The name itself is enough to keep you glued to your seats, and we are also having many interesting talks coming up about how you can evolve your practice after 2020. Our next speaker, Dr. Deven Tuli, is a very well-known national faculty in the field of glaucoma, and will be speaking on a very important aspect of a glaucoma management, which is achieving target IOP. Just for the short introduction, I mentioned he has done his post-graduation from MAMC Delhi. He is clinical and research fellowship from AIMS Delhi. He is clinical glaucoma fellowship from USA. Now he is consultant glaucoma at Delhi. May I invite Dr. Deven Tuli, sir.
Thank you so much. A lot of thanks to Rajesh first, and then to Dr. Viral and all the team of Vidarbha. I've been wanting meetings, and the virtual medium gave me an opportunity. So in the interest of time, I'll just say this, that target IOP, I think there are so many formulas and equations that you will find how to set target pressure. But for comprehensive eye practice, this is the most easy one and the most practical one in everyday practice. So ocular hypertension and early glaucoma, I'm a firm believer that most general ophthalmologists, when they see glaucoma, 70% would fall in this category. They see a lot of early glaucoma and ocular hypertension, much more than we do, as I do only glaucoma practice. And to begin with, I think 20% reduction is a good starting point for these cases. When you are dealing with normal tension glaucoma, then aim to reduce it by 30% straight away. Moderate to advanced glaucoma is about 30% for moderate and 40% for advanced. And in my practice, there is a new category, which is a far advanced or very advanced glaucoma that I actually do a lot my practice in. And for that, we need to reduce it even beyond 40%, sometimes even 50%. That is why I request all of you, I will not know what the starting pressure was unless you mention it in your notes. My practice is mainly referred practice, and in Delhi I practice. So I tell this to a lot of my colleagues in Delhi also, North India also, that please mention what is known as Tmax. Tmax is maximum IOP. Maximum IOP was the pressure at the first documentation when you've not started meds. So that is the one which is necessary for us to reduce to by the percentage that I've mentioned, 20%, 30%, 40% respectively. Always remember that target IOP is not a single number, it's a range. So you can write, say, 14 to 16, which is mid-teens, 17 to 19 is high teens. And every visit of the patient will tell you whether you were okay with setting the target pressure, which is mentioned here. These are, remember, these are starting out points, but every visit will tell you it needs to be adjusted over the course of the treatment. So keep in mind the first one, like I said, a lot of you deal with ocular hypertension and early glaucoma. And the question asked is that when you want to start medication in that category, that is early glaucoma or ocular hypertension, which drug to start with? And my answer is you can start with any of the class of drugs mentioned in this slide. Most common in India still is Timolol. And though you can start with brimonidine, dorzolamide, pilocarpine, any of these. Why? Because for the most part, in most patients, all these drugs as single drugs should give you 20 to 25% IOP reduction when used as monotherapy. And I remind you from the previous slide that you need about 20% reduction in early glaucoma. And all these drugs are giving you that much. So that is why when the concern, and today's talk is only about IOP, when the concern is only reducing IOP, you can start any of the class of drugs mentioned here. Of course, then you have to look at other things like the side effects and all, which we are not going to dwell with in today's talk. So when you've done that, when you've started one of the medicines mentioned in the previous slide, then there could be a situation that most of the drugs will give you 20% reduction, but there are odd one out cases in which that particular drug does not meet the target. So in that case, we encourage to switch to a prostaglandin analog. Why? Because of two reasons. One, that prostaglandins give us 30 to 35% IOP reduction as single drugs, and this is unsurpassed by any other drug available to us in India for glaucoma treatment. But a lot of my colleagues in Delhi, and I'm sure that must be happening in Vidarbha also, a lot of the colleagues actually, suppose they've started timolol as one drug and they want to reduce further, they actually use a combination of brimonidine and timolol or dorzolamide timolol. They use two meds. And this much, these combinations will give you about 30 to 35% reduction that the prostaglandin also gives. So actually, when the pressure is the only concern, it's not wrong to do this. It's not wrong to use brimonidine timolol or dorzolamide timolol in place of prostaglandin. But there are two reasons why actually it doesn't make sense. It makes more sense to use a prostaglandin. One is the IOP reduction, I said. The second one is that prostaglandins give a good night and daytime control of IOP. So it's a 24 hours or near 24 hours control of IOP, which is possible with prostaglandins and may not be possible always with a timolol-like combination. So that is a compelling reason to use. A lot of us say, what about the cost? I think in India, someone from one of the panelists can tell me, in Delhi, we have prostaglandins which are now available for even 100 to 150 rupees. They're Indian products, but they work quite well for the masses. So I think that is not the concern now. Cost is not a concern. You will agree, even a brimonidine timolol will cost that much. It will be more than 150 or at times more than 200 rupees. And please remember, the golden rule in glaucoma management when you're using drugs is mentioned in the last line of the slide. Always use single drugs when they are possible. Don't jump to starting therapy with a double drug because you will not know which one is effective out of the two and also which one is causing side effects. So the golden rule must remember, and like I said, 70% of the practice for most general ophthalmologists in glaucoma is to manage early glaucoma. So please use single drugs when possible. Yes, there will be situations when you're forced to, and that is what I take up next. So at times we may get the patient straight away with a moderate glaucoma. It happens a lot with our patients coming in late because glaucoma being silent. In that regard, you're supposed to use two meds straight away. And in that regard, again, the rule I'll tell you, two medicines you're supposed to use or you're forced to use. And if one of them is not prostaglandin, because that is the one which is giving the highest IOP reduction, then that is not considered a good practice now. So whenever you're using more than one drug for the need to, you need more IOP reduction, then it is a must to keep in mind that one of the drugs should be a prostaglandin. The second one, if I'm forced to use two meds with a prostaglandin, I always prefer a combination therapy. The reason being because patient is still using one bottle, so the compliance is much better. And also the combinations give a much reduced overall preservative exposure. So this is the reason to use a prostaglandin timolol as a second line medication when you're dealing with moderate glaucoma. A lot of our colleagues in Delhi, again, North India, are now, because of heavy marketing, they are using a brimonidine brinzolamide combination straight away. Now, I told you, this is not bad. If it meets your target, it's okay. In your practice, it's okay, it's fine. But remember that prostaglandins give that advantage of good 24-hour reduction. So keep always that in mind and then decide your therapy. Now, what happens? I said you use a prostaglandin and timolol. What happens if timolol has side effects? You cannot use timolol in that particular patient, then of course you're supposed to use 2 bottles separately. And like I said, I impress upon you, one of them, it must be a prostaglandin. Then how to choose your second drug? This is the guideline. I would add brimonidine as my second drug because of its unique mechanism of further enhancing uveoscleral outflow. And also if there is any drug available in India which has some neuroprotective effect, it is brimonidine. That is why, because of this, it is very important to use it in normal tension glaucoma and advanced glaucoma. It's a good drug to add to prostaglandin in these situations. Dorzolamide, brinzolamide would have that enhancing ocular blood flow effect. So if that is a concern, it's a good drug to add to prostaglandin when timolol cannot be used. And pilocarpine, I'm using a lot of pilocarpine in my specialized glaucoma practice because it's a wonderful drug. Please remember this. When no other drug works, pilocarpine still works. And it's a good drug to use in pseudophakic and aphakic situations because then accommodation is no longer a problem. What happens if target IOP is not met and you are supposed to use 3 meds? I've already said, more than one drug, one of the first drugs should be prostaglandin always. Then we can use, and you're supposed to use 3 meds, so we can use a combination of brimonidine timolol, dorzolamide timolol, or pilocarpine timolol as per the consideration of the previous slide. And 3 drugs in 2 bottles. This is known as maximum tolerable therapy, in short is MTT. When you add a short course of acetazolamide, that is Diamox or glycerol, then that is known as maximum medical therapy. So please be aware of this. 2 bottles is the upper limit of medical practice of treating glaucoma with medical drugs in my practice. 2 bottles se upar hum nahi dete in most patients. I'll tell you why. So maximum tolerable therapy, remember this term, 3 drugs in 2 bottles, but now that has changed now because I mentioned that brimonidine and brinzolamide combination is available now. So that maximum tolerable therapy still is 2 bottles, but now it can contain 4 drugs, where the first bottle will be a prostaglandin timolol combination, and the second can be a brimonidine brinzolamide combination. This is the new maximum tolerable therapy. However, if one of these drugs, that is, there are 4 drugs here, if the patient cannot tolerate one drug out of these, any one, then you can add the new ones available in India for the last 1 year odd, is the ROCK inhibitor, where, of course, because this is not available in India in combination with any other, so in that will be the rare instance in my practice where the patient will be using 3 bottles. Mind you, 3 bottle कब use कर रहा है? जब एक drug इनमें से अब उसको tolerate नहीं हो पा रहा. That is the only situation where we use 3 bottles. Otherwise, my practice, medical management, 2 bottles. So what do you do after that? And this is my last slide, Chairman sir. The treatment algorithm that we follow is beyond drugs starts here with laser trabeculoplasty. I use it as a supplement, and it will give us 4 to 5 millimeters of mercury further reduction than what those 2 bottles could do. This is the 2 bottles I've already talked about. Beyond that, we use laser trabeculoplasty. If I can make it easy for you, I use laser trabeculoplasty as another bottle of medication, but actually it's not medication, it's a laser. So this is good if the patient needs 4 to 5 millimeters of further IOP reduction to meet the target. मान लो example देता हूँ, अगर आपका target था 16 और patient को with the 4 drugs, you could get it down to 20. अब 4-5 millimeter और further reduce करना है, उसके लिए आप trap कर सकते हो, you can do it. But I would offer a laser trabeculoplasty as a supplement, and it does that. Charge का जो difference चाहिए, in most situations I can achieve it, though we may have to repeat that after say 1 year, 2 years as the case may be. So when all these above fail, then we use trap. We are using mitomycin C and releasable sutures in all our traps, but we vary the mitomycin to even 0.1% to 0.4% depending on the severity of glaucoma. And if the trap fails in a occasional patient. Then we have now a retrab option, but we have glaucoma drainage devices. We have 2 of them now. Our glaucoma valve is becoming costly and costly and costly. So please remember this. The RD, the Orolab drainage implant, is costing just 2,500 rupees because we order in bulk in my practice, and it's made in India. It is a future. So remember this. This is what we do to meet the target IOP. We use prostaglandins first, then a prostaglandin timolol combination. This is 3 drugs in 2 bottles, 4 drugs in 2 bottles, and beyond that is beyond medication, like I said. Thank you again for the opportunity. I'm grateful to everyone in Vidarbha Ophthalmic Society for allowing me to present today. Thank you.
Thank you, Dr. Deven. It was an excellent presentation, crystal clear ideas. You really made the ideas very clear, and you made it absolutely, it was an enlightenment to listen to your talk. Only thing is, I specifically used listen to your talk because we could never see your face all through your
Sir, it was a special software I used because of the highlight. I hope you could see the pen highlighting all through.
Yeah, we could.
So because I use that software, so my video goes away, sir. You can see my face. It's not so, it's not worthy seeing, but you can see my face. Thank you again. Thank you, Rajesh. Thank you, Dr. Viral, and thank you, everyone.
Right. Dr. Manthani, may I request you to invite our own Akola person, Dr. Shirish Thorat.
Hello. Now I'm inviting our own Akola Academy of Ophthalmology member, Dr. Shirish Thorat, dynamic surgeon, fantastic human being, and currently Secretary Maharashtra Ophthalmic Society. He will delivering his talk on management of PC tear by anterior segment surgeon. A very important topic for all of us.
Thank you, Dr. Malvani, sir. Thank you, Dr. Viral and team VOS for the opportunity, and congratulations for the wonderful conference. Actually, my talk doesn't fit into the ophthalmology beyond 2020. It is near to 2020, at the most 2020. Friends, even after the advances of machineries and surgical skills, the incidence of PC rupture is there. So every anterior segment surgeon must follow some basic rules. These are some of the eyes which are at the high risk.
Girish, your screen is not visible fully.
These are some of the eyes which are at the high risk. The anterior segment surgeon or any surgeon must not fail in identifying the early signs of PCR, like sudden deepening of the AC, pupillary snap sign. This red glow is a clear indication. So these are 3 signs which one should not miss. Later on, you can have inability to emulsify the nucleus, loss of nucleus pieces, and tilting of the nucleus in the vitreous at the later stage. There are some do's and don'ts everyone must follow. Maintain anterior chamber at any cost. Before removing the Phaco probe, remove the viscoelastic by the side port, and then remove your Phaco probe with continuous irrigation on. This will reduce the chances of tear extension. Friends, don't be panicked and don't remove your Phaco probe immediately. It will cause extension of tear. Don't chase the nucleus with the Phaco or the vectis that will cause the retinal tear. There are many factors which manage PC tears, like size of tear and stage of the surgery. We'll see it case by case. Like in this case, this is a small tear, but irregular, and chances of irregular extension are there. So try to convert this tear into the rhexis. Like in this case, the tear is getting converted into the rhexis with the help of forceps. And believe me, the posterior rhexis is much easier than anterior rhexis. Once it is done, you can put an IOL in the bag as a regular case. This is a scenario 2. This is the most common position where rent occurred while emulsification of the last piece of the nucleus. You can see the rent has occurred. Now, primary importance is Don't allow nucleus pieces to fall in the vitreous. Take the help of triamcinolone. Try to remove each piece as early as possible. Do the vitrectomy by side port by maintaining the closed chamber. This is very important. The tricor stains the vitreous very, very nicely. It will reduce the chances of extension of tear and vitreous loss. Once it is done, you can put in the IOL with the optic capture. This is scenario 3. Friends, in this case, the surgeon has not recognized the PC tear early, and he has continuing doing the Phaco, and he has recognized the tear when pieces started getting inside the vitreous. You can see the pieces are moving, not getting emulsified. He has not strict to basic principles. Now, there are many options for these cases. Very interesting and tricky situation. One piece in the vitreous, one piece in the bag, and one piece in the AC. So you should apply many things. We have managed this case like, while removing the first piece, we're trying to get it out, but it is going down, and it is happens usually. So we've taken the help of pars plana vitrectomy, removed the first piece, and with the help of PAL technique and vitrector, took out the second piece in the safest zone of the iris plane. Vitrectomy has already been done and emulsified it safely. Pupil started to getting down, which happens usually. So iris hooks were applied, and with the help of vitrector, tractions were released, and the third piece is returned by the vitrector. After that, IA was done, and intraocular lens in the sulcus is active optic capture done. This technique, which is described by Dr. Professor Amar Agrawal, is very, very, very useful technique. In cases of multiple pieces with the rent, you just take out the pieces in the AC, do limited vitrectomy, and put in the intraocular lens of patient's own power inside in the sulcus, so it prevents all pieces getting into the vitreous. So you can have a Phaco, or you can remove the vitrector. So pieces are not going inside. Only thing is that you should have a good viscoelastic, and in this situation, you should apply more suction and less cutting rate. There is always a debate between anterior and posterior vitrectomy, but one must assess the situation and decide accordingly. Like in this case, everything is fine, but tear has occurred in the last step. So now this tear, while repairing, is getting bigger and bigger, and you can see the initial tear and the final tear. The size is very large, while the same situation where pars plana root was taken, and you can see that the vitreous is literally getting into the vitreous cavity and not extending the tear. The tractions were released, IOL is there, IOL is put into the bag, into sulcus. You can see the size of rent, which is almost equal. There are different pros and cons. Like in the posterior approach, vitreous is getting into the vitreous without disturbing the much vitreous, and you can see the tear shape is at least. So there are the irregular chances of tear extension are very less. While in anterior vitrectomy, you are pulling it out against gravity. So the chances of extension of tear is very large. These are some of the examples where pars plana irrigation save your life. Like in this case, this is a tilting of the nucleus while doing the Phaco. It must be a posterior polar cataract. But only applying the pars plana irrigation lifted the nucleus like anything, and you can remove the nucleus by SICS method. This is another scenario where the corneal opacity patient, hard cataract, usually should be done SICS. So one piece in the bag, second is going into the vitreous. First remove the piece which is inside, convert the Phaco into the SICS or ECC, remove the piece which is in the AC, but by that time, the second piece has gone. But now see the magic. Only applying the pars plana irrigation, the piece has come out like anything. You can see piece has literally lifted in. So these are definitely a benefit of pars plana approach. This is a technique of pars plana. This is for anterior segment surgeon. The conjunctival and scleral entry should be separate. The direction of the entry should be toward the optic nerve so as to avoid the injury to the PC and zunules. Once it is done, you can do the pars plana vitrectomy. This is the distance of sclerotomy site from the limbus in mm. Pars plana vitrectomy has definitely a learning curve. Trocar is needed. You can borrow it from your retinal surgeon, or knowledge of indirect ophthalmoscopy is must. This is a flow chart of management. In early nuclear nuclear pieces are there. Do proper vitrectomy, assess the situation, and type of IOL you can decide according to the situation. While in the late stage, if highlight phase is not broken, IOL should be put in the bag. If it is broken, 3-piece IOL in the sulcus optic capture should be done. My last slide is minimize the extension of tear and the vitreous loss by early recognition of sign of PCR. Don't miss the early sign. Maintain the closed chamber, which is very important. Safely remove the nucleus piece each and every. Don't chase the nucleus in the posterior vitreous. Avoid fishing out of the piece. Use triamcinolone to stain the vitreous. Place the IOL if possible. Suture the wound. Post-op follow-up with indirect ophthalmoscopy is must. Friends, always keep vitrectomy machine and 3-piece IOL ready in your operation theater. Anterior vitrectomy should be done through side port. Pars plana vitrectomy is a handy skill one should learn. Don't hurry in the putting IOL if nucleus piece is in the vitreous, which makes the job of VR colleague very difficult. And before taking patient out of the OR, make sure that AC, that is anterior chamber and pupillary area, is free of vitreous. Thank you.
Hello. May I request Dr. S.G. Hussain, past president VOS, to present a real memento to Dr. Shirish Thorat.
Malpani, you may please invite
Hello.
Dr. Swapnesh Sawant.
May I request Dr. Naveen Soni, coordinator, is ready?
Yes, sir. Very good afternoon, sir.
Yes, continue.
I will like to introduce Dr. Swapnesh Sawant. He is a vitreoretinal surgeon and he is a director at Anidip Eye Hospital in Mumbai. He has done his retina fellowship from Shankar Nethralaya, Chennai. He has also done a fellowship in retina at Moorfields Eye Hospital in London. He was a gold medal at MS examination. He is a winner of Best Scientific Paper in MOS 2015, winner of Dr. B.G. Kelkar Award for Young Ophthalmologist at MOS 2008. He is also winner of Gold Medal Award at IIRSI in 2018. He was a retina consultant at JJ Hospital and Bachu Ali Hospital from 2010 to 2015. He was the secretary of Bombay Ophthalmology Association in 2020-21 year, and currently he is a secretary in scientific committee in MOS. Dr. Swapnesh Sawant, sir.
Thank you, Naveen, for that kind introduction. Am I audible?
Yeah.
Yeah. So first of all, thanks to the entire managing committee of VOS. Dr. Viral, in person, thank you so much. And it's your consistent effort that has made this conference a great success. A big regard to all the seniors on the platform, all the seniors from the MOS managing committee too. So without much ado, I will just share my screen. Is the screen visible?
Yeah, it's visible.
So I'll quickly go through 3 or 4 common scenarios in a proliferative diabetic vitrectomy. As rightly put forward by my previous speaker, Dr. Shirish, Pars plana vitrectomy is a very important skill that all of us should be aware, whether it is an anterior segment surgeon or a posterior segment surgeon. And one important point which I would like to add in that is, once the trocar cannula is inside the vitreous cavity, you should use the light pipe to ensure that the trocar cannula is seen inside the vitreous cavity, and then only the irrigation should be put on. Otherwise, even before starting anything, you could land up with choroidals. So PDR throws up a lot of challenges, which is complex vitreoretinal interface, ischemic process in the diabetic retinopathy, and control of hemostasis is the cornerstone of success of this surgery. We require a detailed preoperative systemic workup of these patients, and a special mention should be given to the renal profile. Many of these patients are on dialysis, and I do advise my patients to have non-heparinized dialysis at least 2 turns before taking up for surgery. Obviously, the anticoagulant should be stopped, but these patients should be counseled that they can have rebleeds. Preoperative assessment should be carried over from cornea to the optic nerve, and each and every aspect of proliferative diabetic retinopathy should be examined, including examination for neovascularization at the angle. B scan should be performed in cases where the media is very hazy, and preferably by the operating surgeon himself. It's good to look at the previous FFA and the OCT reports, because if there is an underlying ischemic macula, we can prognosticate the patient. So first is a very common scenario. Again, a 3-port vitrectomy. Nowadays, with the modern vitrectomy machine, this has become quite easy. No sutures required. We have to examine the anterior hyaloid phase and see for the vitreous and the subhyaloid hemorrhage as seen in this video. It is very important to finish the vitreous cutting in the first phase itself. And the vitreoskisis is always present in these patients where the vitreous is in multiple layers. Once you have finished cutting the vitreous near the ports, you can approach the core vitrectomy and then proceed towards the posterior vitrectomy. As you can see in this particular video, now you see an opening in the posterior hyaloid, which is where you know that you have entered the correct plane, and you have to use that particular reference and try to dissect the vitreous out, because once you are in that space of the hyaloid, that means you know that most of the vitreous is anterior to the cutter and less of vitreous is posterior to the cutter. It's now possible to trim this fibrovascular polyps, and with a great fluidics of the newer machines, we can easily suck out the pre-retinal heme. There is also an option of backflush, which we can separate out these tough clots and then liquefy them and then remove them. So the second case mainly I want to highlight is one of the most important steps of diabetic vitrectomy is the PVD induction. So in interest of time, I will just move to that particular step. And so this particular thing is very important. You can have vitreoskisis over here, but the trick over here is once you are lifting the vitreous, you have to see all the clots moving away. If only 1 or 2 clots are moving away, that means you have not caught hold of the entire posterior pole vitreous. Also, it is important is not to dissect out too much of core vitreous, because you should leave behind some volume of vitreous for the cutter to pick up. And when you are lifting up the vitreous, you should be also aware that you are not creating any peripheral breaks over here. Also important to mark out the skip areas over here and do a good fill-in PRP once you have finished the surgery. So induction of the PVD is very important. You can see over here that there is a fibrovascular polyp, and you should go all around it and not try to tease it out. With the modern bent tip endolaser, it is easy to do endolaser in the deepest of the corners, and surgeon needs to be ambidextrous. But with the bent tip of the endolaser probe, all these things have become quite easy, and you can access the most difficult areas even in a phakic patient. The next level of difficulty is a combined RD, where you have a rhegmatogenous component along with a tractional component. And if the SRF is extending beyond the equator, as you saw in this particular case, it's good to put a belt buckle before even approaching the vitreous cavity, because this is going to behave both like a diabetic retinal detachment as well as a rhegmatogenous retinal detachment. So it's good to support the periphery because there is a lot of retinal contraction along with the vitreous contraction. Now the problem here is the retina is mobile below, and you are trying to tease out this tough apexes or epicenters of the fibrovascular polyps with your modern instrumentation, and the retina being mobile below is going to make your job more difficult. So don't forget to use the LPFC, which will act like a third hand and keep the retina behind, which will make your anterior dissection and anterior trimming of the vitreous more easier without creating more iatrogenic breaks. This particular patient, I have given pre-operative anti-VEGF injections, which made the bleeding throughout the surgery minimal. Also, you can use the foot switch control of the IOP in the modern machines whenever you see a bleeder. It's good to use a lot of endocautery. It's good to use control the bleeding there and there itself and not leave it for the last step. Because if you see better, you can do better. Now, this particular case, you would imagine that most of the dissection is done, and I have cleared most of the fibrovascular polyps lying anterior to the retina. But beware of what lies beneath, and don't forget to look for something below the retina. And what you're seeing here is a thick band of SRG, subretinal gliosis, because in this chronic retinal detachment, one particular thing that you would also have is a thick band of SRG. And if you don't remove it, the retina is not going to settle over there. I would request the moderator to just prompt me if I'm nearing my finishing time. So you can see this, the forceps has been approached through a retinotomy, and there is a removal of the subretinal band, and you can see what a large subretinal band it is. So if you don't remove this, the retina is not going to settle. And the rest of the steps are doing an FGE and doing a lot of endolaser and then putting the silicone oil. Also, not every time is the retina detached, but we also see a lot of tabletop tractional retinal detachments. So there could be small breaks below. This particular case, I tried all the heroics to remove the posterior vitreous, use the cutter, use the forceps, but it was too tough. And finally, I had to use a 24 gauge needle to actually cut off the roof of this tabletop fibrovascular proliferation, posterior hyaloid. And then only I could approach the hyaloid space. And after that, the dissection went on smoothly. So this particular scenario, very, very common in tabletop detachments where the retina as well as the anterior proliferations are stuck together in a very tough manner. And if you try to yank it off, if you try to forcibly use vacuum and remove it, you're going to create a lot of breaks and bleeding. And this is the use of a simple 24 number needle to actually dissect out these tabletop detachments and create an entry in the hyaloid phase, and then use your modern cutters which act both like scissors as well as forceps to access this area and to dissect them out. So because of the port optimization, that is having a port very close to the end of the cutter, the dissection, desegmentation, delamination has become very, very easy. And again, hemostasis in all these cases is very, very important. We would be also facing situations where there are a lot of epiretinal membranes that our diabetic patients do have. I don't do ILM peeling in each and every case, but if it is documented on OCT that there is a significant retinal edema and traction underlying a epiretinal membrane, I try to remove it in the same setting. It could be challenging because it is not like any other macular hole or a ERM where the membrane, once a leaf is lifted up, the dissection proceeds very smoothly. These membranes are more sticky, they are adherent at multiple points, and they have surface capillaries which can ooze below. So do a lot of staining and restaining, and once you achieve that, then the dissection can be done all around up to arcade to arcade, all around the fovea. Mind you, if you have used the IVTA, it can cause a pseudo membrane on top of the retina, and you would be falsely dissecting only that pseudo membrane. So you should use the blue dye along with the IVTA if you have already used it for induction of the PVD. So these are few pre and post-op photos, and common complications of PDR as listed. We have to be aware in cases of recurrent vitreous hemorrhage that is there an anterior hyaloid fibrovascular proliferation. So that's why the first step of dissecting well at the sclerotomies is very important, and examination of these ora areas as well as the sclerotomy areas before closure is important.
You may wind up, doctor, please.
Sure. So that was my last slide, and we have already discussed the role of anti-VEGFs. Thank you very much for a patient hearing, and congratulations again to the organizers.
Thank you. Thanks a lot. May I request the next speaker to be ready? It's Dr. Anil Shah, and I request Dr. Banait to introduce Dr. Anil Shah.
Dr. Banait, unmute.
Banait?
I think he's muted, sir.
Okay, okay. I'll start again. Yeah, yeah.
Good.
Yeah. Yeah. So, thank you, sir. So, I would like to welcome Dr. Anil Shah. Dr. Anil Shah is a consultant ophthalmologist working at the Suryakanta Dolanche Hospital, Nandurbar. Having done his MBBS and MS from Pune, BJMC Pune in 1985, he has started his own practice at Nandurbar since 1986. Along with a good clinician, he is a good researcher as well. He is recipient of many multiple awards, 2 of them coming from own MOS. He has got a research award for development of snare for manual SICS, and also a development of a large foldable IOL for MISS. He has also received an award for development of modified intracystic implant for the DCR surgery. Dr. Shah has also contributed to the academics in form of multiple books that he has authored. One of the books is the Manual Phaco, the Best Out of the West. The second one is the Master's Guide for SICS, and also Oculoplasty Made Easy by Dr. Shah. He has been called to various national and international workshops and seminars to demonstrate his clinical skills. On behalf of Vidarbha Ophthalmic Society, I am welcoming Dr. Shah to give his talk on pterygium surgeries. Thank you, sir.
Thank you very much for my introduction. I am thankful to Vidarbha Ophthalmological Society, the President and Secretary. And today I am presenting a new technique for pterygium surgery. Hope you like it, and I want more opinions from the house regarding this technique. Can I share my video?
Sure.
Aaji.
Dear colleagues, I am Dr. Anil Shah from Suryakanta Hospital, Nandurbar. Today I am presenting.
Dr. Shah, please open your presentation first, then do the screen share. Can you just stop share? First open your video, then do the screen share.
Okay, okay. बरोबर. चालू करू स्टॉप करा स्टॉप करें चालू करें पहला ते ओपन कर Is it okay?
Yes.
Perfect, sir. Perfect.
Yes, we can see. Yes, please go ahead.
When it comes to content, secretion, from Suryakanth Hospital, Vidarbha, today I am presenting a new approach to pterygium surgery. Never let the tear tenons and subconjunctival tissue. Tenons is most notorious tissue. When it comes in contact with tear secretion,
We can't hear you properly.
causing edema of tenons capsule. And if the infection occurs, it can cause
Voice.
edema. It's very long time to resolve, and if gradual occurs,
Usha, can you just can you
Probably it's a
either
recorded thing.
conventional method is mitomycin.
He can stop the recorded voice and instead.
Dr. Shah, can you take over the voice? The voice is not coming.
Okay. Sir, okay.
It's better that you talk directly. That is
Okay,
better.
I'll talk.
Drawbacks are
वो recorded mute कर दीजिए.
Okay, sir, I'll talk. It can cause hydration of the tenons, causing edema. If infection occurs, it can cause granuloma. So meticulous anastomosis is required to avoid the complications. Can you hear, sir, now?
Yes.
Pathophysiology of regrowth. After excision of the pterygium, the microscopic subconjunctival fibrovascular tissue remains. Regrowth occurs when it comes in contact with scleral bed. Edema occurs when tenons and subconjunctival tissue occurs when it comes in contact with tear fluid. Now, aim of my technique is avoid recurrence and regrowth of pterygium, avoid hydration of tenons capsule, avoid granuloma formation, and fast recovery. Principle behind my technique is conjunctival graft acts as a barrier between scleral bed, tenons capsule, and subconjunctival fibrovascular tissue. As the tissue loses its contact with tenons and scleral bed, it starts regressing. Because of the graft, tenons and subconjunctival tissue doesn't come in contact with tear fluid, so there is a least chance of subconjunctival edema and granuloma formation. Many advantages of my technique are there. 2/3 of the graft is below subconjunctival space. So graft remains firmly adherent to sclera. Graft doesn't dislodge with eye movement. There is no need of suturing of the graft. Conjunctival graft below subconjunctival space acts as a barrier, which prevents regrowth and subconjunctival fibrovascular tissue. So there is no recurrence of pterygium. Minimum suturing is required. Inferior tenons is also sutured to inferior limbus. So there is no bare sclera left open. So conclusion is that conjunctival graft acts as a barrier between bare sclera, tenons, and subconjunctival tissue. It hampers the regrowth of pterygium. Inferior limbal tenons, bare areas also covered by suturing. This acts as a barrier to tear fluid to come in contact with tenons and subconjunctival tissue. So there is a least possibility of hydration and tenons granuloma formation, and anatomical apposition is achieved. Now here the video is showing subconjunctival dissection is done and pterygium is separated from subconjunctival area. The pterygium is clearly demarcated. Now the base of the pterygium is excised. This is routinely what we are doing. Then the apex is peeled off from the cornea with a 15 number blade. Now the conjunctiva is sutured. I am using steel suture, 50 micron steel suture, but you can use 10-0 monofilament for this suturing. So the superior conjunctiva and inferior part of the conjunctiva is sutured, and only small bare sclera is left open. Now inferior limbal conjunctiva is also, a graft is also taken from inferior limbus. Thinnest possible graft is taken. Now the conjunctiva, now the tenons attached to the conjunctiva is also excised. whatever the small fragments of tenons are there, they are also excised. Now this conjunctival graft is taken. Now this conjunctival graft is taken from the inferior limbus and it is shifted to the bare sclera. Now the main important thing is that most of the graft is placed below the subconjunctival space. About 70% of the graft is placed below the subconjunctival space, 2/3, and 1/3 is kept on the bare sclera. Now with these bimanual instruments, the graft is firmly adherent to the bare sclera. The graft is below the subconjunctival space, so it acts as a barrier. So the scleral bed is not touching the conjunctiva, subconjunctival space. This is firmly adherent. So this graft doesn't require any suturing. And even if the patient moves its eye postoperatively, it doesn't dislodge. So the graft is firmly secured to the sclera. Now inferior conjunctiva is also sutured to limbus. The aim of my technique is that we should not leave any bare sclera open so that tear fluid should not go below the subconjunctival space and should not come in contact with the tenons and subconjunctival tissue. If this occurs, then we can get hydration or granuloma formation and recovery is also delayed. These are the steel suture which I am using. They are they need not remove also. It doesn't cause any harm to the patient also. Now this is a second day follow-up. The graft is also there. There is some hemorrhage. This is the 10th day follow-up. The graft is also there. Then pterygium has regressed and quiet eyes you can see on the 10th day also. This is another patient 1 month follow-up with graft is also there and a very quiet eye you can see. Now this is another patient preoperative picture and this is 1 month post-operative follow-up of the same patient. Thank you very much for your kind attention. Hope you like this technique. I am thankful to all the members of the Vidarbha Ophthalmological Society for giving me an opportunity to present my views on this technique. If anything is different, then I want some questions from the audiences so that I can improve myself and I give improve myself. So please let me know how is this technique.
Yes, the technique sounds very simple. One thing I wanted to have clarification about, when you put the graft,
yes,
which surface, the anterior surface of the graft is facing the sclera or it is up? When you put the graft?
No, I have directly shifted the graft from the inferior limbus and
yes.
Same as we are performing in suturing of the graft, the same way the limbal area is towards the limbus and other area goes below the subconjunctival space.
No, but the anterior surface of the conjunctival graft is facing anteriorly or?
Anteriorly.
Anterior. So it is as it is, you just shifted there.
Shifted and kept it below subconjunctival space. That is more important. Yes. Rather than suturing.
Okay. So let us see. It sounds to be a very easy and good technique. So now may I request, thanks Dr. Shah, and I'm sure yes, ma'am. Dr. Malik, you wanted to ask something?
Yes, I have two questions in fact for Dr. Shah. One is that why the graft is taken from the limbus. Generally, we take our graft from the superior limbus because that gets covered by the eyelid. Why has he chosen the inferior limbus to take the graft from? And my second question, or shall I ask it after he answers this one?
No, you can take it from superior limbus also, but I am used to practice from the inferior limbus, so I am taking it from the inferior limbus.
no particular reason, that means. There's no particular specific reason.
No specific reason. You can
My
take
second question is, the steel sutures that you're using, you said 50 micron.
Yes.
Don't they irritate the patient?
No. The knot is such that it doesn't cause any irritation. It is biologically inert. There is no reaction, so there is no need of removal also. So because of that reason, I am using steel suture for many years.
Well, madam, I think what he says makes sense, because Dr. Daljit Singh used to put 13 interrupted sutures, steel sutures, and they never used to hurt. I mean, it was amazing. I had attended his workshop at Amritsar way back in 1983-84, and I have seen him putting in every single case. He used to put in a cataract, and his implant he used to put 13 sutures in every single case, interrupted sutures, without any problem for the patient.
Without any problem, that is true.
And he never used to remove his sutures.
No need of removal also.
Yes. So I agree. Well, thank you, Dr. Shah. I remember I had already attended your surgeries earlier.
Yes,
I had seen your snares using, very comfortably used to split the nucleus and take it out through the SICS.
Yes, sir.
Of course, that was long ago.
Yes.
Right.
I have been to Nagpur for demonstration also, sir.
Yes. We remember. Thanks a lot, sir. And Viral Shah, you would like to present him the memento? Of course.
Online,
yes. It's there. It's there. Right.
Okay, sir.
So please accept it on behalf of the Vidarbha Ophthalmic.
Yes, sir. Thank you very much.
Thank you, Dr. Shah.
Okay, sir.
May I now invite our next speaker? She's Dr. Rutika Lokhande. She's going to talk on, "Oh, doctor, I got a headache."
Presentation.
Yes, sir. Good afternoon, sir.
I will like to introduce Dr. Rutika Lokhande, Madam, in a short. Dr. Rutika Lokhande, she has done her MBBS from NKP Salvi Institute of Medical Sciences, Nagpur. She has done her DNB and fellowship in pediatric ophthalmology and strabismus from Arvinda Eye Hospital. She has multiple presentations and publications in state and national conferences. And she is a colleague at Amravati, and she has taken Amravati by a storm by her good knowledge of pediatric ophthalmology, neuro-ophthalmology, and strabismus. Dr. Rutika Lokhande.
Thank you, sir. Thank you for the kind introduction. I would like to thank Vidarbha Ophthalmic Society for giving me the opportunity to present on this platform. So today's topic of discussion will be orthoptic evaluation. It is a case of a headache. Headache is a headache for both patient as well as treating surgeon or treating doctor. Since it is a recurrent complaint, patient will come again and again with headache. There is no definitive diagnosis to it, and there are a ton of multiple etiologies. It can be ophthalmic and non-ophthalmic origin. Obviously, we are more interested in the ophthalmic origin. Technology in our life has simplified the way of living, but has added a lot of complexities, especially to the visual system. Compared to any other vision disorders, binocular vision disorders are most common and are often missed. With the inception of these computers and gadgets, especially in the post-COVID era or after the lockdown, the unseen problems are on the rise. Parents wander from pillar to post for their child's constant complaint from the near work. Despite of best spectacle correction, the child wearing, and avoidance of excessive near work, the complaints will be continued. So this is the 4 children in every classroom will see the print this way. So basically this is a diplopia. Many of the time children will not be able to express the feeling that they are seeing it double, and they will just start ignoring the studies. So the other astigmatic symptoms which we can get are blur vision, double vision, headache, focusing difficulties for various distances like near and far, sleepiness during reading time, or missing the lines during the reading. Headache is the most common complaint. A study has shown that headache was a presenting complaint in 43.5% of the OPDs. So coming to the main topic, orthoptics, it literally means straightening of eyes. It is the specialization in ocular motility and visual development, which focuses on non-surgical treatment of non-strabismic binocular vision disorders. So orthoptic evaluation is a systematic step-by-step phenomenon of evaluation of efficacy of eye muscles and vision-eye coordination. Eye-brain coordination, sorry. So the three arms are important for orthoptic evaluation. One is convergence, accommodation, and binocular single vision, fusion, and stereopsis. So BSV stereopsis can be tested with TNO charts and Titmus fly test. Everyone knows it. By fusion, initially synaptophore was used for testing all these. So I'm not going in detail of this. We will see today the in detail accommodation and convergence evaluation. So coming to evaluation of accommodation, there are 6 components of accommodation we are supposed to evaluate. First is amplitude of accommodation. This is the maximum amount of accommodation an eye can exert. So this facet of accommodation is most relevant to clinician, and most oftenly this one is the only tested clinically in routine practice. No other components will be tested. So basically it is the measurement of NPA, that is near point of accommodation. Everyone is aware of it. So I'll just skip this. Tonic component of accommodation. This component is due to the presence of the passive state of accommodation without any stimulus. This component is most important for pediatric eye examination. So basically, whenever we get a variable refractive errors, variable results in the pediatric patient, a complete cycloplegia is must. Coming to the next component, that is accommodative convergence, formerly known as AC by A ratio. AC by A ratio basically measures the accommodative convergence that occurs when the patient accommodates or relaxes the accommodation. So most commonly, it can be calculated with the gradient method. In gradient method, the original deviation with a full refractive correction is measured. And again, it is measured with a known power of lens. So with the following formula, we can use the AC by A ratio, or we can calculate the AC by A ratio. Normal is 3 to 5. More than 5 is considered to be the high AC by A ratio. Coming to lag or lead of accommodation, the amount by which the accommodative response of an eye is less than the dioptric stimulus is known as lag of accommodation, and the amount of which the accommodative response is much more than required or than the stimulus of the dioptrics for accommodation is known as lead of accommodation. So basically, this is very easy. The patient is asked to fixate on a target. The targets are attached to the retinoscopy head. The patient will fix on the near point or near target, while the examiner will neutralize the fundal globe. The readings, that is whatever we get from a dynamic retinoscopy, we will reduce it from the static retinoscopy, and we will get the total lag of accommodation. So more than one, that is more than +1 diopter, is known as lag of accommodation. That is the accommodative response is much less the stimulus. If the value comes in the minus, then it will be a lead of accommodation, that is the accommodative excess. Coming to the most important component and most ignored is the facility. The accommodative facility is the ability to rapidly change the power of crystalline lens for various distances, for focusing on various distances alternately from near to far. This facility is very important and has bearing on the symptoms where the child's complaint of difficulty in focusing on the board, because during the routine work in a school or in a classroom, each and every child has to do the same. They have to see from the board and then they have to copy it in a notebook. So they will require a good facility. Many a time we will see that the patient will come or a child will come and complain of he is not able to see or he is not able to read from the board. And when we see, the visual acuity will be 6/6. So we do not understand why the patient is doing like this. So basically, infacility, accommodative infacility is the most common cause of such complaints. So it can be measured using the lenses that stimulate the accommodation and that relaxes the accommodation. So basically, it is measured using a lens flipper. A flipper is nothing but a frame which has 2+ and 2- lenses. So the subject, that is a child, is asked to fixate on a target that is at 40 centimeter. The person should see the target clearly and a flip is done. So we have to flip and reflip, ensuring that the text is clear in each flip, and we have to measure the number of cycles completed in 1 minute. So one should always remember that whenever we start measuring the accommodative facility, we should always start with the minus lenses, because it will stimulate the accommodation. If we use the plus lenses initially, we can get a false reading for the minus lenses. So the normative data shows that for children, the normal facility is 6 CPM per minute, and for adult it is 12, that is 12 cycles per minute. Less than it is known as infacility. So the last component is relative accommodation. So relative accommodation measures the total range of accommodation, that is from maximum stimulus, that is maximum stimulation of accommodation, to maximum relaxation of accommodation. There are two types, that is positive relative accommodation and negative relative accommodation. In positive relative accommodation, we measure the maximum ability to stimulate the accommodation. That is, it is the excess of the accommodation which is occurring. And the NRA, that is the negative relative accommodation, we measure the maximum ability to relax the accommodation. So these are the normal values. So measuring the NRA and PRA is very easy. The patient is asked to focus on very small letter or asked to read the letters at 40 centimeters. Lenses are added in 0.25 increments until the patient first reports that the image is blur. The first blur, we have to take the readings. When we do it with positive lenses, then we are measuring NRA. And when we do it the same procedure with minus lenses, we are measuring the PRA. So similarly here, initially we will use, or we will measure PRA first always, and then we will measure NRA. So this was just about accommodative components. Now coming to convergence insufficiency, it is a very common disorder. So convergence insufficiency, okay, I'll skip this. So basically this is the most important thing. This is a questionnaire developed for convergence patient. The patient is given this questionnaire and then he has to fill it. These are the symptoms these are the symptoms experienced by the patient, and this is the magnitude by which the patient will be having. So the score for children, that is more than 16, is diagnostic of convergence insufficiency, and for adult it is more than 21. So these are the simple complaints, like whether eyes are feeling tired while reading, or whether it is uncomfortable, or you are having headache or sleepiness, as we have seen this earlier also. So there are basically 3 components in convergence to measure. First and most commonly used is NPC, that is near point of convergence, positive fusional vergence and negative fusional vergence. So initially we will see the NPC, that is the near point of convergence. It is measured with the help of RAF rule, accommodative target with a vertical line and a center dot in between. The patient is asked to see at it or to look at it, and the target is moved slowly towards the patient until the patient complains of a double line or double vertical line, that is diplopia. This point is noted. This is the subjective measurement. At the same time, the examiner can also see it objectively, because the eyes will start deviating. So basically we can get a subjective as well as objective measurement with the same. The same procedure is repeated 3 times to check whether it recedes with fatigue. Less than 6 is normal and more than 8 is diagnostic of convergence insufficiency. So how to measure fusional vergence? The patient is asked to fixate on a 6-9 symbol, one at distance and one at 6 meters. So fusional vergence, ideally we should check both for near as well as for distance. The prism bar or loose prism, most commonly used a prism bar, is kept in front of the eye, and the patient is asked to fixate on a target, either near or distance. We will slowly increase the power of the prism, and 3 points we have to ask to the patient. The first point when it becomes blur, the second is the point when it becomes double, and the third point when after becoming double we will reduce the power of the prism, that is the recovery point, when patient will tell that the diplopia does not exist or diplopia is recovered. So 3 points are important. First is a blur point, that is the initial point. Second is the break point, that is the point at which the double vision will occur. And third is the recovery point at which the double vision is recovered. So when we do this with base out prisms, we are basically measuring the positive fusional versions. And when we do the same method with the base in prisms, we are basically measuring the negative fusional versions. So these are the normal values for versions, positive, negative, and vertical vergences. So most important thing, mostly ignored, is whether there is any presence of forias or not. In convergence, for evaluation of convergence, it is very important to see whether any foria is present or not on alternate cover test. So check for forias always. It can be either isophoria or exophoria. Measure the isophoria or exophoria both for distance as well as near to test for the near distance disparity. According to the result, we can classify it. According to the result, we can classify the various convergence anomalies. We will see this further. So this was the brief evaluation of convergence and accommodation, and in short of fusion. So basically, whenever a patient comes with non-strabismic binocular vision, visual disturbances, first and foremost important thing is cycloplegic refraction. A patient should always get a complete cycloplegic refraction done. The patient should always wear full correction. And then even if after wearing the full correction, the patient is still complaining the same, then first we have to see whether forias are present or not. If forias are present, probably we are dealing with convergence anomalies. If forias are absent or there are no forias, probably we are dealing with accommodation anomalies. So further we will see how to classify them.
Madam, will you please hurry up?
Yes, sir. For convergence anomalies, if forias are present, it can be exophoria or esophoria. So basically, if the exophoria is more for distance, it is a convergence insufficiency. If the esophoria is more for distance, it is the divergence insufficiency. These are the most common we will find in the clinical scenario. And if there are no forias and just the reduced fusional vergences, it is known as disturbed or dysfunction fusional vergent disturbances. Coming to accommodation anomalies, as we have seen what all the components we are supposed to see in an accommodation evaluation, based on their results, we will classify into 3: accommodation insufficiency, accommodative excess, and accommodative infacilities. Accommodation insufficiency, mainly we will get the difficulty to clear -2 lenses. This will be diagnostic. NRA will be increased. There will be lag on accommodation on the retinoscopy. For accommodative excess, also known as pseudomyopia, there will be variable findings, variable NPA findings, and variable retinoscopy finding. There will be difficulty to clear +2 lenses, increased PRA values, and there will be lead on accommodation on retinoscopy. And when there is difficulty to clear both plus and minus lenses, then we will have the accommodative infacility. So these are the various treatment available. Vision therapy basically treats the person non-surgically. So lens flipper and heart chart are used for the accommodation anomalies, and Brock string and lifesaver card and many other convergence card are used for convergence. So as a vigilant clinician, it is imperative that we take the near vision complaint seriously and make a conscious effort to look for the anomalies and treat it accordingly. Thank you.
Thank you, Dr. Lokhande. It was a nice talk, and you had been working at Tirunelveli, I believe.
Yes, sir. Yes.
Yes, it's a nice place. I had been there for one of the Tamil Nadu state conferences. Thank you, and we welcome you to Vidarbha Board, and expect many more papers from your side in future.
Thank you so much, sir.
Next speaker is Dr. Gopal Arora. He is the past president of the Maharashtra State Ophthalmic Society. And Dr. Gopal Arora, I don't think needs any introduction to this crowd of Vidarbha Ophthalmic Society. I request Gopal to start something very interesting. He is going to talk social media. सोशल मीडिया के बारे में काफी कुछ पेपर्स में आ रहा है, टीवी पे आ रहा है. So let us hear from Dr. Gopal Arora. Social media marketing, do we really need it? Yes, Gopal, you are there?
Is my screen visible, sir?
Yes, sir.
Yeah. Thank you so much, Mukaddam, sir. At the outset, let me thank and compliment Dr. Nitin Upadhyay and Dr. Ajay Khandewala, sir, for putting up a good show in these difficult times, and the very innovative Chairman Scientific Committee, Dr. Viral, for the excellent show. Well, if a person is new to a place, the first preference would be not asking his colleague who is a good eye surgeon. The first preference would be going to the Google and typing this eye hospital near me, because he'll get two things. One is the rating of that hospital, and second is about n number of feedbacks, which is more authentic than asking one individual. Second, fourth, 9 out of 10 person has looked for the internet, looking for the healthcare information, and almost 3/4 have done it in the last month. This is another fact. Can you believe 238 crore people who are Facebook users, 321 million Twitter, and 190 crore YouTube users? This is unbelievable. Don't underestimate a 95-year-old lady whom you have counseled for a multifocal lens, calling you up the next day and asking, doctor, you have advised me multifocal. I've heard that somewhere in the Google that there is something called trifocal lens. You haven't mentioned about it. So don't be surprised. And 75% people searched the web after talking to their doctors. Having put forth all these facts, now I have come to the topic of whether we really need the social media marketing. What is social media marketing? I'm yet to come across an ophthalmologist who works for more than 12 or 14 hours a day, but the social media works for 24/7. Basically, it's your presence in the absence. Why social media? Branding. We have seen a lot of other stuff. Let me talk of the CFS and other VASAN and other things. There is the brand. I remember 20 years back, there was the Fevicol ka jod kabhi toote nahi. So that is a brand we still remember after 20 years. So that is what is called as a branding. Marketing. Marketing is important for simple reason. You know that you are a good phaco surgeon or a good ophthalmologist. What is needed is that everyone should know that you are a good ophthalmologist. There comes the role of marketing. It is not just patient education. It is the self-education, which is an important aspect again in this social media. And there are enlisted things which plays an important role in the marketing. Just to highlight, you don't even need to have the personal enhancement, but the professional satisfaction that you get out of these is very, very important and crucial. The Pew studies showed that 80% of the internet who are used for the internet search for the healthcare information. 35% of those who go online are trying to make a diagnosis of themselves. These we call as the online diagnosers. And only half of these online diagnosers go to the doctors. Do not feel shy, because if it's a very stupid question, when my child be potty trained, a mother might feel, that asking a pediatrician or a psychologist, she might sound very stupid. But then she just goes to the Google and type that question and she get the 10 expert opinions. So even without going to and asking to a pediatrician, she has an N number of good references and the answer to a question. What is basically social media? I just give an example. If I do a good phaco surgery to my patient goes home, he has got 10 family members or maybe 5 family members. Then he tells 5 family members that I have been operated very nicely. I was very happy with the surgery. These 5 family members have got 10 contacts. So they tell their 10 contacts that this doctor is good. So finally 50 people come to know that the surgery went well and this is a good doctor. Let's take another example of social media. Patient is happy, goes home, informs his 5 family members. 5 family members have got a contact or a WhatsApp group of minimum 10 WhatsApp groups, which has got 100 members in one WhatsApp group. So the entire multiplication goes to 50,000. So that is the power of the social media, because just one good thing can be made to 50,000 people. The other advantage is you can directly reply, you can answer to the queries and connect with peers. I'm not very good in oculoplasty. Someone asked me a question, my patient asked me some question about oculoplasty. I can just connect to my peers, just copy paste the answer and tell that patient, so that patient's problem is solved there and then. As I said, you can take 24/7 appointment online. That is the biggest advantage of social media. Being medical professionals, we have got a lot of limitations. We can't publicize the way we expect our hospital to go, but there are ways and means. If there is a festival of Holi, I can mention a lot of precautions which a child should take when playing Holi. I can give them tips and tricks of how one should avoid the eye injury. And in the end, I can write the name of my hospital. So there are ways and means of publicizing within the constraints of the medical profession. Now, do not forget, social media is not an assortment of tools inside, because there are n number of tools. It is the fact that how people communicate today. You accept it earlier, the better. But there are steps in branding and marketing. And this is very, very important. You need to spare time. You need to be really patient, and you have to be committed towards your goal. After you have made a platter, just open it to the public in large, that is the social media. So the platter is now ready for the public to access. Once people are interested, they are enthusiastic, they want to know what something new has come up, and their excitement goes to that level, that is the time that you put yourself in there. Before that, let the anxiety raise. And once people are interested in knowing about the platform that you have raised, that is the time you just need to put in there and be transparent, accountable, and be authentic. There is a rule in the social media. Either you lead or you be left behind, because there is no opt-out. The disadvantages. I remember one of my patients having put forth in my website that after waiting for 2 hours in my OPD, still Dr. Arora did not see me because one of his assistants saw. This is the advantage which can, disadvantage we can make an advantage. That was what the feedback I got, and I implemented and I regulated things for the betterment, and I called that patient that henceforth this will not happen, and that helped me in taking care of such patients who are actually wanted to show you, though there are time constraints related to you. You need to have goals in a social media. You need to use a specific and minimum words so that people are interested in reading and watching. And of these platforms available, you have to be very choosy and specific as to which one you would like to opt for. Facebook, this is one platform. The interesting part of Facebook is when people like your page, your post automatically goes to their page. YouTube, I remember that one Dr. Pankaj Lande from Amravati, every day in and day out, he has putting his videos in YouTube, and that has made him a national figure. Twitter, again, you can use hashtag to go viral. LinkedIn, it may not be that concerned with the medical profession, but you can meet people who are doing what you want to do. Website, most of us are accessing right now. Blogging is another way. But there are important steps in a social media. There are messaging, engagements, commitment, and the responsibility. Messaging, you have to be, yes,
Gopal, please hurry up.
Yeah, you have to be really brief, because patients do not have that time and energy to read all your messages. Second important thing is nobody reads your content. What is the use of writing 6 pages? And you should be committed, because there has to be some refreshed content. You can't write that I have been attended DOS, I have attended AIOS. You have to be a refreshed content. And you should take the responsibility of whatever you have uttered with the same intensity as you have written. There is risk and liability. I am very used to this profession. I just stick forward. Look at these stars. Dr. Michael Wachowski was labeled in 2015 as the sexiest doctor alive. Dr. Kevin Fo, a physician, Howard Lukes, an orthopedician, Wendy Sue, a pediatrician, and our own Uber. I remember going to Rahate Colony in auto rickshaw 15 years back, paying 200 rupees. Now I pay 150 rupees to an Uber with a chauffeur-driven vehicle. So these are the examples. but do not believe in everything you read on the internet just because there's a picture with a coordinate. So you have to play a caution. So friends, in the end, I would like to say, in future, whether you accept it or not, your self-prescription is going to be social media marketing. Thank you.
Thanks, Gopal. May I now invite Dr. Prashant Bawankude. लाइन से महाराष्ट्र ऑप्थेल्मिक सोसाइटी के प्रेसिडेंसी आ रहे हैं. So next, और गोपाल के पहले का प्रेसिडेंट is here. May I invite Dr. Prashant Bawankude to give his talk on management of block perforation.
Sir, Prashant Bawankude sir is having some network issues. He is attending a marriage or something. So I think Dr. Shilpi is there from Sarakshi.
Yes, sir.
So can you share
I'm sharing my screen.
Pre-recorded presentation he has sent? Please say.
Perforation is a well-recognized but uncommon complication, seen now more rarely in the era of topical anesthesia. A survey of Royal College of Surgeons has shown that 75% of the cases of block perforation happen at the hands of anesthetists.
Audio is poor. Can't hear properly.
Please increase the volume, Shilpi.
Sir, I have increased it to the full.
Residents as well as consultants.
Now it's okay?
Periverbal anesthesia is the most common cause of globe perforation, iatrogenic globe perforation, and it is the double injection technique which leads more commonly to block perforation. And the commonest site is superinasal quadrant. The other times when you can have globe perforations is enumerated here. Elongated eyeball and thin sclera in a case of a myopia, posterior staphyloma, and in post-scleral buckled eyes are the predisposing factors. Besides that, deep-set eyes and severe enophthalmos also can lead to more chances of globe perforation. Stages of perforation. When there is a single entry, that is penetration, the visual loss is basically because of sudden rise of IOP, leading to central retinal artery occlusion and cloudy cornea, and because of the toxicity of injected material. If there is double penetration, that is perforation, visual loss is basically because of vitreous hemorrhage, subretinal heme, and detachment. The characteristic of a break is that it is predominantly located in inferotemporal quadrant and superinasal quadrant, and the classic shape is oval shaped. Usually they are 2 in number, and they are usually placed in opposite meridian. Rarely you can have multiple sieving machine like breaks. These are the classic break related fundus findings. That is a linear scar. This is an injected intravitreal depomedron, and this is an ovoid scar in the inferotemporal quadrant. Patients usually have sudden pain at the time of injection with either a hypotony or raised IOP depending upon whether the injection or the drug has been injected intravitreally with sudden loss of vision. When it is missed on first at the time of injection, it is usually noted on first postoperative day when the patient complains of diminished vision along with hypotony, hyphema, vitreous hemorrhage, and retinal detachment. The signs of perforation noted during vitreous surgery for block perforation are puckered scleral scar, the choroidal scar caused by needle drag, and the classic retinal break either in the form of oval breaks or multiple sieving machine breaks. Management. If the media is clear and there is no intraocular drug, laser can be done as shown in this particular diagram. If the break is associated with localized artery with no intraocular drug and clear media, pneumoretinopexy can be a procedure of choice. But whenever the drug is injected intravitreally or if it is associated with vitreous hemorrhage, retinal detachment, in such cases, vitrectomy is the way to treat. Early vitrectomy definitely leads to better prognosis, basically because it removes the toxic intraocular contents, prevents severe PVR, because PVR in this case develops as early as 2 weeks, and it also removes the scaffold for ingrowth from the needle tract. Prognosis depends on how early you intervene. Early diagnosis and management means better prognosis. This is the first case which was referred to us following a doubt of having a globe perforation when it was posted for cataract surgery elsewhere. Here we are doing a cataract surgery, and you can note over here that a cataract surgery is done in the absence of globe because there is a dense vitreous hemorrhage in the posterior pole. It's so difficult in the absence of a globe because of the vitreous hemorrhage and the Phaco done, intraocular lens implantation done, and here the vitreous hemorrhage is being cleared. The retina was iron, and there was a large choroidal tear which you can see hazily through that hemorrhage with the attached retina. So just vitrectomy with endolaser around the site was done in this case. This is a case which was referred to as a bit late, and here the patient had a retinal detachment, as you can see over here. In this particular case, vitreous hemorrhage is being cleared, and you can see a linear scar over the macula, another tear in the superior inferotemporal quadrant, and another tear over there. This is classic perforation, where you can see a choroidal tract, means the needle has grown from here, and in the macula there is a linear scar. Exactly, the needle has hit at this particular point. So the tamponade was done, followed by laser. This is another case where patient presented to us with retinal detachment with vitreous hemorrhage, and you can see it had also associated PVR in this case, and it also had simultaneous macular hole in this particular case. It had severe PVR, so we have done vitrectomy. Following vitrectomy, membrane peelings being done. You can see a site of perforation over here. Yes, and the PVR being peeled off. You can see a macular hole. Whether it was a reason because of a perforation, we are not sure, but it does not look classic like a because of a hole. It is concomitant morbidity, island being peeled, and the routine technique of laser, and followed by tamponade. This is a case of a pathological myopia who had undergone retinal detachment surgery in the form of buccal some years back. He was posted for cataract surgery, and this is first post-operative day when the patient was referred to us. You can see first you have to secure the Phaco wound to facilitate the posterior part of the surgery, and after securing the wound, here vitreous hemorrhage is being cleared, and after the vitreous hemorrhage is being cleared, you can see this is a high myopic lobe. You can well see the buccals in the periphery, and there is a large linear tear just supernasal to the disc, which was identified, and we had to do subclinical artery laser being done and followed by a tamponade. So to conclude, even the experienced surgeons can have globe perforation. The incidence of is more so common at the hands of anesthetist, but if you compare the incidence at the hands of residents versus consultants, it is almost equivalent. Peribulbar anesthesia is the most common cause of iatrogenic globe perforation, where you see the break predominantly in supernasal quadrant followed by inferotemporal quadrant, and more commonly in a double injection technique. Early diagnosis and management definitely means better prognosis. Lasers and pneumoretinopexy, when media is clear, there is minimal fluid, and there is no intraocular drug injection. While if there is an intraocular drug injection, plus if it has vitreous hemorrhage or a retinal detachment, in these cases, vitrectomy with endolaser with a tamponade is the procedure of choice. Thank you.
Thank you, Dr. Bhavangure, Dr. Shilpi. Unfortunately, the audio was throughout very poor. We could finally listen to something, but all the same, it was with the difficulty we could understand. Right. The next speaker is again, as I said, another president of Maharashtra Ophthalmic Society, Dr. Sunaina Malik, and may I request Dr. Malpani Dr. Malpani, or you'd like to introduce Dr. Malik?
In my
Anyway, it doesn't matter. Dr. Sunana Malik is a product of the Government Medical College, Nagpur. After her post-graduation, she was working at Aurangabad, and she is as I said, she was the president of Maharashtra Ophthalmic Society. Way back in 1998, I think she was secretary of the Maharashtra Ophthalmic Society, and she really took a long time to rise to the level of president of Maharashtra Ophthalmic Society. Initially, I had said about the All India Ophthalmic Conference, which we had at Nagpur. And I remember Sunaina and myself, we had acted in a one-act play, which was presented during that conference. So it was an interesting thing I wanted to share with you. So please, Dr. Sunaina Malik, you may please go ahead.
Thank you so much, sir. Good afternoon, or it is almost evening, I should say. I thank the Vidarbha Ophthalmic Society for having me as faculty for this particular topic, because it's very close. And I'll never forget that play, sir. It was one of the worst plays I must have acted in. I can never ever forget it in my life. And because it was written by Dr. Madan Gopal, I had no say in it, but I had to act in it. So you can say it was a forced acting on my part. So this is the MOS-PGIO logo which we have designed. And what is MOS-PGIO? Actually, it's a professional group indemnity insurance scheme for MOS members. This idea was sown in my head by Foxy, who have an almost similar scheme. And the thought of something similar for MOS originated from Aurangabad, because Aurangabad members urged me, ma'am, do something. This was during my presidential tenure, almost towards the end of my presidential tenure. So it took hold in my mind, and that's why I call it my brainchild. And I had always felt the need for some protection of this kind for MOS members. And with the help of Dr. A. Deshpande, it became a reality. Now, what is it? It is a scheme to protect MOS members to save their money also, especially those members who are in solo practice like I am. We need coverage very badly, because we can be taken to the consumer court by any dissatisfied patient. And nowadays, all of you know how finicky patients are. We can be sued for a huge amount. And because this indemnity is being taken as a group, it is always beneficial, as we'll show in charts later, because united we stand, but divided we fall. According to the new CPA Act, which has come into force since July 2020, the patient can sue the doctor for a sum of even up to 1 crore or more. Moreover, now the case can be filed anywhere in the country. Means it need not be in the city where you are practicing. So you will have to run helter-skelter to attend hearings, and you can imagine what a huge toll this will take of the practitioner, both mentally as well as financially. Now this becomes a chakravyuh. Because your mental health is poor, so managing money becomes harder, and then you're worrying about money makes your mental health worse. So it goes on like this, like a vicious cycle. What are the benefits of this indemnity insurance? And I can assure you that if I was not convinced about this, I would not be recommending it, because I don't ever do anything I don't believe in. The insurance company will pay the compensation amount ordered by the court up to the limit that you have taken. The company will provide and pay for the advocate in the court. If you do not want the insurance company advocate, then a fixed amount will be paid by the company as advocate fees to the advocate, depending on where the case is. Means whether it is in the district or the state or the national commission. The same thing will be done if the case is appealed in a higher court. And this coverage will be for 1 year. You have to renew the policy every year. It starts from the day your premium amount is deposited with the company, which means like we have already started this scheme. We are actually now nearing 200 members when it will go into effect. So I have paid in November. So for me, the scheme will start from the day I deposited the amount into the account of the company. What is an additional benefit is that there is support from the company even in a criminal case. Of course, they won't go to jail for your sake, but they will support you. And indemnity insurance with 1:1 ratio up to 5 crores at a very competitive rate is being given. You have to enter the scheme before 31st December to get the benefit of it next year onwards. You can do 25 lakhs this year, which has a very minimum premium of 1623. If you're doing it only for yourself, increase it up to 5 crore next year at your existing policy renewal date. You can discontinue your existing policy when you shift your main policy to this scheme with the retroactive date carry forward with same or more coverage. This is very important for all of you to know. And there's a 10% addition for each skilled or unskilled unnamed staff to cover vicarious liability, and a 25% addition for refractive surgery. The premium is with 18% GST added. So now I'll show you that there are a few disadvantages to this. In case of a previous incident for which the case is lodged, even after the date of deposition of premium, it will not be taken care of by this company. And you cannot take the lawyer of your own choice. For example, you want to take Ram Jethmalani only, but the company will only provide you a certain amount of as lawyer fees if you're taking a lawyer of your own choice. You cannot go for a prime lens for the price of a lesser one. What is the difference between individual and group indemnity insurance? All the facilities given in individual and group insurance are the same. In individual insurance, the premium may be double or even more. And individual insurance is done by individual directly, but in group insurance, it is done through a group of similar professional persons under a banner like MOS. This is the premium chart showing what is the premium for an individual for this much sum assured. Like for 25 lakhs, I said it is 1623. I think now I have it by heart. And as you can see, the amount goes up, but even for 1 crore, the premium is just 6,490. My next chart is going to show you with 10% and 25% added. This chart shows you with 10% loading, with 25% loading, and what is the total payable amount. So if you are taking only 10% loading, then your amount goes to 1785 from 1623. If you are adding 25% for refractive surgery, it goes to 2195, which I think is extremely reasonable. No other company is going to give you such competitive rates, believe me. So because we wanted to bring this into effect, we formed a committee for MOS PGIO, as we call it in short. The MOS office bearers of this will change every year, which means the president, the secretary, and the treasurer will change every year. But we needed a company which will stay, a committee to handle this smoothly. So we formed a committee which comprises of Chairman Dr. A. Deshpande, co-chairperson myself, and Secretary Dr. Vardhaman Kankriya. We will also remain for a period of 1 year, but we may continue again with the permission of the GBM of MOS. The President, Secretary, and Treasurer of MOS will change every year as the office bearers change. What is the procedure of taking indemnity insurance? Now we have changed this a little bit. You need not be a MOS member when you join, but you need to become one even after joining. You fill a one-page form, sign it. If done online, digital signature will do. If offline, take a printout of that form, fill the form, sign it, take a photo of that form and send it to this email ID, or you can send it to any one of the three of us. Plus proof of transferring the premium amount directly in the account of the insurance company. The company name, account number, IFS code is given in the next slide. You will get the policy directly by courier from the company. These are the company details which can be had from me, any one of you who's interested, and I hope you are interested because this talk has been put in by Viral specifically to initiate more people from Vidarbha to join, and I'm thankful to him for that. So there can be a few doubts in your mind. The first doubt is, if you have a previous indemnity policy, then what? In that case, your policy will act as an additional security when the limit of the group policy is over. So we are not asking you to stop your previous policy. Let it continue. Next year, you can decide what you want to do. The individual policy, when expires, you need not renew it. Then you can shift totally to this group policy because that will protect you. If you want, your group policy can start working from the date of expiry of your individual policy. Doubt 2. If you are in solo practice, then it is wiser to take a larger individual policy, example of 1 crore, which is what you should be doing because you get more coverage. What are the steps to be taken once you have taken the policy and you get a notice from the court? Immediately inform the committee of MOS PGIO and the company. Forward the notice to them. They'll take care of the rest of the things. Thanks. Thank you so much, all of you. And here's to a corona-free world.
Thank you, Dr. Sunana. It was a nice information regarding this sort of scheme. Most of us have indemnity insurance, but together I think the charges are really fascinatingly less. I'm sure Dr. Viral Shah wants to present you with this certificate for your participation. Yes, Viral?
Thank you so much, sir. I'm very happy to be part of VOS, really.
You are basically a VOS member.
I am a Vidarbhian only, basically, by birth.
How can you forget you were Sunana Ahuja?
Yes.
Later on you become Malik.
I can never forget that, sir. I can never ever forget that.
Thank you.
Thank you so much.
Next speaker.
Viral, let it be. I'll take it as given. I accept it as given. Thank you.
Next speaker is Dr. Ashish Thul. He's going to talk on new kids on the block, rock inhibitors. He's going to rock with his talk. Ashish, please.
Thank you, sir. At the outset, I would like to, am I audible?
Yes, quite.
So at the outset, I would like to thank the VOS Scientific Committee for this opportunity and heartiest congratulations to Team VOS, Dr. Nitin, Dr. Ajay, our Chairman Scientific Committee, Dr. Viral, and all friends from Akola Academy of Ophthalmology for putting up such a wonderful show. So ROC kinase or ROC inhibitors, as they are commonly known, have, as sir said, created quite a buzz in recent years. And we'll be talking about their indications in various conditions in ophthalmology, the mechanism of action of these molecules, what are the options available with us today in our clinical practice, the data from various clinical studies telling us about its efficacy and even the adverse effect profile. And finally, we'll look at how and when we can use this in our day-to-day clinical practice. So ROC inhibitors have shown to be effective in eyes with glaucoma, corneal endothelial disease, and diabetic retinopathy with macular edema in various lab as well as clinical studies. So in cases of corneal endothelial disease, these are supposed to act via increasing the proliferation of corneal endothelial cells and also decreasing the rate of already damaged corneal endothelial cells and preventing the apoptosis. So the proposed methods of delivery are either using topical drops or using these in conjunction with cultured endothelial cells and using it as an intracameral injection into the anterior chamber. Case series, this ROC inhibitor, particular ROC inhibitor eye drop was found to be successful in preserving corneal clarity and visual acuity in eyes with Fuchs endothelial corneal disease. A small case series of patients from Japan who had undergone cataract surgery and suffered endothelial damage on using Ripasudil eye drops were found to have recovered corneal transparency and also an increase in endothelial cell density. Ripasudil molecule as eye drop has also been used after Descemet stripping only procedures and helped in quicker visual recovery. In cases of diabetic retinopathy, ROC inhibitors prevent creation of anchor sites for leukocytes to microvascular endothelium, thereby preventing leukocyte-induced retinal vessel endothelial damage. They also kind of reverse the endothelium nitric oxide synthetase inactivation and again slow down the microvascular endothelial damage in the retinal vessels. These mechanisms have been proven in studies on diabetic rat models. The proposed methods, because we have to act on the posterior segment, are intravitreal injections and also intravitreal implantation for sustained release. Any role of eye drops which are available with us? Well, there is a small retrospective control study which showed that topical ripasudil drops led to decrease in the foveal thickness, but there was no improvement in the visual acuity in these patients. They have well established themselves as IOP lowering effects agents in various clinical trials in recent years. Some studies in lab have also shown its effect as anti-scarring agents. The ripasudil and netarsudil, the molecules which are available commercially with us today, both act by either increasing aqueous outflow at the level of trabecular meshwork, or in case of netarsudil, an additional mechanism as well. So basically, both these work by inhibiting the Rho kinase pathway, which will lead to a change in the cell shape and actin cytoskeleton structure, which will lead to preventing the contraction of the trabecular meshwork beams, and this will allow greater outflow to the meshwork. In addition to this, with netarsudil, which is also a norepinephrine transport inhibitor, it will again lower aqueous production and episcleral venous pressure as well. So the ripasudil molecule was already approved in Japan in 2014 by the brand name Glanatec, 0.4% concentration. The preservative is BKC, and the dosage recommended is twice a day. Same is available to us from Ajanta Pharma by the brand name Ripatec, same concentration. This is available to us since last 1 year now. Its IOP lowering efficacy is modest in the studies which have been done, around 4.5 millimeters of mercury, and it is consistent over a year. The most common adverse effect which is seen is conjunctival hyperemia. As you can see, more than 65% of the patients had conjunctival hyperemia. This is basically due to the vasodilatory effect of the drug. It also has good additive effect with timolol as well as with latanoprost. And in a study in patients who had already been using maximally tolerated medical therapy, ripasudil on addition to this treatment showed further 15 to 16% reduction from baseline. So any use in secondary glaucoma, this is a large multi-center retrospective trial which was done in Japan, which showed that in patients with uveitic glaucoma, exfoliation glaucoma, and even steroid-induced glaucoma, the ripasudil molecule was able to bring down the IOP by almost 7 millimeters of mercury at the end of 6 months. And an interesting finding in uveitic glaucoma, it also led to significant decrease in AC cell score, telling us about its anti-inflammatory property. The second molecule, netarsudil, got US FDA approval in 2017. This comes by the brand name Ropresa. The concentration 0.02%. Again, the preservative is BKC. As against ripasudil, here only once daily dosing is good enough. Launched in India by Ajanta Pharma not even a month back now by the brand name Netalo, and with similar properties to Ropresa. These are the trials, phase 3 clinical trials on the basis of which the drug got FDA approval, basically investigated safety and effectiveness of netarsudil in comparison to timolol. It showed that at baseline IOP of 25, less than 25, and even at less than 30 millimeter of mercury, once daily netarsudil was found to be non-inferior to twice daily timolol, and it reduced the intraocular pressure to just less than 5 millimeters of mercury from baseline. Adverse effect profile is quite satisfactory, and the most common adverse effect, as was seen with ripasudil, is conjunctival hyperemia. More than 20% patients in these studies showed corneal verticillata. This is something like a whole keratopathy that we see with patients who are on amiodarone therapy, or even with topical tobarine. You can see this. These are not visually significant. This interesting ocular adverse effect not noted in FDA trial was reticular bullous epithelial edema in corneas treated with netarsudil. Most of these patients already had a history or risk factor for development of corneal edema, but this does tend to reverse after stopping the drug. One more fixed drug combination of netarsudil with latanoprost has got US FDA approval just last year. We are eagerly waiting for its availability to us in India. This, because both the molecules are working with different mechanism, has a significant IOP reduction efficacy, and more than 58% were able to bring down the intraocular pressure to less than 16 millimeter, and over 30% of the patients, the intraocular pressure IOP reduction was almost 40%. So again, good systemic side effect profile and ocular adverse effects, same as what we would have with the individual molecules. In clinical practice, where would we want to use it on the basis available? In corneal endothelial disease, we would want to use ripasudil in maybe patients with Fuchs corneal endothelial disease in early cases, and even patients who are having early pseudophakic bullous keratopathy. As far as diabetic retinopathy and macular edema goes, with the presently available Rho kinase inhibitor drops, there is no data to support its role in the treatment of diabetic macular edema. As far as glaucoma goes, established as an adjunctive treatment in any type of glaucoma wherein the angle is open and there is resistance at the level of trabecular meshwork, whether it is primary open angle glaucoma, ocular hypertension, or these secondary glaucomas. Uveitis glaucoma, we know that it does work. Now the thing is, in angle closure disease or in angle recession glaucoma, if the synovial closure is not too much, then maybe have a limited value. And cases with neovascular glaucoma, because the angle has already been secondarily closed due to synovial closure, this might not have real use at all. Its role as an anti-scarring agent, as I said, it does have potential. So whenever we have postoperative early bleb failure, maybe this can help in lowering IOP as well as preventing the fibroblastic proliferation, but we need further evidence on clinical studies. To sum up, ROCK inhibitors, both ripasudil and netarsudil that are available to us, are a welcome addition to our therapeutic armamentarium, may be useful in corneal endothelial disease, has a definite role in glaucoma therapy, although it causes modest IOP lowering, but it has a reasonable safety profile. And as far as its use post-filtering surgery, we need to keep our fingers crossed and see whether it helps up or not. Thank you so much for a patient hearing.
Excellent talk, Dr. Thul. Very interesting. Ek vicharu ka, what is the cost of this drug? I mean,
yes, sir. Ripasudil, which is available, it comes in BD dosing, a 5 ml formulation, and it comes to around 250 or so. And netarsudil, which has been launched last year, just last month, not even 30 days now, it comes to around 450 or so, and it's once daily dosing and comes in 2.5 ml.
Thank you. Thank you. Yes, Viral, you want to offer him the memento? Or
yeah, for VOS members,
for VOS members, no memento, sir. We are a family.
Right. Thank you. Last speaker, the last talk is by Dr. Anupam Bagdi, and he is going to talk on acute chemical injury management.
Thank you, sir, and a very good evening to all of you. Since I am the only one keeping you away from enjoying your Sunday evening, I'll try to be very crisp. I'll be talking on acute chemical injury management, and I don't have any financial disclosures to make. So why are we discussing this topic? Why it is very important to deal with acute chemical injury in a very, very proper fashion? It is because there are dreaded sequelae to this condition, which may limit the vision to a great extent for any patient. And if managed properly, probably a lot of these cases a lot of these sequelae can be avoided. So only 7 crucial steps are needed to be kept in mind while dealing with such patients. Step 1 is ask. This is in relation to taking a detailed and proper history. For example, this 40-year-old patient comes with both eyes chemical injury. What questions will you ask him? So first of all, apart from his chief complaints and the details about chief complaints, it is very important to ask him about what is the inciting agent that has caused this type of injury. The common inciting agents in this part of the world are lime, that is tuna, insecticides and pesticides due to farming being a very common occupation, then firecrackers, and also some acid-based cleaners. It is important to know about them because each of them has a different prognostication for the patient's condition. Of course, apart from this, we should also ask if any irrigation has been done for the patient's condition, anyone else has washed the eye, and for how long, with what. So after a detailed history, it's time for examining the patient. It is very difficult in some situations where the patient is very uncooperative because of his symptoms. So it is important to instill a drop of proparacaine hydrochloride before starting to examine him so that he becomes comfortable. After that, what all aspects of the examination needs to be seen? Apart from visual acuity, lids and agnetza are an important part to be seen closely, because in cases with firecrackers or acid injuries, this portion also might be significantly damaged. And the most important part in examination is the extent of epithelial loss and ischemia. So in this photograph, what you can see is all around the limbus, there is significant whitening and blanching of the vessels. That is ischemia. And we need to identify the areas which are completely ischemic because they need to be removed at any cost. Also, fluorescein staining is the mainstay where you will actually come to know about how much epithelium has been denuded because of the injury. And fluorescein, if you instill fluorescein just as much as we instill for Appalachian tonometry, then that may not be sufficient in large ulcers. In large areas of epithelial defect, you may need to paint the surface with fluorescein so that sufficient fluorescein is instilled in the eye so as to mark the complete denuded area. And also we need to make a clear distinction about how much of limbus is affected, because the stem cells covering stem cells which lead to formation of corneal epithelium are located at the limbus. This is the prime factor which decides on how the patient will do in future. So when you examine such a patient, in cases of large ulcers, it is always better to examine by a nude eye in a dark room with a indirect ophthalmoscope's blue filter. Because of the large areas of denudation, sometimes it's not very easy to be seen on slit lamp. And with the blue filter, each and every border of the epithelial defect is noted very clearly. And this has to be documented because at each follow-up, we have to see the improvement in the epithelial coverage. Also, the other aspects that need to be seen are the fornices, because a lot of chemical may be hiding there and you may not be able to make out with a routine examination. So double evert, and in this patient where you can see that after double eversion, a lot of retained chemical is noted there. So every part of retained chemical has to be removed at any cost. That is the first step of management. Anatomical integrity should be assessed because in some cases there will be collagenolysis leading to perforation in the cornea or sclera, or sometimes because of cracker injury or a blast injury, there may be pre-existing perforation which needs to be taken care of. And of course, since these patients will need a lot of steroids in their management, we have to make sure that pre-existing infection does not exist. So after all the assessment, you will actually come to know what is the relative toxicity of the substance that the patient has had injury with, what is the area of involvement, and what is the depth of penetration of that chemical. This all will lead you to prognostication of the case and how the patient will do in future. You can, on the basis of your findings, you can classify the injury into different grades. The initial classification, which was the Hughes classification, it was further modified by Roper Hall. And now a newer classification by Dr. Harminder Dua has been recommended, which takes into consideration the number of clock hours of limbus involvement and the percentage of conjunctival involvement into consideration. And it is considered to be a better prognosticating indicator compared to the Roper Hall classification. To sum up the classification, it is divided into 6 grades, where grade 1, 2, and 3 are considering the limbus involvement less than 50%, and grade 4, 5, and 6 have limbus involvement more than 50%, and similar percentages of conjunctival involvement. We will see in the further slides how the treatment strategy is different for different grades. The third crucial step in managing acute chemical injury is irrigation of the existing chemical. Basically, 3 questions arise. Is when to irrigate. So it is as soon as possible. Whenever you get a chance, as soon as possible, even if you are consulting the patient on phone, ask him to just use clean tap water to clean his eyes, and any liquid that is available with you, any clean, sterile, non-toxic to the surface. RL is okay, NS is okay, BSS is okay, anything can be used for irrigation of the ocular surface. For how long? So usually 1 to 2 liters of this solution should be used over 1 to 2 hours, which shortens the overall treatment and gives better outcomes to the patient. Use of litmus paper is also recommended for a pH check because after irrigation, whatever the inciting agent may be acidic or alkaline, it should come back to neutral pH in the irrigation solution. So you should continue irrigation till the litmus paper shows 7 pH. And eyelid speculum can be applied, which allows a better maneuvering of the irrigation. Some newer devices for irrigation have also been marketed, which allow for easy maneuvering of the irrigated solution. Now coming to the aim of treatment. After assessing the complete situation, we should be very clear in our mind what is the aim of our treatment. So it is just described in 3 words: save the eye. Because these cases are very difficult to manage when the complications start arising and when the sequelae start developing. So saving the eye by means of promoting reepithelialization, whether corneal or conjunctival. Please mark these important words, whether corneal or conjunctival, because we have to promote epithelialization at any cost. Even if the corneal stem cells are completely damaged and the conjunctival epithelium grows over the cornea, it is still okay in cases of severe injuries. That is a successful outcome of the initial management. So we have to make sure some type of epithelium definitely covers the surface and protects it. Because if the epithelium is denuded for a long time, it can lead to collagenolisis and melting. So we also have to prevent melting and collagenolisis because of the deepithelized stroma. Step 5 is to start the right medications. When we discuss about the medical therapy in cases with chemical injury, the first and foremost and the most important molecule that is corticosteroids topically. Topical corticosteroids in cases of chemical injury are one of the exceptions where you would want to give a high dose of topical steroids even after seeing a large epithelial defect. So we have to keep in mind that we have to start steroids in these cases as early as possible and as prolonged as possible. Some other medications which can support repair and minimize the ulceration are vitamin C, tetracyclines and citrates, and also some others which promote reepithelialization are tear substitutes, bandage contact soft lenses, and autologous serum. The mechanism of action of steroids is by reducing inflammation and by reducing the proteolytic enzymes released by these inflammatory mediators. This leads to easier healing of the epithelial defect over a stronger stroma. But we have to bear a caution in mind that if a steroid is used as an alone agent for a long time in cases of a epithelial defect which is not healing or which is a persistent epithelial defect, then it can lead to accelerated collagenolisis and ulceration. So we have to follow up the patient very carefully, and if a defect is not healing, we have to add adjunctive therapies like amniotic membrane, tarsorrhaphy, etc. For example, this patient had come with both eyes Lyme injury after copious irrigation and starting topical steroids. He responded very well in just 1 week's time. So steroids definitely reduce the amount of scarring also and accelerate the process of epithelial healing also. Some studies have shown the role of vitamin C in accelerating in preventing collagenolisis, mainly in the earlier phases. And also role of tetracyclines in inhibiting the matrix metalloproteinase enzymes is well known, and this leads to a stronger collagen and it inhibits the collagenolisis activity. Bandage contact lenses are also used to promote epithelial migration, and it also promotes basement membrane regeneration. Autologous serum has been shown to be effective in a lot of studies because it contains a lot of growth factors for the epithelium and the collagen. Coming to the 6th step, that is need for surgical management. So here first we need to make sure we select the right patient for surgical management. The classification of the injury that we saw some time back, I'll just discuss once again on it. So when we see something like grade 1, grade 2 or grade 3 injury, wherein the damage is limited to 50% of the limbal clock hours or 50% of the conjunctival surface, we can start medically managing the patient, and probably these will not require surgical management. in future. However, if the injury is more than this and it falls in grade 4, 5 or 6, there is a definite indication of surgical management, and a very important role is played by amniotic membrane in such cases, which helps to cover and protect the epithelial defect till the epithelium grows back. So when we talk about surgical management in the acute setting, we have to know that we have to debride all the necrotic areas which have completely lost their blood supply. So we have to keep excising all the tissue till we see bleeding blood vessels, and all the necrotic tissue has to be removed, because it will not allow normal healing of the rest of the areas of the surface. We also, after excising the necrotic tissue, when the bare area is seen, we have to find a suitable bed to cover this denuded corneal surface, corneal or scleral surface. So we have to either proximate a layer of conjunctiva surrounding which is healthy, or just the tenons surrounding which has healthy blood vessels. So immediate establishment of limbal vascularity is very important, and it helps to prevent anterior segment necrosis.
Please wind up, Dr. Bagdi.
Sure. Amniotic membrane transplant, we know that it is anti-inflammatory, anti-fibrotic, and anti-neovascular. So it helps in quick healing of the epithelial defect. I'll just skip the video in the interest of the time. Tenonplasty is when the healthy tenons is used to cover the raw areas which have been created due to excision of necrotic tissue. Those will be, so tenons, though it is a poorer substrate bed than conjunctiva, it is also very helpful. And in some cases, adjunctive tarsorrhaphy along with amniotic membrane or tenonplasty is a good option to keep the surface healthier compared to open eyes. Last but not the least, let me tell you, counseling plays a very, very important role in such cases, because there is a reason to it. Initially, with a large epithelial defect also, the patient may come to you with just a 612 or 618 vision. But when the epithelium heals with a conjunctivalization, probably the patient is going to lose that vision also, and the vision may become still worse. So you have to make sure you explain the patient very well what the natural history of this, the course of the disease will be, and what needs to be expected in the coming months. So thank you. And I would request any questions if you have.
Any questions? Well, Malpani.
Yes, may I request Dr. Nitin Upadhyay, President VOS, and Dr. Rajesh Murarka to please present a memento to Dr. Anupam Bagdi. Dr. Anupam Bagdi has completed his fellowship in cornea from LVPI, and he's a versatile singer, sir.
Very good. Is he practicing at Akola?
Yes, sir. He's practicing as a corneal consultant.
At Akola.
Akola.
So, on behalf of my team, Dr. Malpani, Dr. Sonakia, Dr. Banait, and Dr. Naveen Soni, I thank the organizers for giving us this opportunity. There is there time for the panel. Yes, Viral Shah, you have kept a panel discussion, and there are panelists waiting. I see Anand Junjunwala, and
if they have any questions, sir, please go ahead, sir. If they want to put in some comments, the panelists, they are most welcome, sir. Dr. Varsha Pandey, madam, Dr. Sunil Agrawal, Dr. Afat Khan, sir, Dr. Anand Junjunwala, Dr. Durgesh, and Dr. Shivani.
Well, since there are no questions, I think we should wind up.
Yes, sir. Thank you.
Hello, sir.
Yeah, please.
Hello. Nice talk by all the presenters. I would just like to comment about orthoptics, and that is a very important topic which is actually neglected, and that has been taken. And practical tips one should know as a general practitioners, just to calculate how to see the convergence insufficiency, and that is a simple test, and taking the pen towards your tip of nose, and when it becomes double, that is the near point of convergence. And when it becomes blurred, That is the near point of accommodation. So you don't need many sophisticated instruments or even RAF rule in general practice of ophthalmology, and you can just by simple these two tests find out the near point of accommodation and near point of convergence, and you can guide the appropriate exercises, because asthenopia is a very common complaint nowadays with lot of computer work and near activities. So I think if we are aware of these things, we can do proper refraction and give symptom free near activities to the patients, and we can just guide them regarding accommodation and convergence by giving proper refraction.
Thank you so much, madam.
The other talks were very excellent, and I would like to thank Dr. Saurabh also for giving that insight regarding the pharmacy shop, because up till now we were just thinking about the optical shops. So this is a new idea, and I think that is really will be just everybody should think about it. Thanks. And Dr. Bagdi's talk was also with good practical tips. I really appreciate Dr. Viral's way of choosing the topics for this session. Thank you. Thanks.
Thank you so much, madam. Thank you for your comments. Dr. Anand Junjunwala is there? Dr. Anand?
He was there.
Okay. So I think, on behalf of the Ophthalmic Society Scientific Committee, I would like to thank the chairpersons, Dr. Mukaddam sir, Dr. Malpani sir, moderator Dr. Sonakia madam, convener Dr. Shashan Banai sir, and coordinator for this session Dr. Naveen Soni, and all the panelists who took part for conducting of flawless and smooth session. All the talks were excellent. I am grateful to all the national faculty as well as our own VOS stalwarts who presented such nice talks and made this session very interesting. Lots of nice comments are pouring in on the webinar panel. I would share it with I would have to segregate them and send it to individual faculty, and they can reply to that. Thank you. Thank you so much. Over to the organizing committee, Akola Academy of Ophthalmology, and organizing committee of VOS-VRCON 2020.
Thanks. Thank you.
Yes, sir. Upadhyay, sir.
Hello. So it was the first experience. Can you hear me?
Yes, sir.
It was the first experience after the post-COVID, a virtual and a physical combination. So it was a new learning for everybody. I first of all want to congratulate Dr. Viral Shah and his team for the excellent scientific feast. डॉक्टर विरल ने मुझे पूछा था सर कैसा करना है. Viral, I will not interfere. You are the scientific chairman. You have to go with it. I want the excellent program. And उन्होंने जो किया है वो मेरा सेटिस्फेक्शन उन्होंने फुलफिल किया है.